So very warm welcome to all. We are starting with the Saraswati Vandana. Yeah. Thank you very much. To begin with the blessings of God, I welcome you all to this International Congress on Diabetes, New Dimensions in Diabetes, NDID 2022. And we are doing this international conference since many years, and this is the 4th year of international conference. And I thanks to all my stalwarts who join us every year. And to start with, we are having our none other than our friend Parthakar, and he has given his time, and thanks a lot Partha for joining. Without wasting much time, I would hand over to the Kanan, Master of Ceremony of Hall A, and Ishita, who is the Master of Ceremony of Hall B. So over to you, Kanan.
Yeah. Good afternoon, friends. It's a great pleasure and honor to be associated with the whole NDID team and organizing team. And also, I would like to my heartfelt thanks to Ashish for giving us a great opportunity. So we have 2 days program, day 1 and day 2. It's a galaxy of topics, a galaxy of speakers. Without much wasting of time, on behalf of Almighty, we go to the first topic: how the world of diabetes has changed and what's the new and future. For this, we are eminent chairpersons. It's a great pleasure and pride to invite the chairpersons, Dr. Rajesh Kesari and Dr. Abudaya Verma. Over to chairpersons.
Thank you so much. And first of all, heartiest congratulations to Dr. Ashish Regra. He's been organizing this conference since many years, and we are very lucky today to be a part of this conference because we've had many eminent speakers over the years who've been enlightening us and bringing more and more knowledge and enriching us about diabetes. And today we have a wonderful speaker, a great specialist, a great human being, Dr. Parthakar. He is doing a lot for the betterment of diabetes patients, and especially the type 1 diabetes that he is taking care of personally in many aspects of treatment of disease, not just the science of disease. So I think this is one of the greatest qualities of a doctor, to be associated with patients, with their lives. Treatment of diabetes is not only about administering drugs or insulin. It is also about looking about the social aspects of the disease, about the psychological aspects of disease. And everything is changing in this world. Our lives are changing. Technology is changing, advancing at a very significant pace. And so many good things have come into this world for the betterment of treatment of patients. I won't be taking more time. So I would request my co-chair to give a short introduction of Parthakar. I know the introduction is very long. Dr. Abhijit, please.
Yes, thank you, Dr. Rajesh. Good afternoon, friends, and thank you, Dr. Ashish and the team NDID for giving us opportunity. So now I would be introducing our first speaker, Dr. Parthakar, who basically needs no introduction. He's been a consultant in diabetes and endocrinology at Portsmouth Hospital's NHS Trust since 2008, and he has been the clinical director of diabetes from 2009 to 15, and he is being part of multiple national award-winning departments due to his services and care provided. And as Dr. Rajesh has already mentioned, that one of his main areas of interest and his passion is in helping to redesign the diabetes care to integrate chronic disease management across primary and secondary care. He's the pioneer of Super 6 diabetes model, which aims to deliver diabetes care differently. And he has developed a novel transitional care service in Portsmouth, as well as created a hypo, which is we all know, a major hinder in management of diabetes hotline to enable direct communication of ambulance personnel with special staff. So a very good indeed work. And he is also a co-creator of Talking About Diabetes, especially the type 1 diabetes, the rise of machines, the various technologies in type 1 diabetes management. And he also holds the role associate National Clinical Director Diabetes with NHS England, leading on developing the NHS Right Care Diabetes Pathway, leading on Freestyle Libre being available on NHS tariff. I think again a very big congratulations to him for this. Helping to coordinate the development of diabetes language matters, document and development of type 1 diabetes NHS England resource. And he is one of the co-leads of diabetes GIRFT process, which had led on developing a diabetes technology pathway with multiple stakeholders, and he is a regular blogger for the BMG. So I think really a great personality for management of diabetes and service to people. So I hand over now the session to Dr. Parthakar. Please, sir, go ahead.
Thank you, everybody, and beautiful introduction. And I think as everybody has done, let me start by saying thank you.
Can you be a bit loud, Dr. Partha? We can hardly hear you. Please be a bit closer to the mic. Or...
Yeah. Is that better? Better?
No, but still not.
Not that good. Hold on one second. Let me see what's going on with my mic system. How's that? Any better? Better? Little bit better?
A little bit better, yes.
Okay. I'll try and speak loudly. How's that?
Yes.
Okay. So I'm going to start by saying thank you to Ashish and for all the work he has done, and thank you for the invite, and to all of you as well for being here at this time and taking the pain of introducing me everything. So I've got about 10-15 minutes to go through a few things. I will quickly go through some slides and then we'll take some questions. Some of it you will all know. So I will share my screen so we can get that done. On, and hopefully you can all see it now. Okay, so I have basically said what is happening in you, and I have sort of titled it Tongue Twisters, Gizmos and Basics. That's what diabetes care is like at the moment in 2022. So if you look at all these things, these are all these new names that keep coming in different countries, and every country will have different names. And the reason I put it up, we have moved a long way away from those days when we just had metformin and glimepiride or gliclazide and all those drugs to think about. We have got all these explosion of new drugs, whether it's GLP-1 analogs, SGLT2 inhibitors. So if anybody said, what's the basic change that's happened in type 2 diabetes drug management? Over the last 4-5 years, the whole world has completely changed because we're talking about end organs, etc., etc. So going forward on that, right, let me just get that done. So this slide probably summarizes the biggest changes we have. So nowadays we're talking about remission of type 2 diabetes. If you go back 10-15 years, it was not a big topic to discuss, but it's definitely now one of the biggest things happening. You have got people talking about what is the best diet, and you will have different forums. It has to be the ketogenic diet or the low carb diet or the Mediterranean diet, but conversations every
your voice is not loud.
Voice is still not coming loud?
Yeah.
I'll try again. I can get as close as possible. I'm not quite sure what's going on to the mic here. Okay. How's that? Is that better?
A bit better.
Better.
Okay. Sorry about that. Not sure what's going on with the computer and everything this morning. So what we do have is the debate about the best diet, and you have the role of metformin being challenged, and all these new classes of drugs coming through. So that is the fundamental change that's happening in diabetes care. People are discussing what is the biggest change that needs to happen, and all these new drugs and the cardiovascular outcomes, heart failure, renal failure, and which drugs comes first. And that is being reflected in all the national and international guidelines, whether it's NICE, whether it's ADA. We are now talking about new drugs. And this is what's happened in the world of technology. Just like, you have seen series of Star Trek, things have progressed. This one has happened as well. And what you see in the world of technology, this is the biggest change that's happened. And it's happening in every country. In some country, quite rightly, it's dependent on the amount of money and everything. But glucose monitoring is starting to change. So in the 80s, we had the change from urine dip to glucose stick by fingers. And now we are getting into this particular area where people are talking about non-invasive sensors. And then you got pumps being connected to everything. So that's become a big thing going forwards about technology. What we do have as a result of that, the basics. What about the basics? In the basics, we have all these people with diabetes struggling with all these things in life. And that is not changed. So if you look at that particular principle, it's that number I always say, as beautifully introduced, where right at the beginning, the diabetes is not just about numbers. It is also about the interaction you have with the patient, and we don't find much time to interact with the patient. So you do have what we call 3 planks: the self-management of patients, peer support, and access to trained professionals. And we're all trying to sort of do that better. The problem that we have in any part of the world is access to trained professionals. So I'm going to take a pause here and again remind ourselves, if you divide diabetes care into type 1 and type 2, in general, what has happened in the world, type 2 now talks about reversal and remission, which is possible in a lot of patients. Then we talk about metformin, of course, but after that, the whole world has changed about which drugs we input. Do we try SGLT2 inhibitors? Do we try GLP-1 analog? And the days of gliclazide is much less in lots of areas. Then we talk about type 1, where we talk about basically where we are with technology. Type 1 is all about technology. Type 1 is about new insulin. That's what type 1 is about. People in that community is more switched on. So that in general is the big changes. Data is there to suggest how much improvement it's done. And all across the board, we know technology works. That is not a new thing. And you have all these sort of new online things coming through as well, which I'm not going to talk about. But one of the big things when you talk about other countries, very easy for me to sit in the UK setting and say that, oh, well, everybody should have this and everybody should have that. But access matters, the basics matter. And most importantly, the money matters. So when you're talking about in an Indian setting, for example, what is affordable, you do have that widening divide. And that is a responsibility also, which we talk about. And it's good to see Indian companies also come up with products, come up with interventions, come up with things which are more affordable, because all you have otherwise is external companies coming and saying, here is the money and this is what you should provide, which is not possible for everybody to do. So it's important we have that sort of division as we go along, and we aware that you have that innovation in place locally so that the right technology is available to everybody. So just to sort of quickly go through what are the basic changes in diabetes care. If you take a step back, when we see a patient with type 2, we're talking about remission. We're talking about drugs which have got end organ outcomes. If you got type 1, we're talking more about technology. But all of that is dependent on the ability of the person to buy, which goes back again, links it back into what is affordable. And for example, in a country setting, what is the country itself doing and the local companies to make it more affordable for people. So that's what I'll end. And I'll sort of, sorry about this noise and everything, but I will then, what I can do is I can take any questions and anything that you need.
Thank you, Partha. Over to chairpersons.
Yes, sir. Thank you, Dr. Partha. Very, I would say, in simple words, you have really given the gist of the whole thing, that how the diabetes scenario is today, and how we should really be managing diabetes, especially in countries like India, where we have so many patients, and how really we can with different you can say directions, a multi-pronged approach will help in management of type 2 diabetes. And in fact, now with easily availability and quite affordable technologies also in India, definitely we can now take care of our type 1 diabetes better than a decade which was earlier. Okay, thank you. Over to Dr. Rajesh, sir. You are muted, Dr. Rajesh.
Thank you so much, Dr. Partha. It was really very wonderful, enlightening, and straight to the point. I'd also like to come to the point. Have you ever felt or noticed that a lot of changes that are taking place in the management of diabetes, the newer things that we are coming up, either in technology, definitely there's no doubt that technology has changed a lot towards better, smaller equipments, like you've shown CGM and other devices which are helping our diabetic patients. But except for that, I feel there are a lot of things which have been hyped greatly out of proportion. Especially, I would say, remission. Why is it that we are running behind the industry? The industry brings out certain, let's say, certain aspects of diabetes. Because I remember it started with GLP. Before that, with particular insulin, there was so much discussion about hypos. Well, we know about diabetes, we know there are hypos since decades now, but certain aspects of diabetes are being hyped up every time a new product is introduced, even though having new products is very good. So what is your opinion about this? Why we doctors and science people are not at the forefront? Why are we following the industry?
I totally agree with you. I 100% agree with you. I think the incidence of hypos in type 2 and incidence of hypos in type 1 are very different. And I think we all know that from our practical work that we do. And you're absolutely right. We don't put enough emphasis on the basics, which is what I say. Because let's not forget, metformin. Okay, so let's talk about diet. Diet we don't put enough emphasis on. Metformin is still a wonderful drug, right? And you're totally right about, so what you will see nowadays, what has happened, if you go to conferences, the emphasis on hypos has suddenly gone down a little bit, and people now are talking about end organ outcomes.
Yes.
If we've all been in conferences 4 years back when everything was about what? DPP-4 inhibitors, right? Everything. You have lots of hypos. If you use this drug, you will not have hypos. Now, you and I know that if you look at DPP-4 inhibitors now, nobody's talking about it, or people are starting to come off it. Why? Because the same people are now saying, oh, it doesn't give you HbA1c much improvement, and it doesn't do anything. So why were we hyping it up for so many years? I totally agree with you. I think for me, the basic question should be, the reason we do diabetes care is improving end organs. If there is genuine evidence of something improving your end organ, like we do with lipids, right, cholesterols, then I think we should pursue that. But I fundamentally believe in type 2 diabetes, the focus is on the wrong place. It should be much earlier in the treatment. Rather than saying to a patient, here is another drug, I think we should focus more and more, a lot more on lifestyle and a lot more on what people, because what happens, people sort of say, oh, you can't afford this. But you can probably afford a better diet than you can afford most of the other drugs.
That's very good. So thank you so much for your honest opinion.
Professor Partha sir, can I have a question, sir?
Please.
It was a wonderful talk. So, Professor Partha sir, we are in the era of precision diabetology. We already have this oral semaglutide in the form of SNAC technology. What about your reviews on upcoming oral insulin? Any idea about the oral insulin, Partha sir?
So oral insulin, I think, is still going to take some time. The data that I have seen, which I liked, was more the weekly insulin that's coming, right? I think that will be interesting, but the problem will be the pricing with all these things.
Sure.
Right? But the data on the weekly insulin looks good, and I think a lot of our type 2 patients will like that.
Yes, sir.
Okay, to have once a week insulin. I'm not sure about the data in type 1 yet, if I'm very honest.
Fine.
Type 2 data, it looks possible, but oral, I think, is different.
Thank you, sir. Thank you very much.
So thank you, Partha, for joining in this event, and you have given a wonderful talk and the crisp message you have given for the management of diabetes in the real world. And soon we will meet live when you will come to India. And thanks a lot. Thanks a lot to Abhidya and Rajesh for joining.
Thank you so much
with us. And we are having more stalwarts to come. Over to Kanan.
Thank you. So this year, our NDID 2022, our theme is 360 degree of control of diabetes. For that, we have a unique topic now, the universal solutions for diabetes management. For this, we have esteemed respectable chairpersons, Professor Smith, Srivatsava sir, and Dr. Balaji Jaganmohan sir. Welcome, and over to you, chairperson sir.
Thank you, Dr. Ashish. Thank you, the entire NDID team, for inviting us to chair this session. Can we have the speaker introduction slides for Dr. Dakshata?
Welcome, sir. Welcome, sir.
Yeah, so it's my pleasure indeed to introduce Dr. Dakshata Padai. She's a practicing diabetologist at Mumbai. So she's more into preventive diabetology, and she's the director at the Conquer Diabetes Care Center in Mumbai. And she's also the founder of the Om Diabetes Club, which I believe is a support group of more than 15,000 diabetic patients. And she's also the founder committee member of the United Diabetes Forum. And there are several publications in national, international journals. And she's received a lot of awards for diabetic foot care in pre-diabetes and several other work that she's done in the field of diabetes. So without further delay, I will ask Dr. Dakshata to come over and present this very unique presentation on the universal solution for managing type 2 diabetes. Over to you, Dr. Dakshata.
Thank you, Dr. Balaji. Thank you for this kind introduction. Thank you, Ashish, for inviting me. And I'm extremely sorry that I could not join physically. We have to join virtually. Actually, my laptop is not supporting the presentation. So Neelam will be sharing the screen. Neelam, you will share the screen?
So welcome, Dakshata.
Thank you, Ashish. I'm sorry for this. Huh?
No, next year we will be joining live.
Sure. So rather than focusing on problem, I think it's high time that post-COVID we all have agreed that we have to focus more on solutions, then the problems will disappear. So topic given to me today is universal solution for diabetes management across baseline, various HbA1c from lowest to highest HbA1c level, background therapies, and obviously the comorbidities present in our patients. So the next slide, Neena. In next 10 to 15 minutes, we will be focusing shortly in guidelines. Guidelines are our Bibles, challenges and complexities. What are the advantages and limitations of different plethora of OADs? We will be focusing on DPP-4 inhibitors as a monotherapy, add-on therapy. We will be looking at few landmark studies and the comorbid conditions. What is the role and what is the safety, or what are the benefits of DPP-4 inhibitors in CV, renal, and hepatic and elderly patients, as well as post-menopausal women? And what are the extra glycemic benefits of DPP-4? Next slide. So maybe I'll skip for first few slides because everybody knows this number. These are the numbers, and highest prevalence of type 2 diabetes right now is in elderly population. Yes, there are newly diagnosed young diabetics, but the patients who are newly diagnosed and already having comorbidities are elderly population. Next slide. So this is a centenary year of insulin birth, and from 1920 to 2020, after animal insulin was invented, about 14 classes of OADs have been invented, and they are there to help us. So let's look at the solutions. What are the solutions we have, and what is the complete solution towards diabetes management from this basket? Next slide, please. So go to guidelines. We do follow guidelines, blindly. And when it comes to guideline, ADA, American Diabetic Association guidelines are like Bible to us. So whenever a patient comes to us, walks in our cabin, patient is maybe newly diagnosed or pre-existing diabetic patient. If patient, now the guidelines have changed totally. If patient already has some comorbidity, ASCVD or CKD, the solution is completely different. Maybe metformin plus SGLT2 plus GLP-1 inhibitor, or maybe SGLT2 or GLP-1 without metformin. But most of the patients who come to us may not have comorbidities, or maybe having comorbidities, but they are still not diagnosed. So when such kind of patient walks in our cabin without complication, what are our complaints? Our first thing is obviously quality of life. Previously, maybe 5-10 years back, the cost of therapy was very, very important, whether the drug is pocket friendly. But looking at the burden, financial burden of the complication of diabetes, if A1C is not controlled initially, looking at the metabolic memory effect, 34 years of UKPDS with us, we are really not bothered about the cost of OHs. So the second thing which will come to our mind is hypoglycemia and weight gain. So we need a drug which is weight friendly, if not weight friendly, but at least if patient doesn't, molecule should not cause weight gain. And hypoglycemia, when it comes to minimization of hypoglycemia and glycemic variability, I think DPP-4 inhibitors really stand tall amongst this list. Next slide. It acts perfectly across all HbA1cs. Next slide, please. So complexities, I have just, it's not just fasting, post-lunch and HbA1c at present when we are treating diabetic patient, it's glycemic variability and quality of life. So we are going to look at hypoglycemia, weight gain, comorbidities, and last but not the least, adherence to the treatment. If the patient causes least glycemic variability and patient drug is not very expensive, the adherence from patient side to the for the molecule is going to be great. Next slide. Sorry for this delay, but somehow the PPT is not supported in my laptop. Now, whenever we are looking at South Asian phenotypes, definitely there is going to be something different: lifestyle factors, modern urbanization, lack of physical activity, high carb, fat-rich diet, and these postprandial peaks which are responsible for complications on the background of severe insulin resistance, severe early beta cell secretory defect, abdominal obesity, and there is going to be this factor which is always on the back of our mind: 50 genotype, phenotype, the specific genetic defect in Southeast Asian. We need to look into these factors whenever we are choosing any oral anti-diabetic drug. Next slide, please. So we have more and more problems getting diagnosed, and we have more and more classes of drug. We have more and more drugs in each class, and many drugs are juxtaposed. Non-medical therapies are coming into action, combination, various logics behind combination therapy, and multiple permutation and combination. So let's try to have a simple problem. Now, this is a very good slide in which it's just not, we are looking at glycemia, lipids, and anthropometry, blood pressure. We are looking at many, many factors. So if we have a drug which is, addressing at least 70 to 80% of these complexities, it is going to be beneficial to our patients in long run. Next slide. So it has to be a customized therapy. It has to be an individualized therapy, and we have to be proactive from the diagnosis of diabetes. Next slide. So whenever patient comes to us, definitely psychosocial and economic factors play a role. But age of the patient, duration of diabetes, what is the life expectancy, what are the comorbid conditions, and whether patient already has any vascular complication. These are the factors we are going to look into whenever we are going to choose any oral anti-diabetic therapy. Next slide. So which is the best choice? Next slide. I'm going to open it on my mobile. So just looking, I think there were some issues about DPP-4 inhibitors, about pancreatitis and upper respiratory tract infection, and I think we don't need any robust clinical evidences from our own clinical practice. We have reconfirmed belief in this molecule, and I don't think any of us are seeing any of these side effects so prominently in our daily practice. Next slide. Now, there are these different defects with respect to ominous octet. And whenever I'm comparing DPP-4 inhibitor with other classes of drug, I think it is addressing almost 6 to 7 defects out of 8 at insulin secretory level, resistance level, hepatic glucose output level, and just there's the except renal effect, alpha cell defect, incretin defect. I think everywhere we are having positive effect with DPP-4 inhibitor. Next slide. Next slide, I would omit this slide. Neelam, this is in PDF form, that is why it is taking time, na? Next slide. So by patients on gliptin, they have better adherence. Now, this is a retrospective analysis of all OHs compared. If you see adherence with gliptins, DPP-4 inhibitors is almost 41% with respect to SUs, metformin, and pioglitazone, whether the adherence is about 30%, and any adherence more than 40%, near to 50% is great. Next slide. Now, selectivity. Whenever it comes to selectivity profile of DPP-4, whenever we are comparing Sita with Bilda, Saxa, and Lina, and then the gliptin, more than 100-fold selectivity of DPP-4 over DPP-8 and 9. And with respect to fibroblast activating protein, also sitagliptin has more than 100-fold selectivity. Next slide. Now, whenever we are comparing HbA1c lowering efficacy, that is the main thing. It's always a primary outcome of any landmark study, that HbA1c reduction, when we start at baseline of 8.5 or 8.2, A1c reduction with sitagliptin as opposed to vildagliptin is robust, 1.2%. With saxagliptin, it is around 0.6. So there is a robust HbA1c reduction as compared to other classes of gliptin. Next slide. Now, this is with the baseline HbA1c is 7.5, 8.8, or 8.0. With respect, even if the A1c is on the lower side or higher side, the A1c reduction has to be at least 0.9 to 1.2% with sitagliptin. This is being proven with various studies. Next slide. And as an add-on to pioglitazone, the HbA1c reduction is very, very robust. Now, as an add-on therapy to other OADs, sitagliptin is always well tolerated in all patients, and it appears to be effective in subjects with type 2 diabetes who experience inadequate glycemic control last time, with metformin alone or with So with combination of glimepiride and metformin and acarbose, it basically gives reduction of HbA1c more than 1% when it is added to background OHs like metformin, SU, and acarbose. Next slide. This was a Korean study. Now, as a similar efficacy is seen either as a monotherapy or combination therapy. So this is basically a systematic review of all randomized controlled trials from health economic evaluation studies, systematic reviews, and meta-analysis. It shows that outcome was reported as weighted as mean change from baseline and odds ratio with 95% is. So whether it is used as a monotherapy or with metformin or SU, the HbA1c reduction is quite robust, around 0.7 to 0.9. Next slide. Next slide. Now, this is meta-analysis including 12 randomized studies, which included huge subject size of more than 10,000 subjects. And when compared that CV hazard ratios in patients with SU and gliptin, there was no difference. So it showed is non-inferiority to SU with respect to CV hazards. Next slide. And these selected mechanistic trials, yes, there are mechanistic trials with DPP4 inhibitor. It's not only with SGLT2 inhibitors or GLP-1s, but it is with DPP inhibitor. Some mechanistic trials have shown positive effect on positive CV effects by increasing endothelial function, decreasing inflammation, decreasing plaque formation, improving left ventricular function, decreasing triglycerides, and in some patients decreasing myocardial infarct size as well. Next slide. Again, when you are comparing all the gliptin landmark studies with cardiovascular endpoints, sitagliptin scores tall. Next slide. From TICOS. Now, this is real world evidence. More than 1 lakh newly diagnosed patients were identified from Taiwan National Health Insurance Research. And if you say the CV outcome, whether it is CHD or stroke or any adverse CV outcome, sitagliptin has proved is vital. Next slide. 1 out of 2 diabetic patients have CKD. So let's talk about CKD. Next slide, please. When we are talking about gliptins in CKD patients, they are effective across spectrum of CKD. We have been using 25 milligram of sitagliptin for our dialysis patients, reduced EGFR patients, severe CKD patients, I think since last slide. Since last more than 10 years, and we have seen excellent results. Then safety consideration, there is no concern. These patients can be, gliptins can be given, DPP4 inhibitors can be given in all stages of CKD. Next slide. So from secondary outcome studies, if we see 23% of the patients who participated in TICOS had some degree of CKD while entry into TICOS. And treatment with sitagliptin was generally well tolerated with no meaningful difference in safety outcomes observed between those with CKD patients assigned to sitagliptin and placebo. So there is no adverse outcome with sitagliptin in CKD patients in TICOS study. Next slide. So this is emerging renal CV data from all the outcome trials, and the results are still not out clearly. So let's wait for it, but definitely we are going to get some positive results. Next slide. Now, NAFLD is a big, a giant elephant in the room. So more than 60% of our patients already have NAFLD at the diagnosis. We all know that. So let's look into role of SITA in NAFLD patient. Next slide. So Vilda, we know because of the hepatic, it cannot be used in hepatic impairment. But when you are talking about SITA, it is indicated in patients with mild to moderate hepatic impairment and it is not contraindicated in severe hepatic impairment, but there is no data in severe hepatic impairment. So let's hope that in coming years, like how we have data from GLP-1 and SGLT2 inhibitors in patients with hepatic impairment in NASH, we do get some data with sitagliptin. Next slide, please. Now, elderly patients, we do have, a lot of elderly patients where we need to choose our OHs very, very wisely. Now, this is the study conducted in Chinese population, around 300 patients. The mean age group was around 73. And when DPP4 definitely reduced HbA1c, but the improved safety of liver and kidney was also established. Next slide. Next slide. Now let's talk about extraglycemic benefits. Gliptins are robust secretagogues. So they have some effect, but still they are weight neutral. You know why? We will have answer in the next slide. Next slide. Now, these are the obese patients, around 120 patients. In these patients were already on insulin. And if you see sitagliptin in obese patients who were on insulin, the reduction BMI came down when sitagliptin was added. All the parameters of insulin resistance came down, and specifically the ghrelin level came down. Next slide, please. So ghrelin is a basically appetite stimulant hormone. Now, these group of patients, when added sitagliptin was added, there was significant decrease in total ghrelin level when patients were receiving sitagliptin, and not in the patients who were receiving only medical nutrition therapy. So weight loss was associated, or maybe due to reduced ghrelin level in patients who were receiving sitagliptin therapy. Next slide. Now, on systolic blood pressure, so the reduction is robust. Always we see that the reductions of antihypertensive agents happen. Maybe
we have only 1 minute remaining.
Done. Next slide. Menopausal women, sitagliptin has some positive effect on bone metabolism, and the bone mineral density also improves with this. Next slide, please. Next slide. Fracture risk is very much reduced. Elderly patients, better the sarcopenic parameters like fat-free mass and skeletal mass improves, and hand grip strength also improves. So sarcopenia definitely improves in our patients. Next slide, please. Last 2-3 slides only. Cognitive impairment is 100%. These are few landmark studies. There are few more studies also. They show that improved glucose control, and there may be some other mechanism, but cognitive impairment, maybe will be less glycemic variability in this drug. That also contributes to better cognitive improvement. Next slide, please. And in COVID-19, it was seen that retrospectively, when the patient were continued with gliptins, the ICU admissions were less, respiratory support was less, and the mortality rates were very less. Next slide, please. I think probably we'll go to the last slide directly. So this is the universal solution: effective, efficacious, renal, CV, hepatic, safe, and extraglycemic effects are quite, clinically meaningful, and minimal hypoglycemia and weight gain. Last slide, please. First. So it is approved by US FDA, CVOT, renal hepatic safety, dosing, OD dosing, much more convenient, adherent, patient exclusivity, and selective DPP4 enzyme activity. So just lastly, I think this is a drug which should be started at the time of diagnosis, even if the HbA1c is quite on the lower side, maybe 6, 6.5 or 7. From its study, we know that gliptins, they have a lot of positive effect when started initially. So it's just that we all have to be proactive in using this drug. Thank you so much, and thank you, Ashish, once again.
Yeah, Dakshita, that was well defended, gliptin, I think, but I have just two questions to you. One is that even European guidelines, they have moved from universal solution to a precise medicine. What is now we call it as precision medicine. So they have given up, going after metformin, but rather introducing drugs which better suit the patient, medically also and pocket-wise also. So we are moving more towards precision medicine even in diabetes. So now why are you propagating or are proponent for a universal solution for diabetes? One. And the second part is, though I do not debate that gliptins are part of universal solution, but don't you feel that SGLT2, suit better for universal solution for diabetes, looking at their beneficial effect? Gliptins do not have beneficial effects. Beneficial effects in terms of cardiovascular outcomes, renal outcomes, atrial fibrillation, heart failure, and not many things which are now being associated with SGLT2. So why propagate gliptin vis-a-vis SGLT2 inhibitors?
Yes, I do agree. So I'm a great fan of SGLT2 inhibitors. But sometimes newly diagnosed patients, when they come to us, and elderly patients who are newly diagnosed patient, it is age-related hypoglycemia. These are the typical patients that I think they have more of robust DPP4 defects, GLP1 defects, GIP1 defects, and they are addressed better. And they don't need to be treated very aggressively. Even if we are fond of SGLT2 inhibitors, many patients, they may not be having comorbidities. underlying comorbidities. And when we are prescribing these drugs, there can be some side effects. I would be still little cautious about SGLT2 inhibitors side effects. I'm not talking about genital infections, which we see commonly, but there can be some other side effects like hypertension. And we see that in the elderly patients, when we start this drug, it becomes little tough to manage. Now, DPP-4 inhibitor is a drug which is a mild drug. I do agree. And I'm talking about universal solution, means it's glycemic effect, extra glycemic effect, and we are just probably, according to me, concentrating on CVD and renal benefits of SGLT2 inhibitors and GLP-1. But there are outcome trials of TICOS and other examine and other DPP-4 inhibitor trials where there is going to be, because improvement in cognitive function, these extra glycemic effect which I'm talking about, sir, are definitely seen with our patients, because least glycemic variability is something which we see with DPP-4 inhibitor, the smooth reduction of HbA1c control. Definitely, it's not a very potent A1C reduction agent as compared to sulfonylurea or DPP-4 inhibitor. In fact, pioglitazone also, though pioglitazone is not a secretagogue, it is a sensitizer. But the quality of life, you would also agree, sir, is much better if DPP-4 and metformin combination suits to our patient compared to any other combination. The glycemic variability is less, and the symptoms of glycemic variability are very much less. And universal solution means fasting. It's not just glycemic effect, but with the years of landmark studies, I think the extra glycemic and the renal and hepatic effect what we are getting from the studies is the universal solution, according to me.
Yeah. So probably for our rescue, gliptin have come in a combination with the SGLT2 inhibitors for our rescue. Over to you, Dr. Balaji.
Jay and Viru combination.
Yeah, I think,
what do you say, power of duo?
Power of?
This is power couple. What do you say? The combination.
Of course, this is a part. But I would say the gliptin plus metformin is a better dating couple. शादी के बाद सब बिगड़ जाते हैं.
Over to you, Balaji.
Yeah, I feel that, as Professor rightly pointed out, SGLT2 inhibitors are the only drugs along with GLP-1 which has protection for end organ damage as well as vascular benefit. DPP-4 inhibitors are more of neutral. We've seen that in the CVOT trials. There is more of cardio as well as renal neutrality. So definitely they're universal. They do not have any immediate safety concerns. But in the long run for organ protection, I think SGLT2 is the way to go. And this combination, as you rightly pointed out, is a savior now in these times.
Agree, sir.
Okay, so over to you, Dr. Ashish. Thank you, Dr.
Thank you, Dr. for excellent talk, and over to Kanan for next topic.
Thank you, Smith and Balaji,
for joining us and gracing the event. Smith and Balaji, they are always with us. Thank you, friends.
So, dear friends, let us move to another important session. Initiation in person with type 2 diabetes, both are uncontrolled and multiple OADs. For this, we have the wonderful esteemed chairman, Panda, and Dr. Amit Rajput. Panda is a professor and head of the PG Department of Medicine, SCB Medical College in Kotak, Odisha. And Dr. Amit Rajput is a consultant diabetologist from Jalgore. Over to chairpersons.
Thank you, Dr. Kanan. And it's our privilege. I joined Dr. Amit Rajput to chair this session. I thank Dr. Ashish Dengra and the whole team of New Dimension in Diabetes, the NDID, for the academic update, and after the beautiful session by the Kheta on the oral universal solution in the form of SGLT2, DPP-4, metformin, comes the issue that when OADs fail, we know a time will come when OADs will fail, and we have to approach to the insulin. We have none other than Dr. Om Lakhani, who is from Ahmedabad, and he is the consultant endocrinologist and at the Department of Endocrinology, Zydus Hospital, Ahmedabad, and he is DNB endocrine and the winner of President NBE Gold Medal in Endocrinology National Board of Examinations, and national winner of the ESI TISA in 2016, and second runner-up in A.V. Gandhi Award, and winner of second 2 gold medals in the MD and 5 gold medals in MBBS. So he has also been honored with the Dr. Vittal Rao Nadagowda for best thesis in MD medicine and developer of the notes in endocrinology up. So you see here a brilliant student and who has been a key faculty in the field of endocrinology to tell you when OAD fails, how do you plan insulin therapy in your patients. We present you Dr. Om Lakhani. I request Dr. Amit Rajput to start the session.
Thank you, sir. I would just like to add that Dr. Om Lakhani is also very active on social media, and his posts are worth going through on a daily basis. So over to you, Dr. Lakhani.
Thank you, Amit. Thank you, Jayant. How are you for joining us?
Fine. Please go ahead.
Yeah. Actually, Om is having his marriage anniversary, so we send the recorded version.
First and foremost, before I begin, I'd like to thank my friend Dr. Ashish for inviting me for this wonderful conference. I apologize that I could not be in person, so I'm sending this as a recorded message. So today I'm going to discuss a very important topic: insulin initiation in patients with type 2 diabetes who are uncontrolled on multiple oral antidiabetic drugs. Now, this is a topic which is close to my heart. We have in fact done a lot of work on this topic and done some research as well, and actually made an app as well for this topic. So I hope it is very useful to the people who are listening to this. Okay, so what are we going to discuss today? We are going to discuss first when to initiate insulin. We'll be also discussing which insulin should we initiate. Should we start a basal or a prefix co-formulation insulin? How much dose or what dose of insulin to initiate, and how to titrate the initial insulin that we initiated. So we are going to discuss all of these as topics. So let's start with the first thing, that is when to initiate insulin. Now, before we begin, this is the app we have created specifically for this purpose. This app is called the Centurion Insulin app. It's available both on the Android as well as the iOS Play Store. The purpose of this app is to help physicians understand which patients insulin should be initiated. Also, which insulin should be the right insulin for that patient and what dose of insulin to initiate. So this specifically caters to the topic we are going to discuss today. So you can go ahead and download this app from the the screenshots given and from the QR code, and you can start using it. It's free of cost, absolutely free app. You can start using it, and you can in fact use it along with my presentation so that you get an idea of how to use the app as well as a lot of issues about insulin initiation. Okay, so first of all, when to start insulin? So broadly, of course, all patients with type 1 diabetes need insulin. That we all understand that. And of course, patients presenting to us with diabetic ketoacidosis also need insulin. That's also very well known to us. Any patient having diabetes in pregnancy or hyperglycemia in pregnancy often need insulin. When to use insulin and when not to use, it's something which is a separate topic in pregnancy. A pancreatic diabetes patient, a patient what is known as a type 3C diabetes, needs insulin. A perioperative patient often needs insulin. And in-hospital patient are admitted to the hospital also often need insulin. Patients with end-stage renal disease or end-stage liver disease, cirrhosis liver, or chronic kidney disease often need insulin. So these are a broad idea of which patients require insulin. Now let's look at a very specific area, that is patients with type 2 diabetes as outpatient who are on multiple oral antidiabetics. When should we start insulin in them and how should we start? So let us look at a case. So this is a case of a 58-year-old male patient. The patient is having type 2 diabetes since the last 8 years. He had recent worsening of diabetes after COVID-19. Now currently he is on glimepiride 6 mg, voclibose, metformin, and DPP-4 inhibitors. It's already on 4 oral antidiabetics, more or less in their maximum doses. He's mainly having neuropathic symptoms. So if you look at his case file here, his fasting blood sugar is 164, his post meal is 293, HbA1c is 9.1, so clearly out of control. Creatinine is normal, LDL is fine, SGPT is slightly elevated. He's also having subclinical hypothyroidism and low vitamin D. So these are the investigations of this patient. Now, we can use our app to actually determine whether the patient requires an insulin or not. Sometimes patients are reluctant for insulin. We often do the same exercise, ask the patient to input their own data in the app, and then they find out that the patient requires insulin. So it's a very good process, especially for patients who are reluctant to use insulin. So we'll input this data in the app. Okay. The patient is on 4 oral antidiabetics, so we entered 4 over here. Okay, so click on this. And it clearly tells us that our patient, Mr. SJ, needs insulin. Now, if we click next, it will also tell us the dose of insulin and the type of insulin. So we'll discuss that in the next few slides. But overall, this app clearly says that the patient requires insulin. Now, here, how we have developed this app, that's again a separate topic in itself, but I'll tell you the logic behind why this patient requires insulin in the next few slides. So, if you see the RSSDI, Endocrine Society of India guidelines are very clear of which patients require insulin. So this is, a sort of consensus on which patients should be given short-term insulin. A patient who is having catabolic symptoms, a patient who is having catabolic symptoms meaning weight loss, polyuria, polydipsia, patients having very high sugars, that is HbA1c more than 9, fasting more than 200, postprandial more than 300, acute complications of diabetes, hospitalized patients, perioperative patients, transplant patients, critically ill patients, pregnant patients. These are all patients who require insulin for sure. I think we know this very well. Of course, insulin therapy should also be considered in all patients failing to achieve glycemic targets with 3 oral antidiabetics. This is as per the RSSDI guideline. And you should consider initiating insulin in these patients with symptomatic severe hyperglycemia or who are having an unstable state. So, the first take-home message is which patients with type 2 diabetes should be on insulin. As we discussed, patients with osmotic symptoms, patients with an ongoing catabolism, like I said, weight loss, polyuria, polydipsia, patients with HbA1c more than 10%, random sugars more than 300, pregnant patients, ongoing ketosis, typically HbA1c more than 8.5% or 9% with 3 or more oral antidiabetics should be put on insulin. And this is as per the RSSDI guidelines. And this is exactly what we follow in the app as well. Those having severe organ involvement in terms of chronic kidney disease or chronic liver disease and perioperative patients. These are the patients who require insulin. Now, which insulin should be starting? Should be starting as the first insulin of choice in patients. Now, typically the formula that we use is, we look at the fasting. There are 3 things we can use. We can use fasting blood sugar divided by HbA1c as one formula. If it's more than 20, what it tells us is that the contribution of fasting blood sugar is more to the overall HbA1c. In such cases, basal insulin should be preferred. But if it is less than 20, it tells us that the contribution of the post-meal sugars to the insulin is more, to the HbA1c is more. And hence, perhaps you should use a premix or a formulated insulin. So this formula, that is fasting blood sugar divided by HbA1c is very useful for finding out which patients require basal insulin versus premix. Let's look at a case over here. So this is a patient who is a 55-year-old patient. She is having HbA1c of 10%. Her fasting blood sugar is 189. Her post-lunch sugar is 310. So again, we can input this data in the app over here. These are all standard disclaimers which we have to take for every patient so that we are sure that we're dealing with the right patient. Okay, so it tells us clearly that the patient needs insulin. I think that we have determined, right? The patient's HbA1c is 10. And it also tells us the type of insulin. So in this patient, as you can see, the fasting sugar was 189, the post-meal was 310. So this patient had mainly a lot of contribution from post-meal sugar. So in such cases, a pre-mixed or a co-formulation insulin, starting once a day before dinner. We generally start once a day and then you can titrate up, titrate. And it also suggests the dose of insulin which can initiate. In this case, it suggests a dose of 14 units. If you want to look at it, it will also tell us the types of insulin which are available in India. So you can have a look at which of them are available. So the idea here is that this app also helps you to know which type of insulin should be initiated. And generally, as we discussed, with the fasting blood sugar divided by HbA1c, if it's more than 20, then basal insulin is better. But if it's less than 20, in such cases, a mix or a co-formulation insulin is better. Okay. So the second take-home message is that you use fasting divided by HbA1c ratio. If it's less than 20, use premix or co-formulation. More than 20, use basal insulin. Okay. Now, what dose of insulin should be initiated? So the third question is, so we discussed when to initiate insulin. We discussed what type of insulin to initiate, but now we'll discuss what dose of insulin should be initiated. Okay. So the formula here that we have to use is again very simple. A lot of manufacturers recommend 10 units of insulin or 0.1 unit per kg, but clearly this is less than what is often required. Remember, in India, patients come with a lot of glucotoxicity. Patients come to us with very high sugars. And at that point of time, insulin initiation with 10 units is often not enough. We may have to give much higher doses. Typically, the best is to use a formula which takes these glucotoxicity into account. And the formula that we typically recommend, and this is from Treat to Target formula. This is a trial which was done. Here, typically, you start fasting blood sugar minus 50 divided by 10. So it's very simple. If your fasting blood sugar is 200, 200 minus 50 will be 150 divided by 10 will be 15 units. So typically, you can round about to the next 2 digit or you can keep at 15. And this is typically the dose that we'll be using as a starting dose of insulin. Okay. So let's look at a case over here. So this is a 38-year-old male patient with type 2 diabetes with unintentional weight loss. Came with very high sugar, random sugar of more than 600 and urine ketones were negative. Now, if you look at his reports, his fasting blood sugar is 316, post-meal is 508, his HbA1c is 13.5, his creatinine dose that we are using is GPT 60 as the starting dose. This patient is a classical patient. So let's look at a case. So a lot of these patients, 38-year-old male patient practice, this patient clearly has what is known as with unintentional variant of type 2 with very high sugar, random sugar of more than 600. And you the different debate, negative type 1 hair. Now, if you look at this report, topic in all this, what blood sugar is 300 is post-meal of insulin should be initiated. HbA1c is 13.5. Now, if you look at this dose that we are using, fasting blood sugar is 360. Here now, 10 patient is a classical patient. Let's look at a case. So a lot of these patients, 38-year-old male patient, clearly has what is known as with the unintentional variant of type 2 with very high sugar, random sugar of more than 600. And you the different debate, negative type 1 hair. Now, if you look at this report, topic in all this, what blood sugar is 300 is post-meal of insulin should be initiated. HbA1c is 13.5. Now, if you look at this dose that we are using, fasting blood sugar is 360. Here now, 10 units.
So,
so you can clearly see here, the insulin in this case was suggested as a basal insulin. Again, if you would have calculated the ratio, you would get got what we suggested. The dose suggested here is 27 units, right, which comes from patient as fasting blood sugar of 316. If you do the calculations, you'll find as 27 units. You can use 28 units or 26 units. You can round it up. We can use 27 also. But in newly initiated patient, you can just start with the 2 units because that's what's demonstrated in the insulin pen. So in this patient, starting
especially mobile.
The take-home message here is fasting blood sugar minus 50 divided by 10 is a good formula for insulin. Now, how do you titrate things? Okay. So, Fixed fasting is the first thing. That's the first rule that we follow. We ask the patient to regularly monitor the fasting sugar. So first thing we target is just, Arjun ki, focus. We start with just one thing, that is correcting the fasting blood sugar. Right? And typically, we increase the dose of insulin by 2 to 4 units every day. We have fasting blood sugar in the range of 90 to 140. Okay. So another pro tip I'd like to give you, if the sugar is coming down, let's say patient's blood sugar is 200 and today it's 160. Anyways, it's coming down with, let's say, 16 units of insulin. In such patients, will not increase the dose of insulin because it's coming down, even though the sugar is not in the target, it's coming down, then will not increase the dose of insulin. So that's typically what we tend to follow. Okay, so I'll give you some example of titration here. So if you see this patient, this patient's fasting blood sugar is 154. So for, it has seen others, so it was 22. And it had gone up to 185, so we increased the dose of insulin. Right now it's come down from 185 to 175. So in this case, we increase, but generally a lot of patients we don't increase. Right, again, from there, it came down to 156, so we kept the same dose. Okay, and it came down to 99, we kept the same dose. Right, 129, again, more or less within the range, so we kept the same dose. So that's how we typically titrate these patients. Of course, there will be certain clinical judgments will be taken. Right? So as far as titration is concerned, once morning fasting sugar is concerned, then if you use a pre-mix insulin, then you can similarly look at the pre-dinner glucose and titrate to keep a target of 100 to 150 mg/dL. So if you're using twice a day pre-mix insulin, and this is how you could titrate. So basically fix the fasting and then look at the pre-dinner sugars. If the pre-dinner sugar is normal with only once a day insulin, then you don't need to add any additional. But if you require, you might have to add a pre-mix insulin before breakfast as well. So what take-home message here is that we fix the fasting first, titrate once a day insulin, initially basal or once a day premix, increase the dose by about 2 to 4 units to achieve a target of 90 to 140 milligrams. Okay. So we'll summarize by giving you some take-home messages. First and foremost, which patients require insulin? Typically, and the topic here was patients on multiple oral antidiabetics. This is important. This is as per RSSDI guideline. Right? Patients with HbA1c more than 8.5 to 9% with 3 or more oral antidiabetics should be initiated on insulin. Second important message is that you use fasting blood sugar by HbA1c ratio to choose the type of insulin. It's less than 20, select premix insulin. More than 20, select a basal or co-formulation insulin. Third important thing, fasting blood sugar minus 50/10 is a good formula for insulin initiation. This is the initial starting dose of insulin that you should be using. Again, fix fasting first, titrate once a day, initially basal, increase or reduce dose by 2 to 4 units till you achieve a target of 90 to 140 mg/dL. So this is all we had today. Thank you for your patience. And once again, I apologize for not being here in person, and I thank Dr. Ashish for this entire video. Thank you so much.
Thank you, Dr. Om. It was actually a very practical solution and a digitally advanced solution for the practitioners and the diabetes consultants at the different rural setup as well as semi-urban setup who face real difficulty in deciding whom to put on insulin and what dose and how to go for dose adjustment. And then downloading this app will really help putting the case scenario and suggestion of the app, and the further titration can comfortably be done if the doctor is little tech savvy. And I'm sure the young consultants who are below 50 can comfortably do this in the different primary care settings as well as the semi-urban and the even little backward areas. Though advanced setup is not there, they can use this in calculating. So it's very good plan, and the case-based discussion was very informative, and I'm sure it was very simple for the listeners, and questions if any Dr. Amit and me and Dr. Ashish can take up. Dr. Amit.
Yeah, thank you Om for important talk, and Amit, your comments.
I would like to add one point that if say the app shows a requirement of 40 units for a particular person or a particular patient, but some patients have different insulin sensitivity and insulin resistance. So he might land up in a hypo even with a 10 units of insulin. So I would still like to add that we should start low and go slow.
Yes, very correct. Because formulas can't be followed strictly. You have to follow the patient insulin resistance and all the things you have to see. So thank you, chairpersons, respected Jain sir and my friend Amit to join with us. And we are having our next speaker, Padma Shri Dr. Shashank Joshi sir, and he is here to bless us. Over to the chairpersons.
Thank you, Ashish.
So our next chairpersons are Sunil Kota and Bensley. And again, Sunil is a very good friend of mine. He is consultant endocrinologist at Diabetes and Endocare Clinic, Behrampur, Odisha. And another is dashing handsome our Bensley. And he is a very good friend of mine. And he is a consultant diabetologist from Bliss Diabetes Center, Vasai. Over to respected chairpersons.
Thank you, Dr. Ashish. Thank you, Ashish, for inviting us. And without wasting time, I would like to introduce Dr. Shashank Joshi. No one requires knows Dr. Shashank Joshi. No need for any introduction to Dr. Shashank Joshi. He is the consultant endocrinologist in Mumbai and the head of the COVID task force in Maharashtra. So, sir will be talking about the keynotes about this session. So, over to you, sir.
So thank you so much. First of all, I congratulate Dr. Ashish Dhengra. Ashish ji has been doing this wonderful educational meeting. It is great to see Sunil and Bensley both. And, we still are continuing in hybrid mode. So first of all, happy Ganesh festival and Gauri Pujan, and which is why it precluded me from not being there physically. Hopefully next year, Ashish, I'll be there in person with you. Celebrating the academic extravaganza.
Thank you.
I'm going to talk on digital diabetes care using machine learning with human touch, which will continue with what Om started. And what I'm going to talk is it's time that we need to embrace digital diabetes care for a brighter future. So that question is very clear. So we have a digital diabetes digitosome, and we need to integrate technology with current management. We also know remission is a possibility, and we have a twin cycle in diabetes. We have a twin way to reverse diabetes. We have some personal expertise on this in terms of an RCT using artificial intelligence in diabetes. But we can actually reverse chronic disease, hand-holding and using technology, and maybe one or two take-home messages. So clearly we know that artificial intelligence is here to stay. We have continuous monitoring. We have now e-pharmacy clinics. We have a connected home. So people have gone home. We have intelligent treatment plans customized for people's personalities. And therefore, we are trying to now create a digitosome, which means a digital connectivity and space for diabetes care and management, for diabetes research, and for diabetes prevention. And we are looking at integrating big data and artificial intelligence. One of the places where the previous speaker also alluded to is hypoglycemia is one of the major rate limiting steps for diabetes management. We know because it is a hindrance to insulinization, it is associated with adverse outcomes, there is a direct and indirect cost of hypoglycemia. And for successful diabetes management, prevention of hypoglycemia is the key. And we know that there are multiple factors which increase or make somebody vulnerable to hypoglycemia, which are listed here. And clearly we know that there are newer approaches to reduce hypoglycemia therapy. So there is pharmaceutical advances in terms of insulin therapy. We know that we are getting better and better insulins, and we have better and better ways to recognize hypoglycemia. We also know that the pumps have evolved, and clearly the CSI has evolved, glucose monitoring has evolved, CGM has evolved, and we have now the revolution, whether it is the Freestyle Libre or Dexcom, which has clearly changed the way we think about digital diabetes care. And things will move further now, because machine learning and artificial intelligence is like predicting. And we are scientists, we are physicians, we are clinicians, but we will be able to predict glucose spikes, glucose lows, and we'll also be able to develop smart insulins, which will be glucose responsive, which will be like molecules which will turn on when the glucose is high and turn off when glucose is not needed. So we are having a lot of advances in this direction. And diabetes remission has now become a reality. We know that diabetes remission now has become an acknowledged term. And we know for somebody to be in remission of diabetes, there has to be absence of glucose lowering therapy. There has to be normoglycemia, and there has to be more than 1 year of duration. That's the definition. And this is the meta-analysis of the remission. I don't want to go into details of it, but globally now there is a recognized definition for remission. And that global definition for remission is that it is defined as return of A1C to less than 6.5%, which either occurs spontaneously. So spontaneous remission is possible in type 2 diabetes, or following intervention for at least 3 months in absence of a glucose lowering pharmacotherapy. And if A1C is not a reliable marker, people recognize that the fasting below 126, A1C less than 6.5 also is recognizable. And we also know that testing A1C for remission must be done before and after. And we need to keep on doing it at least every year. So obviously, one of the major ways to remit diabetes is via diet. Let food be thy medicine, medicine be thy food is what Hippocrates said. And clearly our lifestyle is skewed now. Our modern lifestyle, we know that, sitting on a chair or sitting is the next smoking. And our sedentary lifestyle has been the prime drivers of Asia and Chindia. China and India lead due to economic development, urbanization, change of diet and lifestyle. Formerly it was going to Jabalpur was impossible because of the access. But now with the air connectivity, it is quite easy and doable. Even now I was in two thoughts whether I should fly down to Jabalpur to see my friend Ashish today night and come back tomorrow morning. But clearly that is what has happened now. We are the epicenter of diabetes, which is occurring at a younger age, at a lower degree of obesity in our population. So we have central obesity at a lower BMI. That's our phenotype. And it's all driven by our waste kinetics. So we are thin fat Indians, more fat, less muscle. We are sarcopenic. We have abdominal obesity. We are sedentary. We have affluenza. Is it genetic? Yes. It is familial. Is it environmental? Absolutely yes. And it's all through a metabolic organ, which is also a structural organ called muscle. And we clearly know for the same BMI, we have more fat in our body composition. So we have more fat, less muscle mass, probably driven through the mitochondria in our mitochondria. And we are a carb fat country. In fact, the highest carbohydrates are consumed in central India, where Ashish is located. And they love their sweets, they love their brunch. They definitely all over India, we eat too much of carbs and fats and very less proteins. So obviously, when Professor Taylor removed the twin cycle hypothesis, when we eat too much, we have a fatty liver, and that triggers a fatty pancreas because the islets also get triglycerides, and that clearly is there. And metabolic inflexibility is the root cause. So clearly, mitochondria is at the heart of the matter. And the way the mitochondria selects glucose and fat depends on whether we are metabolically flexible or inflexible. What happens in type 2 diabetes is our metabolic inflexibility sets in, and the metabolism is not flexible like before. And clearly, mitochondria has a capacity to switch between oxidative fuels depending on the nutritional context. And that is normally lost when you get obese or type 2 diabetes. And that is why disease gets progressed. And that's a unique characteristic of mitochondria. There's evidence for this. For example, this is from Professor DiFranzo's group, which clearly showed that ATP synthesis decreased in mitochondria from obese and type 2 diabetic subjects. Clearly, you can see that here compared to the leaner individuals. So it's all in the mitochondria, which is the seat of the biogenesis and insulin sensitivity. And we can modulate mitochondrial biogenesis, function, reduce insulin resistance, and improve insulin sensitivity simply by exercise or restricting calories or pharmacological intervention. So it is doable. But the first principle people applied was very low calorie diet. And very low calorie diet started way back in 1929. But it led to poor quality proteins, insufficient micronutrients, and sudden deaths. And that is why Codex introduced safety standards. And now we have definition of very low calorie eating plans. So VLCD, very low calorie eating plans are 450 to 800 kilocalories. Low calorie diets are 800 to 1200 kilocalories. And they must have at least 50 grams of protein. And they must be micronutrient replenished and 7 grams of fat. So that's a mandatory Codex norm of 1995 that if you are doing any drastic plan, these are mandatory requirements. Obviously, bariatric surgeons pipped the post by reversing diabetes very early, and Morris et al. Showed it. But Taylor also showed, Professor Roy Taylor, that you can do the same what you get in bariatric surgery by severe caloric restriction. And you can restore the first phase of insulin secretion. And it is just, they showed in the direct trial that just by, doing severe caloric restriction, half the patients you can actually remit diabetes. So what did they do? They replaced meals with low calorie diet, negative calorie balance was established, they depleted liver and pancreatic fat, and they reversed diabetes. And everything was reversed. So shorter the duration of diabetes, younger the patients, you can reverse diabetes. So that is a very, very doability today. And you can use technologies. Like, for example, we have used technology in a metabolic way using a twin technology, where we have tried to create a digital twin of human health signals, happiness signals, causal signals, and use precision nutrition, precision medicine, and directed by a coach and a doctor, we can actually reverse diabetes. Many such programs exist. Twin is one of them, where we did RCT. And through RCT, we showed that we can create and predict the way the CGM predicts. If you have 35 days CGM readings, artificial intelligence can remap with a prediction accuracy of 7 milligrams a CGM profile. So actually the computer can learn and predict it. Similarly, we can predict, just like glucose, we can also predict blood pressure. So if you study blood pressure over 24/7 for 35 days, you can actually predict blood pressure also. Similarly, we can predict food response. For example, if Sunil eats a idli, I eat an idli, Ashish eats a idli, and Dr. Panda eats a idli, and Dr. Bensley eats a idli, some of our glucose may go up in green, some may have a yellow response, some may have a red response. It could be variable. So this food tolerance can be picked up by CGM and translated into evidence, and we can actually make decisions. What food to eat, have less idli, more sambar, what meal to cook, what combination, how often to do. And we can actually have very high accuracy on taste standards. So we can actually start reversing chronic diseases. Some people sleep less, some people eat fast, some people eat too much. So we can actually predict who is having what using technology. So with technology, you can reverse diseases, and you can use continuous machine learning, take in all the sensor inputs, whether it's CGM, blood pressure, ketone monitor, Fitbit, a body scale, all the blood work, and synthesize this information and all the big data, and then use all the nutritional database. For example, of the microbiota, macrobiota, gut microbiota, and all the medicines, and process this information through computerized networks or neural networks to get precise advice for nutrition, precise medication support, and precise inputs to the coach for sleep and activity. So this is very doable. And you can see that you can later on remove a lot of these gadgets. So we have done a RCT to show that reversal is a doable possibility. You can actually reverse using technology, eliminate medications. You can not only reverse diabetes, but hypertension, dyslipidemia, obesity, cardiovascular risk, renal risk, liver fat, pancreatic beta cells, insulin resistance, and inflammation all can be reversed. And all the metrics can be changed. So it's clearly possible to do remission and revision, and we can use this. And it's independent of BMI. We have published this data at multiple places, including at ADA this year. And we have shown that using technology, you can handle not only diabetes, but also obesity. And that is independent of obesity. So clearly we know that if you use and monitor 174 health experience signals with CGM, blood pressure monitor, ketone monitor, smart scale, Fitbit, Apple Watch, an app, and synthesize this and then give advice, you can actually use precise readings, member logs, blood reports, use machine learning, artificial intelligence, medicine database, and nutrition database to curate a plan supervised by coaches and doctors to help our patients. So remission is doable. Remission definitions are now available. There are challenges in the definition. I will not go into details of that. But at the center of our universe is the patient-centered care. Because we have so many gadgets, we have so many tools now, but patient is still the center of our universe. And clearly we know that we can digitalize, and we can clearly digitalize diabetes with patient and provider burden. We know that there are a lot of geographical accesses to care, but COVID broke that barrier. And clearly we now know that it is possible to use that. But digitalization also became overburdened during COVID times. We had a digital toxicity, I call it. Because, we were overloaded with too much of information. predominantly from a computer screen, from a television screen, or even from a mobile phone screen. And therefore, it is important that we need to send the right preventive messages. So it's a short talk, which Ashish told me, sir, talk only for 15 minutes. So I thought I must be brief. But my final take-home message is very simple, that we are living in a digital world. Diabetes care is getting more and more digital, but still we advise everybody to have 1 hour of digital detox. No mobile time, no WhatsApp browsing, no social media browsing, no television, no computer screen. We need to really do some, good amount of meditation for that. We need to sleep well and sleep on time. But the prevention mantra is eat less, eat on time, eat slowly, have a large breakfast, moderate lunch, and a light dinner. Eat the right food. Do a lot of physical activity. Try to do yoga. Try to do pranayam. Try to do some kapalbhati to burn your abdominal fat. Try to do Surya Namaskar. Try to sleep well and sleep on time. And most important, it is important that we just are not disciplined, but we need discipline with happiness. We need to smile. We don't need to get stressed out. I saw Ashish was so stressed out whether I am going to join him. So I said, I will join you live, because rather than sending him a recording, which looks very inanimate sometimes, I thought I would rather join him live, because I can see some smile on his face. Because if I can't join him physically, at least I thought I'll join him digitally and talk to him on the digital diabetosome. So I again reiterate that today we are living in best of times, but unfortunately we are blessed with worst of times. Despite of so many advances in diabetes today, I'm telling you a distressful fact. IDF Atlas published in 2019 said 4 million people died due to diabetes. IDF Atlas published in November of 2021 said 6.8 million people are dying every year due to diabetes. This is despite of all the GLP-1s and the SGLT2 inhibitors which are there. So mortality has actually gone up in diabetes. Why? Because we have not corrected the fundamental defect in diabetes, which is lifestyle. Type 2 diabetes is driven by lifestyle. And therefore, it's important that we need to be healthy and happy. And we need to embrace technology and use it intelligently, talk and do good science with our engineers, and ensure that we can make people living with diabetes, particularly type 2 diabetes, in a healthier and happier world with better outcomes. Thank you so much. And thanks a ton for all the kindness and goodness of yours. And I'm sure next time I'll be there in Jabalpur in person with you and enjoy some hospitality of yours. Thank you so much.
Thank you very much for joining live, sir. And I hope because of the Ganesh Chaturthi you are there, and that is very important, because due to God Ganesha's blessing we are here joined together. And thanks a lot for giving the message of digital detox. That is very important nowadays, because we are become irritable by use of more mobile and social media and all the things. So over to the chairpersons. Thanks a lot for excellent talk.
Must say, marvelous talk by the master. Just previously, Jayant Pandasa was stating that if you are below 50 and just be bit of tech savvy so that you can update yourself. But looking at sir, we can always say that age is just a number. And thanks for that one marvelous. And I can say it was a talk based on technology at glance. He has touched upon probably all the major aspects. Many things we learn from you, sir. Each time we listen to you. Thanks for that marvelous talk.
Thank you, sir. Thank you very much. And because of the algorithm which diabetes clinician follows, lifestyle modification, no one hits that mark as good as you, sir, because that was what was stressed in this lecture. Because of the new molecules coming up, we are all stressing at the bottom of that algorithm. No one stressed at the top of the algorithm, lifestyle modification. So you have talked really well on that. So thank you for the great talk and for the take-home message.
Yes, main 3 pillars are exercise, diet, and meditation. But patient wants medicine. So basic 3 pillars are missing. So thank you very much, Joshi sir, and thanks a lot Bensley and Sunil for chairing the session and gracing our event. And over to the next talk by Supratik. Our chairpersons are Dr. Parimal Swami and Vikram Chauhan. Parimal Swami sir has joined. Over to the respected Parimal Swami sir. He is consultant diabetologist and physician at Jabalpur Hospital and Research Center, and he is a very good academician. And over to Swami sir. Hello.
Hello. Can you hear me?
Yes,
Hello.
Yeah, now it is clear, sir.
Okay. So, it's in order to
Sir, your voice is cracking.
Okay.
Sir, your voice is cracking. Yeah.
Hello. Hello.
Yeah, you are audible, sir. Audible.
Now am I audible?
Yes, sir.
Yeah. So he's MBBS, MD, MRCP UK, FRCP Edinburgh. He is a fellow of American College of Physicians and he is fellow RSSBI. He is MS in endocrinology in London. Dr. SK and Diabetes Center and Endocrine. He is Salt Lake and Apollo Sugar, Kolkata. He has published 30 plus national and national articles. He is author of 5 books, and his special achievements include that he is a speaker at various national and international conferences, honorary chairperson, International Youth Summit, and SGLT2 Plus conclave. He is a part of organizing committee for ECP 2021, Diabetes India 2021, RSSDI Defeat Diabetes Task Force, National Scholar, and rank holder 10th board examination. So, with Dr. Sutik to deliver on diabetes.
Thank you, Chairperson, for all your kind words of introduction, and thank you, Dr. Ashish, for this kind invitation today.
Thank you, Supratik, for joining us.
Congratulations for the wonderful academic contents that you're having for this conference. As always, it was a pleasure listening to Dr. Shashank Joshi, and he's a maestro, and it was a pleasure to see Dr. Sunil Kota and Dr. Bensley and all our friends here. So I'm just going to need a second to upload my slides.
Yeah.
So, please give me a shout if the slides are seen, and I'm just going to put it onto a slide.
Yeah, visible. So Supratik is having very important topic, imiglamin. It is very new topic as our theme is new dimensions in diabetes and 360-degree control. So he has chosen an important topic. Let's sit back and relax and listen to his important talk.
Yeah, so I think it follows what Professor Joshi was saying. So we'll talk about a little bit of modulations of the mitochondria, and we'll take it from there. It's a very new molecule, and we are still understanding. Just to set the context, I wanted to say that globally, we see that there is a rise in the incidence of diabetes, and we know that by 2045, probably India is going to be the diabetes capital of the world, and the numbers are going to rise across the globe. So it's going to be a global problem. And we know that Indians are a different phenotype altogether. We have a lot more fat around the waist. So because of this visceral fat, we have a higher insulin resistance as compared to the Western counterpart for the same BMI. So in our circumstances, I think one of the things that needs to be addressed while we are talking about diabetes management is, of course, to address the insulin resistance. And over on top of that, you also have to talk about the beta cell dysfunction and how we can prevent that. So when we talk beta cell dysfunction, we know that it results from inadequate glucose sensing to stimulate insulin secretion, and therefore elevated glucose concentrations prevail. And the beta cell insults would include something like a cytokine-induced inflammation, obesity, as we were talking about, so weight reduction, moderate exercise, and then, of course, insulin resistance. And we know that because of the virtue of our genetics, we're predisposed to insulin resistance. And overconsumption of saturated fat and free fatty acids also are the results that might lead on to a beta cell insult. And a progressive beta cell decline in the function leads on to beta cell exhaustion, and it precedes the beta cell demise. This is the basic pathophysiology. You have the environmental factors. You already have the genetics for the Indian phenotype. and beta cell overstimulation leads on to hyperinsulinemia. And this is exactly what happens in the initial phases of diabetes. So circulating insulin levels is not a problem. It's only the insulin resistance that comes into play. And at this point of time, we need to address the insulin resistance in order to take care of this hyperinsulinemia. Otherwise, this will lead on to obesity and then finally beta cell exhaustion and type 2 diabetes. Insulin resistance is characterized by diminished response to insulin stimulation, resulting in failure of the target tissues to inadequately dispose of the blood glucose, inhibit lipolysis, stimulate glycogen synthesis, and inhibit hepatic glucose output. So these are the various mechanisms that lead on to insulin resistance. We can have increased reactive oxygen species. We can have impaired glucose oxidation, impaired fatty acid oxidation, metabolic inflexibility, or there might be a change in the endoplasmic reticulum mitochondrial upregulation that leads on to insulin resistance. And this will affect the white adipose tissues, the skeletal muscles, and liver. So let's look back and talk a little bit about mitochondria. We know that it's the powerhouse of the cell. And the most important fact about mitochondria that they're important for adenosine triphosphate ATP production, something what Professor Dr. Shashank Joshi was talking about just a few minutes ago. So mitochondria are also the key regulator of glucose-stimulated insulin secretion in the pancreatic beta cells. And we know that during the past decades, evidence has shown that mitochondrial function is closely related to various facets of diabetes. And it could be the pancreatic beta cell dysfunction, insulin resistance, obesity, and vascular complications of diabetes. So we have the two factors that we were talking about, genetic factors like the mitochondrial DNA mutations, the nuclear DNA mutations, or the common genetic variants, and the environmental factors like obesity, intrauterine malnutrition, or environmental pollutants. And both of them go on to cause a mitochondrial dysfunction. And this would lead on to a beta cell dysfunction. And the basic pathophysiology we had already talked about, but it involves impaired insulin secretion, beta cell failure, abnormal fusion and fission and autophagy, and insulin resistance, which is because of decreased mitochondrial DNA, increased cytokines, as well as various products of inflammation, etc. So that would lead on to diabetes. So how does the currently used hypoglycemics act? It might act at the level of the adipose tissue and skeletal muscles by increasing the peripheral glucose uptake, like the biguanides and the thiazolinitions. It can act at the level of the pancreas by increasing the insulin secretion, like, for example, the sulfonylureas, meglitinides, exogenous insulin. At the level of the kidneys by decreasing glucose reabsorption, like the SGLT2 inhibitors, or at the level of the liver by glucose introduction, like the biguanides and thiazolinitions, and intestine by reducing the glucose absorption, like the alpha glucosidase inhibitors. What's the need of the hour? So we need a comprehensive molecule which has a dual mechanism of action, and that is designed to increase the insulin secretion in response to glucose and also improve the insulin resistance. So wouldn't it be wonderful if you have both simultaneously, two mechanisms which simultaneously comes into play, which not only takes care of the insulin resistance, but also helps improving the levels of insulin in our circulation. So imiglemin seems to be the first of the group of oral tetrahydrotriazine compounds. And just to introduce the drug, it's approved novel drug for type 2 diabetes with differentiated mechanism of action. It was approved in Japan in June 2021. And by October this year, we're expecting a DCGI approval in India as well. And Japan is the first country in India to approve imiglemin. And it's supported by numerous preclinical and clinical studies. And it's the only oral compound with dual mechanism of action, which is designed both to increase the insulin secretion as well as improve the insulin resistance. So imiglemin is the first orally available anti-diabetic drug which simultaneously targets all three key organs of the body, i.e. the pancreas, the liver, as well as the muscles. Imiglemin targets the two main defects that are seen in the type 2 diabetic patients, i.e. pancreas, by increasing the insulin secretion in glucose-dependent manner, and also at the level of the muscles and liver by decreasing the excess production of glucose by liver while increasing the effectiveness of insulin or insulin sensitivity in the muscles. So here you see the dual mechanism of action. One, you have the increased insulin secretion in response to glucose, and on the other hand, you have improvement in the insulin sensitivity. The possible molecular mechanism by which imiquimod improves the glucose homeostasis would be increased insulin sensitivity, decrease in the gluconeogenesis at the level of the liver, increase in the beta cell function, increase in the mitochondrial function, and also decreasing the oxidative stress. So this is the basic mechanism of action. Here we see that we want to target two basic defects. One, we need to improve the beta cell function and beta cell protection. At the same time, we want to enhance the insulin action. And in doing so, we have the cellular metabolic pathway, which increases the nicotinamide phosphoribosyl transferase, and at the same time increases the nicotinamide adenine dinucleotide, and that in turn increases the calcium mobilization. So this is similar to what you have for the sulfonylureas. It partially inhibits the competitive complex 1, reduces reactive oxygen species formation, restores complex 3 function, and also prevents the opening of the pores, which are the permeability transition pore, and also increases the ATP generation. And in turn, leads on to improved beta cell function, which increases glucose-dependent insulin secretion, prevents the beta cell death, and also increases the function of the beta cells. It enhances insulin action acting at the level of the liver, as we said. It reduces excessive gluconeogenesis. It decreases steatosis, and at the level of the muscle by increasing the insulin signaling as well as stimulating the glucose uptake. So if you look at the PK/PD, the oral drug needs to be administered twice a day. The general recommended dose is 1000 mg twice daily. It has got very low protein binding and very low hepatic metabolism. Majority is excreted in the urine unchanged, and no drug-to-drug interactions has been noted with the metformin, sitagliptin, or cimetidine. No QT prolongation, no PK differences between the Caucasian and the Japanese, and no food effect at all. Half-life, plasma elimination half-life is 13 hours. Excretion is not metabolized and it's eliminated unchanged in the urine. So special populations like the renal patients, imiquimod is not metabolized, and that's why you need sort of a dose reduction. As of now, it is approved that it can be used in 1000 mg twice daily, up to an eGFR of 45. So so less than 45, it's not approved as of now. But one of the studies do say that between 15 and 45 eGFR, you can use it at a reduced dose of 500 mg twice daily. And if the eGFR drops below 15, then you can use it at 500 mg once daily. However, as of now, with the current prescribing information that comes from the innovator, it says that since there was no clinical trial that has been conducted in patients with moderate or severe renal dysfunction, less than 45, as of now, we do not sort of recommend the use of this particular molecule at an eGFR of less than 35. Hepatic patients is safe and well tolerated in patients with moderate hepatic impairment, and trials have not been conducted in patients with severe or Child-Pugh C liver dysfunction. Pregnancy should not be given. Lactation, consider continuing or discontinuing breastfeeding, taking into account therapeutic benefits, and transfer to milk if needed. What clinical trial experiences that we have, and the 3 different studies that came with this particular molecules at times 1, times 2, and times 3. So one was where you compare that with placebo, and of course you see that in times 1 study there was a bigger drop in the HbA1c to the tune of about 0.89 from a baseline, which was between 7 and 10 HbA1c. And again, if you look at the dose range phase 2b study, here the baseline was 7 to 10, and we used various dosages, 500 mg twice daily, 1000 mg twice daily, or 1500 mg twice daily. And you can clearly see in here, 1000 mg twice daily, drop was close to 1% HbA1c from the starting baseline. These are the baseline characteristics that were there in the phase 2b study. It was matched with the placebo. It's times 1, which is a comparison with the placebo, double-blinded placebo-controlled trial, which was a 24-week trial with 213 Japanese patients. Times 1 was observed to meet its primary endpoint, and what we got was a statistically significant drop in the HbA1c from the baseline as compared to the placebo, which was around 0.87. Safety and tolerability was good and very similar to the placebo. So times 2 was about the safety. So it was a 52-week open label parallel group times 2 study with 714 Japanese patients. And in this trial, 1,000 mg of imiclibin was given orally twice daily in combination with existing anti-hyperglycemic agents. So imiclibin here was added on top of the other existing OHAs. These were the results. There was a considerable drop in the HbA1c when added to the DPP-4 inhibitors, sulfonylureas, and even the whole range of anti-diabetic agents, except for GLP-1 receptor analogs. The imiclibin was observed to demonstrate robust efficacy benefits, especially with the DPP-4 inhibitors in particular. And also, as we know from the safety and efficacy data, there was no particular safety concerns that came up with this times 2 study, which was looking into the safety aspects as well. So times 3 was where it was added on to insulin for that matter. In 36-week open label extension period of times 3 study, 208 patients who completed the first 16 weeks of the study were treated with imiclibin as well as insulin therapy. And this was in particular the study design where patients were stable on insulin doses where then imiclibin was added in one arm, on the other arm they had placebo. And we see that there was a robust drop in the HbA1c from baseline, those individuals who were using insulin. The time course of glycated hemoglobin over a 52-week study period according to the groups. So here, imiclibin was added and was a robust drop. And then following which, again, you see as compared to the placebo, there was a bigger drop in the HbA1c throughout the study. Open label extension period showed a sustained mean HbA1c decrease from the baseline of around 0.64% in patients receiving imiclibin for 52 weeks and 0.54% in patients receiving imiclibin and insulin for at least 36 weeks. So major adverse drug events were very similar to the placebo. Just wanted to highlight a few things like the GI side effects was one of the most common ones, along with nasopharyngitis was one of the things that came up when being used with the other molecules. So hypoglycemia with monotherapy was very, very little. Incidence was 1 in 75 in a group, in the 500 mg group, 1.4% in the 1000 mg group, and 1.4% in the 1500 group. So as of the serious side effects, hypoglycemia, 6.7% may occur when used in combination with insulin or sulfonylurea or insulin secretagogues. Other side effects were very, very similar to the placebo and were of no major concerns. And just to highlight that these were the other side effects that we know with the known OHAs or other anti-diabetic agents. This, I just want to conclude with this particular slide that we know that metformin can address the insulin sensitivity. Sulfonylureas can cause beta cell stimulation. DPP-4 inhibitors, again, the incretin-based therapies are known to act on both the beta and the alpha cells. But imiclibin seems to be the only one which would sort of address both the insulin sensitivity as well as the beta cell stimulation. And that's why it's very, very unique and something that we are looking forward to using. So thank you so much for your kind and patient hearing, and I'd love to take any questions that you'd have for me.
Thank you, Supratik, for excellent talk. And over to Kanan. Are there any questions?
No, Asha, I couldn't be able to see any questions in the chat box.
So what is the future of this drug, Supratik?
Yeah, so we are still speculating. We're hoping that once it comes, DCGI approval is pending in October. We are hoping to get that in the market soon after. So after that, we'll try and place this drug. And it seems like a very promising drug in terms of, the mechanism is concerned. And obviously, we are looking forward to the real world data that we'll be generating from our own populations.
So thank you. Thanks a lot for giving the...
Supratik, very nice presentation, very comprehensive presentation about a new therapy. I think last year they have tried for the approval from DCGI, but it could not get through. So what were the causes? Why they could not?
Yeah, there were certain pending points that they had raised queries on, and they had been furnished. And they have, as of now, it stands that by October, we should be getting the DCGI approval.
And Japan is using this as it's a clinically approved molecule, like they are using it in their day-to-day diabetes practice?
2021.
Okay.
Yeah.
Okay. So I think you gave a very, very comprehensive account of this new molecule, and probably it will add to the armamentarium of our diabetes fighting army. And I'm hopeful that if this molecule sort of fulfills its promise, probably it can be used for the diabetes prevention or the reversal of diabetes also, looking into its pharmacokinetic profile, acting on both the aspect of type 2 diabetes, that is the beta cell dysfunction and the insulin resistance. So thank you very much for a comprehensive introduction of this profile. Back to you, Ashish, for the further proceeding. Thank you again.
Thank you so much. Thanks a lot for making the discussion more elusive, and thank you, Supratik, for excellent talk and bringing up this topic to the NDID. And Kanan, over to you.
Thank you so much. Thank you, Supratik sir, for the wonderful talk. And let us move on to the very interesting and important topic on the remission of type 2 diabetes or population level, the role of diet. For this, we have the esteemed chairperson, Professor Vasan Kumar sir. We know sir is the president and National RSSDI, the senior consultant physician and Apollo Hospital of Hyderabad. And another chairperson, Dr. Professor V. K. Bharatwaj sir, is a professor of MD Pediatrics and DM Endocrinology, is the founder president of Jabalpur Endocrine Society, the founder member Indian Society of Pediatric and Endocrinology, the founder member of Diabetes Society of India. Over to respected chairpersons. Ashish.
Yeah, Bharadwaj sir.
Chairpersons cannot come.
Yeah, Bharadwaj sir is there.
I couldn't be able to see the chairpersons.
Okay. Oh. So Kanan, you introduce Anjana.
Okay. It's a great pleasure and pride to introduce our own madam, respected madam, and daughter of our mentor and teacher, Professor V. Mohan sir, Dr. R. Anjana. Madam is a MD and a diploma dietitian from UK. She holds PhD, FACP, FICP, FRCP, and both the three important Glasgow, Edinburgh, London, and FAC also. He's a managing director of diabetology of Dr. Mohan Diabetes Specialty Center and vice president, Madras Diabetes Research Foundation, Chennai. His main research areas are prevention of diabetes, epidemiology, physical activity, translational research, and technology diabetes. And is PI and co-PI for several national and international projects also. She published nearly 300 papers in prestigious national and international peer-reviewed journals and delivered lectures in several national and international conferences. She received several awards, including the prestigious Young Outstanding Women Achievers Awards from the Tamil Nadu Dr. MGR Medical University, then Innovator from the Indo-UK Health Summit, the Tamil Nadu Young Scientist Award from Government of Tamil Nadu, the Shakuntala Amit Chand Prize from the ICMR, and several others also. She is a member of various scientific bodies such as API, IMA, RSSDI, ISPA, and DAS and EAS also. In 2020, she has been selected as the member of the WHO Salim Yusuf Emerging Leaders Program as a world-renowned leader in global cardiovascular disease research. And more than that, madam is more interested in Bharatanatyam and other classical dances also. Welcome to you, madam. Welcome to you, madam.
Thank you very much, sir, for that kind introduction. And thank you to Dr. Dengra for having me here. So I think I will share my screen now. Can you see this?
Yes, madam. Yes,
yeah, you can see this. Yeah, thank you very much. So I think the topic for
madam,
today...
Put in the presentation mode, madam.
Yeah, one sec. Let me do that. Okay now? Yes.
Not yet, madam. Yeah, now it's coming.
Okay, so the topic for today is remission of type 2 diabetes at a population level, the role of diet. So thanks once again, Dr. Dengra and this team for having me here today.
Thank you, Anjana, for joining us and gracing our event.
It's a pleasure. So, and I have no conflict of interest to declare. So if you look at the natural history of diabetes, we move from the stage of normal glucose tolerance, pre-diabetes, clinical diabetes, and then to the stage of complications. So thus far, we've been talking about how to control diabetes. We heard from Dr. Supratik about some new drugs that are coming in, prevent complications, etc. Then we started talking about how to prevent diabetes in the stage of pre-diabetes. How do we prevent diabetes? But today we're talking about something completely different. We're talking about for those who have diabetes, can you reverse them back to pre-diabetes or indeed all the way back to normal? That's what we're asking. So now, what is this definition of reversal or remission? The ADA defines remission as having an A1C of less than 6.5% for more than 3 months without any medication. So that is the definition that we'll go with. And what's the evidence that we have so far? One of the first studies on whether remission was possible in diabetics came from the Counterpoint study. So what they did here is, this was a small proof of concept study where they studied 11 people with diabetes and put them on a 600 kilocalorie diet. Now, just to put this in context, the average Asian Indian is eating something like 2,500 kilocalories a day. So from there to move to a 600 kilocalorie liquid diet was no joke. So they did this for a period of 8 weeks and looked at what happened to hepatic glucose output, the peripheral insulin sensitivity, beta cell function, etc. Pancreatic and liver fat content was also looked at. So this is what happened. Given here in the first panel is the glucose level. So you'll see week 1 to week 8 given below in the x-axis. Even in the first week, there's a huge drop in the glucose and it stayed flat. The red line there is the controls. Now, what happened to the liver? You'll see that the fat percentage came down slowly by week 2 and stayed down even lower than controls. In the pancreas, it took a little bit more time. It took 4 weeks for the fat to go away, but then again, it stayed almost equivalent to controls, and insulin sensitivity improved, and the first phase insulin secretion also improved, even becoming better than that was in the control. So that was the effect of the very low calorie diet. Then they went on to do the counterbalance study. The same UK group went on to do this. So here what they did, they divided diabetics into those with duration less than 4 years and then more than 8 years. So short duration, longer duration. They did the same thing for the first 8 weeks, but then they went into a weight maintenance phase for 6 months. But again, this was only 800 cals for the period of 6 months. Now, what happened here? In the first one, so this is the first column, and we're talking about weight loss here. So short duration is in green, long duration is in purple, and weeks are in the x-axis. So what's happening to weight loss? It's coming down very well. So whether it was short duration diabetes, long duration diabetes with 800 kilocalorie liquid diet, it's coming down really well. Weight loss approximately in the whole group was about 14 kilograms. Now let's go to fasting glucose. Now what happened to the short duration? So like we saw in the very first Counterpoint study, the sugars came down very well in the short duration and stayed down for the period of 8 weeks. Now what about the long duration? There are 3 types of people when it came to long duration. The first was similar to short duration. So that is the lowest line here, white dotted line, the lowest one. It came down, stayed down, similar to short duration. Then there was the second group of people for whom it came down, but it came down kind of reluctantly, slowly, kind of that way. Then there was this group of people for whom no matter what you do, the sugar just did not come down. Weight came down, but sugar did not come down. We then move on to this direct trial. This is from the US, large number of people, 280 or so. And again, here they went on to 24 months and they had the intervention versus control. What did they show? Now, all these bars are very confusing, but primarily what they showed, look at the lower panel. Here they showed the degree of remission is directly proportional to weight loss. So if you lose 5 kilos, this is the remission percentage, 5-ish%. If you lose 5 to 10 kilos, then it becomes 20-30%. If you lose 15 kilos, it's becoming 50-60%. And if you lose more than 15 kilos, you have about 86% remission. This comes down to about 70% at the end of 2 years. So this is a lot of variability here. So the more weight you lose, the more remission is possible. And again, there were differences between the short duration and the long duration diabetes. So what they said is remission is possible. That's what I've been showing you so far. But for a select group of people, maybe shorter duration with better C-peptides, more weight loss, and at least 10 kilo weight loss has to happen with a very low calorie diet for a prolonged period of time for this to happen. But we don't have much data beyond 2 years. Now, in a country like India, if I simply told you go on to a liquid 800 calorie meal replacement, is that something that a lot of people would agree to? Would you agree to it? So there are definitely barriers to people doing something like this in India. The Western style meal choices, having these protein bars and shakes and all, are not very culturally acceptable in our country. So we have to look at what will work for India. There's no population level acceptable macronutrient ranges for chronic diseases in our country. We looked at various surveys. We looked at NFHS, NNMB, NSSO. We weren't able to generate anything, and thus we went to the ICMR INDIAB study, or India Diabetes Study. So this is funded by the Indian Council of Medical Research and the Department of Health Research, Government of India. And the aim of this particular manuscript was to provide optimal macronutrient recommendations for remission and prevention of type 2 diabetes using Indian dietary data at a population level. We're talking about 1 billion people here. Sorry, this is not except it's published now. This slide is a little old. It is now published in Diabetes Care.
Welcome to the workshop, sir.
So now what did we do? We have data from whole of the country. There's 30 states and union territories. And we had dietary data in 1 in 5 individuals. Okay, so let's look at these numbers. Now we had 113,000 in the beginning, of which 30% was urban and 70% was rural. That is according to the census of India. Every 5th participant was about 22,000. From there, we had to take dietary available data was in about 20, remove all outline. You have to remove known diabetes also. We're only looking at newly diagnosed diabetes here. So we had about 19,000 individuals for whom dietary data has been analyzed in this country. You can see the very equal distribution between men and women and the absolute census distribution. Our study population lies on the census lines exactly. So just telling you that we have a very representative population in the study, which is representative of India as a whole. So what did we do? So in the beginning, I'm going to tell you, I'm not a mathematician. I'm a very simple diabetologist, and I don't understand these very complex equations. This was done by Dr. Sheshadri from Kalasalingam University. But in a nutshell, what we did is we took all the data from INDIAB. I told we had 19,000 individuals, divided them into 4 categories. So you have the newly detected diabetes, NDD, you have pre-diabetes, so this is from the natural history, right, that I told you, NGT, pre-diabetes, diabetes. Now, in these categories, we then further substratified urban-rural based on sex, based on physical activity level, BMI and age, because you can't have dietary recommendations for the same across different age groups, BMI, etc. Then we used what is called as a quadratic programming optimization. So what we do here is that we ask the question. So the equation is given on top. You adjust for everything that is non-dietary, okay? And then only for the dietary factors, you ask the question, what is the optimal combination of dietary macronutrients like carbohydrate, protein, etc., that will push 80% of the population into remission in the NDD category, into normalcy from the pre-diabetes category. So we had 2 categories of remission. One is for those with newly diagnosed diabetes, and the second is for those with pre-diabetes. So 2 reversal in 2 categories. Then we had 2 for progression. So from NGT, who would go to diabetes, from pre-diabetes, who would go to diabetes. So 2 progression categories, 2 regression categories we had, and we had to find the nutrient recommendations in each of these categories. So this is what we found. These are the overall changes that have been published. So the current intake in the population, carbohydrate is between 60 and 70% of everything that the Asian Indian eats. So it can be rice, it can be roti, it can be noodle, pasta, whatever you put, there is 60 to 70% of carbohydrate. Protein is about 10-ish%, maybe lower in some places. Fat is about 25% and fiber is 3.5%. This is what is currently happening. Now, for remission, okay, so this is the remission slide for those with NDD. You go from 49 to 54. So only about 50% of everything you eat, carbohydrate is allowed. Then take up the protein to 20%. Fat stays where it is. Fiber kind of doubles to 6%. So this is what is needed. And then for pre-diabetes, a little relaxed. You can go to 55%. Protein stays the same. Fiber doubles, and fat also is little bit more allowances there. So this is the remission kind of macronutrient combination that we have found. And does it change for urban and rural, active versus inactive? Yes, slightly it does go change, not much. So what does this say? If you're in a rural area, slightly more carbohydrate is allowed. If you're very active, then up to 58% carb is allowed because you are possibly burning it. There's not too much difference with the fat, fiber, and protein. So it's the carb that keeps changing. For men and women, again, men 1 or 2% more than women is allowed, and younger people are allowed a little bit more. Similarly, if you are thinner, you can have a little bit more. If you're overweight or obese, the carb becomes very, very tight. And you can see the fat recommendations also move and protein. Now, so what about pre-diabetes? That is for NDD that I showed you. Similar, very similar numbers. Only thing is that I told you up to 55%. In a diabetic individual, we say 50, not more than that. Here, up to 55, 5% more is allowed. Again, differences follow the same kind of data. It goes like urban little more, active little more, men more, younger more, and thinner more. Allowance is allowed, calorie, carbohydrate, and fat. The last part is about prevention of progression. And again, now we have two categories. We have the normals and we have those with pre-diabetes. So the one on the left here is the pre-diabetes and the right is normal. So what happens here? Here, up to about 60% carbohydrate. So these are people who don't have diabetes. We're talking about healthy lifestyle prevention of progression. So 60% up to that carb. If you have pre-diabetes, comes down to 57%. Fat stays at about 24%. Protein is at 20%. That's an easy number. Fiber is at 6%. So again, that's an easy number. And allowed fats, the good fats, as you can see here, the nuts, dairy, all of this is for prevention of progression. Right. So I'd like to conclude by saying that for the first time, we've looked at population-based approaches for both remission and prevention of progression of type 2 diabetes. We need reduction in carbohydrate calories and adjustment in the protein increase. We also help in prevention of progression. And again, there, the main thing is the protein intake going up with differences based on activity, BMI, etc. Thank you.
Thank you, Anjana, for excellent talk. Over to Kalan.
Thank you, Dr. Anjana Bada, for the wonderful, excellent talk. You have given a wonderful insights on the main topic of remission of diabetes and also regarding the population-based approach, especially the urban and rural population. You enlighten us like anything, but thank you very much for the updates. Thank you very much. So without much wasting time,
for the new researchers, those who are doing the job in small towns, and how they should go ahead for the getting the data of the prevalence or any incidence of diabetes, because in the smaller towns or in the nearby villages there are missed cases. So what message you should give to the doctors in the small towns?
So the message, did you say messages for small towns doctors?
For getting the data of the patient who are not being diagnosed.
Yeah, so to get the data, one has to do screening, right? But for the diet prevention and thing, it's the same. I've shown you for rural versus urban. So you'll be probably in the peri-urban rural area you're talking about now. Generally, it's about, if for a diabetic, stick at 50% carbohydrate and increase with protein. See, the problem if you don't bring the protein is that the minute you decrease the carbohydrate, fat will go up. Now that is unhealthy. So that is the one message that we have to go. If you decrease carbohydrate, you must replace with protein. So that is the one small message that we say. For everything else, up for NGT and all that, you allow a little bit more carbohydrate activities and things are good. Screening, the only way to find out is to screen. So the way to get data is to screen and collect and get data.
Thanks a lot for an important message. And you and Dr. Mohan are doing excellent epidemiological studies for India, and you are getting the data. And that's why we are managing the patients rightly now, because you all are giving the numbers and the figures what we help, like the HbA1c and how the other screening helps. So thanks a lot for giving your excellent insights.
Pleasure. Thank you.
So over to Karan.
So thank you, madam. Shall we move to the next topic? Now we have a very interesting and important topic, which is routinely, we will say, routine clinical practice. How to manage the hypertension diabetes. What are the new things to be understood? What are the new things that to emerge? For this, we have wonderful chairpersons, Dr. Rajesh Jain and Dr. Sushil Patel. Rajesh Jain is the consultant diabetes and director of Jain Hospital, Kanpur. Dr. Sushil Patel, I think, is a diabetologist at the Ascar Diabetes Center from Vadodara. Over to you, chairpersons.
Thank you, sir, for a kind introduction. And as we are right now discussing the newer modalities in the treatment in the diabetes in this conference, I hope that all of you are enjoying this conference. So I request my co-chair, Dr. Rajesh Jain, sir, to introduce our esteemed speaker, Dr. Anuj Maheshwari, sir.
Rajesh, please be brief while introducing me.
Yeah, sure.
So may I get more time to talk?
Sure.
Okay, sir. Go ahead.
Actually, I know personally Dr. Anuj Maheshwari very well, so I don't need all these to read for him. He's a well-known diabetologist in Uttar Pradesh, and he's leading India in international forum like American College of Physicians as a governor. And he has done a lot of work on UPDCon in Uttar Pradesh, and still it's very active organization in Uttar Pradesh. And he has the opportunity to organize RSSTI in Lucknow and the DIPSI conference. And he's an international man in diabetes and representing India all over the world. So this is what I have to say about Dr. Anuj. So now, Dr. Anuj, you can start your session. Yes.
Thank you.
Come on, thanks for accepting the invitation. Thank you.
Thank you, Ashish, and thank you, Dr. Kannan. Good to see you here. I'd like to share my screen.
Welcome, Anuj, sir. Welcome.
Yes. Hope you can see my screen.
Put the full mode, sir. It's no okay, sir.
Okay. So in next 15 minutes, I shall be trying to finish the hypertension in diabetes. What is new? It's really a good topic, that what is being done out of what is new. We all know that diabetes and hypertension constitutes a twin epidemic, which are giving a compounded enormity. Means 1 plus 1 is not going to be 2, it is going to be 3. And each perpetuates the other. What is new, if I can enumerate what has been new in the recent years? The first thing is that we got a new cutoff for the diagnosis of hypertension. We got a new cutoff suggestion for the target management of the hypertension in diabetes as well as out of diabetes also. We have got few new preferences of medicines, especially in the settings of diabetes. Combination therapy has been well recommended by multiple organizations, recommending authorities and guidelines across the world. Circadian rhythm impacts hypertension. This was well known to all of us, but how can it play an important role in management of hypertension? Monitoring of hypertension has not been simply on clinical blood pressure checkup. Now it has been shifted towards ambulatory blood pressure monitoring or home blood pressure monitoring. And diabetes, hypertension is a salt-sensitive hypertension. Very few of us realize it and know it. The new recommendation says in adults with diabetes and hypertension, antihypertensive drug treatment should be initiated at a blood pressure of 130/80 mm of mercury or higher, with a treatment goal of less than 130/80 mm of mercury. This has been given by American Heart Association and American College of Cardiology joint guidelines in 2017. Now come on to the history of the hypertension when the management of the hypertension has started. We all know way back in 1942 when American President Roosevelt has died, he was having a stroke, and before the death of his before the death, he has a day before the death, he had been found to have a blood pressure more than 200, which was declared by their physicians normal. So it was the GNC 4 and 5 which said that 160 or more than that blood pressure is only required to be treated systolic. 150 or more than that systolic blood pressure is required to be treated by GNC 6, and 140, which were being followed by all of us few days before and as of now also, has been given by GNC 7 and also supported by the International Society of Hypertension as well as American Society of Hypertension. That was the 140 mm of mercury systolic blood pressure. Later on, Sprint in 2015 came up with a weird recommendations of the 120. In fact, it has not been recommended to keep lower than 120, but it said that 120 is the ideal blood pressure for a complication-free life. Now, later on, 130 has been given by the American College of Cardiology and American Heart Association in 2017 that 130 systolic blood pressure is the cutoff mark to treat. As far as the 120 recommendation of the Sprint is concerned, it has been measured in a very ideal situation. That's why it was coinciding with the casual clinic systolic blood pressure, which was at higher. So 120 was coinciding the casual clinic systolic blood pressure 136 and 140, while the diastolic blood pressure 76 of the Sprint was coinciding with the casual clinic diastolic blood pressure between 82 to 84. So new classification which has been developed by ACC and AHA combined 2017 says that normal blood pressure is called when you are keeping it less than 120 and less than 80 of the diastolic. It would be called elevated if the systolic blood pressure is between 120 to 129. And elevated blood pressure category has only been given for the systolic blood pressure. It has not been given to the diastolic blood pressure. Hypertension is stage 1, systolic between 130 to 139 and 80 to 89 of the diastolic. Hypertension is stage 2 if it is crossing 140 or at equal to the 140 systolic, or 90 diastolic or more than that, called stage 2 hypertension. Even in 80 years individuals or more than that, the cardiovascular events has been shown to be bringing down significantly if the blood pressure has been kept at less than 120 and 80. So this myth has been removed by these organizations that higher the age, the blood pressure can be given the liberty to keep on the higher. And in fact, the concept of the arterial stiffness is also not being putting up any effect on these recommendations. So during follow-up of the 6 years, we could reach to the we could reach to the conclusion that even 80 years or more than that, blood pressure should be brought to the almost normal level, ideally 130/80. And if possible, 120/80 also. The blood pressure and cardiovascular disease risk in pre-hypertension has been studied in a strong heart study. Also, it has been seen it increases the cumulative incidence of the cardiovascular risk once a person reaches into the pre-hypertension. So obviously, the pre-hypertension is also the area of the risk. We all know that diabetes is the equivalent of the cardiovascular risk. So we know that diabetes is causing the cardiovascular risk even when it is alone. But once the diabetes and pre-hypertension are together, they are actually keeping the compounded risk that is the highest of all pre-hypertension and diabetes, what you can see here in this slide. So percentage chance of the cardiovascular events in 5 years if a person is not having diabetes can be reflected in this picture. But once a person is having diabetes, it changes the scenario and it's reflected like this. So majority of the cardiovascular events occur with blood pressure less than 140/90. This has been wonderful and very weird kind of the observation has been put in the editorial of Jash. And what we could see that 140/90 is the cutoff for the blood pressure correction, but most of the cardiovascular events are occurring when the blood pressure is lesser than about 63% cardiovascular events are occurring once the blood pressure is being maintained less than 140/90. Only 37 are being maintained 140/90. What does this give this message? That although we are capable enough or we have been successful in putting up our patient or keeping our patient almost around 140/90, we do our best 140/90 to keep, but those who are not really being given the target blood pressure, they usually fall prey of the cardiovascular and stroke complication. The new hypertension guidelines has been supported by the Indian data in a Mumbai cohort study, and which said that if the blood pressure range is shifting from 120 to 129 to 130 to 139, the risk adjusted hazard ratio for the risk of death and ischemic heart disease is shifting only from 1.16 to 1.19, which is not much. But once it is a matter of stroke, we see that it is a big jump. It shifts from 1.16, which is in the 120 to 129 range of the systolic blood pressure, to the 1.73 if the systolic blood pressure lies between 130 to 139, which is a matter of great concern. So association between systolic blood pressure and diastolic blood pressure is well shown in the for the CVD risk in this particular slide. Several meta-analyses have reported a gradient of progressively higher cardiovascular risk going from normal blood pressure to the elevated blood pressure to hypertension. Here you can very well see about the cardiovascular mortality, stroke, coronary heart disease, myocardial infarction, the increasing trends of the risk. So let's come on to the BP goal. It has got the U-shaped relationship where we can see that least amount of the risk is at the 120 to 130 range of the systolic blood pressure. Even if it goes further lower, then risk increases, whether it related to the primary endpoint or it is related to the CV death. So blood pressure lowering for the prevention of the cardiovascular disease and death, there has been a review and meta-analysis in which it has been identified that 123 studies has been put up in this meta-analysis, including the more than 6 lakhs patients, and it shown that every 10 mm mercury reduction systolic blood pressure significantly reduces the risk of major cardiovascular disease events. At the same time, it also inferred that in the support of strong lowering blood pressure to systolic blood pressure less than 130 mm of mercury. Here you can see the brief description of every 10 mm mercury reduction in systolic blood pressure is bringing down 13% of the all-cause mortality, and it is showing the strong support for lowering systolic blood pressure less than 130. Even at the age of 75 years, we had the evidence that benefits are getting more with the stringent blood pressure control or intensive blood pressure control, may it be related to the primary outcome or all-cause mortality. So BP threshold has been, as well as goal, both has been given for the pharmacological therapy to be initiated almost 130/80 for all kind of the clinical condition, except if there is no clinical CVD and 10-year atherosclerotic cardiovascular disease risk is less than 10%, then you are having a liberty to keep the BP threshold 140/90 instead of 130/80. And second one is the secondary stroke prevention, where you can see that 140/90 is permissible BP threshold for the diagnosis. So new target blood pressure and new cutoff for the diagnosis is 130/80 mm of mercury. Multiple antihypertensive agent may be needed to achieve the desired target. Let's come on the new preferences of the medications. For primary drug treatment, hypertension, any of the following drug can be used as an initial choice as per the ACC/AHA. And beta blockers are listed out as secondary agent and they are not included as primary. So consider beta blocker. The recommendation of the European Society of the Cardiology in 2021 has come up at considering the beta blocker as any treatment step when there is a specific indication like heart failure, angina, post-MI, atrial fibrillation, or younger women, those who are planning pregnancy. Under primary agent, chlorthalidone is preferred on the basis of prolonged half-life and proven trial reduction of the CVD. The important thing what has been observed in relation to the diabetes, that certain drugs are used in the hypertension management are making the person hyperglycemic. It has been shown that about all-head trial has shown that 8.1% of the incidence of the new onset diabetes after the 4 years uses of the lisinopril, and 9.8% were the amlodipine, and 11.6% was occurring on new onset of the diabetes after 4 years uses of the chlorthalidone. Beta blockers has also been found to be causing the new onset diabetes mellitus. So now the question arises, does choice of antihypertensive drug matters? Yes. Preference for the combination therapy has been suggested by the International Society of Hypertension in 2020, which said even from the day one, once your patient is diagnosed, you can start with the dual drug therapy instead of starting on the monotherapy. You can use the lower dose combination, but if you will start in the dual drug therapy, chances of getting correction earliest would be more. And there has been a recommendation of the ACE inhibitors to be combined with the calcium channel blockers as a first preferred therapy. In the condition of the diastolic hypertension, obviously the diuretics becomes a better choice, but on step 2, you can go for the dual full dose combination if your patient is not getting good control on the dual low dose combination, and later on you can move forward for the triple combination. Finally, if the patient is on the resistant hypertension, the spironolactone can be added to. It has been seen in multiple trials which has been done in the past that most of the hypertensive patients are requiring the multiple drug therapies, may it be UKPDS, may it be ABCD, MDID, HOT, ASK, IDNT, all have shown most of the patient, those who has got control on the antihypertensive therapy, they were 2 or more. So that's why the dual therapy or multiple drug therapy has been well recommended by most of the organization nowadays. All-cause mortality has also been found to be reduced by the perindopril indapamide combination. And as far as the advanced trial is concerned, it has preferred that ACE inhibitors to be combined with the thiazide like diuretics as an excellent first-line agent, because it gives a better hypertension control, reduces hypokalemia, cardioprotective, as well as it is making a better adherence. Hypertension in diabetes has also been studied in the accomplished trial, and amlodipine have been found to be superior to the hydrochlorothiazide in combination treatment with an ACE inhibitor. Cardiovascular mortality has been found to be significantly bringing down by the perindopril and amlodipine combination. It was 24% reduction in the cardiovascular mortality as compared to the atenolol thiazide combination. The correction of the hyperglycemia controls the hypertension, well known. If you are choosing a correct anti-glycemic drug, that also plays a good role. Although hyperglycemia correction itself plays a good role in correction of the hypertension also. Means if you are taking care of your blood sugar, patient of your blood sugar, then probably your hypertension of your patient would also be well corrected. But in conditions, if it is not, then you can choose wisely. Like if you are choosing the SGLT2 inhibitor, apart from vasodilating effect, these drugs are directly inhibiting the natrium hydrogen exchanger 3 in the proximal tubule, resulting in the blocking the reabsorption not only of the glucose but also of the sodium, which is promoting the natriuretic activity and causes the loss of sodium with the molecule of the glucose while taking care of the hyperglycemia. So we have seen that effects of the SGLT2 inhibitor on HbA1c, body weight reduction, systolic and diastolic blood pressure in various studies. Circadian rhythm and its importance in the managing hypertension has also been well studied, and it has been found that morning hypertension is more injurious and it is playing a bigger role in developing the nephropathy and retinopathy and other microvascular disorders. In diabetes, especially the big BP, has a specific characteristics. Usually it stops dipping many of the time. Normally in a normal person, 10 to 20% dipping takes place in the night time from the daytime. But in diabetes, this dipping either gets lesser or is lost. That's why the diabetes blood pressure becomes more difficult to handle. So a lot of studies has been done on the circadian rhythm of the blood pressure. I'm not going to the detail of all of them, but I will share you one important thing, that sleep heart rate and albuminuria were a strong predictor have been found of the mortality, and sleep heart rate and dipping and ambulatory arterial stiffness index has been proven the prediction of the risk, especially in the patients of hypertension. Why should we do ambulatory blood pressure monitoring or home blood pressure monitoring in diabetes? Because systolic hypertension is more common in diabetes, which is stronger predictor of the cardiovascular event. 65% of the type 2 diabetes has systolic hypertension. Diabetic patients are more likely to be non-dippers, and therefore office BP measurements do not reflect a real CV risk. White coat hypertension seems to be less frequent, and masked hypertension is more frequent in diabetic patients, and it can only be caught with the ambulatory blood pressure monitoring. Depression is more common in diabetes, so adherence is problem in diabetic patient, and clinician inertia is another big problem because we always remain focused for the glucose control instead of the blood pressure control. So non-dipping conveys the worst prognosis regardless of the 24 hours blood pressure, and absence of normal dipping and dipping magnitude predicts mortality in hypertensive patient. Diabetes is a salt-sensitive hypertension. Diabetic patients are believed to have salt-sensitive hypertension with high glomerular blood pressure and a flatter pressure diuresis curve. Hyperinsulinemia caused by insulin resistance is also involved in accelerating the reabsorption of sodium from the renal tubule, and excessive salt intake inhibits the nocturnal blood pressure reduction. That is the biggest problem and unique thing with the diabetes. So take-home message for this particular talk: hypertension management mitigates the vascular risk in diabetes. Therefore, BP should be checked every visit. Try to catch them early. We can start lifestyle modification even at times when the blood pressure crosses 120/80, because this is the right time. Loss of the night dipping, nocturnal hypertension, mass hypertension are more commonly seen in the diabetes. Therefore, ABPM or home blood pressure monitoring should be preferred method of monitoring blood pressure. Many recommendations are favoring to use cutoff of 130/80 for both diagnosis and treatment. Though we still need to gather scientific evidences to support, but keeping in mind our own population, which is more prone to develop the metabolic diseases and their adverse outcomes are more occurring in the Indian population, it would be a very good idea not to allow blood pressure crossing 130/80 since from the very early of the life. Approach each patient individually. There are recommendations to start treatment with combinations from very first visit together with lifestyle modification. Attempt to offer the best of available treatment options without compromising patient safety. Thank you very much for your kind listening.
Thank you very much, Amit, for giving us an insight on diabetes and hypertension, and it is very close to your heart. And you are definitely doing a lot of awareness program on hypertension in all over India. Over to the chairpersons.
Yeah, I think this is a very important lecture.
Yeah, Rajesh, unmute.
You are muted, Dr. Rajesh. You have been muted.
Yeah. Actually, Dr. Anuj, wonderful presentation, and it was very clear that in diabetes you have suggested AC inhibitor and calcium channel blocker, which is not highlighted in every events. And moreover, the primary healthcare physician writes ARB with the calcium channel blocker as a primary prevention for hypertension in diabetes, and which is logically wrong. Okay, so I want to highlight this particular point, that we should try first of all the AC inhibitor with calcium channel blocker or diuretic with triple combination also, as you already suggested, that all-cause mortality is lower in diabetes, in hypertension.
Dr. Rajesh, as far as the recommendations are concerned from various organizations, they say that either you can start with the ACE inhibitors or ARB, depending upon the level of blood pressure, and you can combine it with the calcium channel blocker, even from the day one also. Although recommendations and guidelines are not our country specific, so we cannot say that 100% it would be applicable to our own country, but many of the people are really, as you have said very rightly, that many of the primary healthcare physicians are not getting these guidelines. We are not reaching to them with these guidelines of the International Society of Hypertension as well as ACC. And in fact, many of the guidelines are also having the contradiction in themselves also. So this is also creating a lot of confusion in the prescriber, which to follow or which not to follow. That's why I tried to resolve all those confusion in my talk, giving the reasons for each and everything what I said there.
Thank you, Dr. Anuj.
Thank you.
So thank you very much, Anuj, for joining us and blessing the event. And Soon we will meet.
Dr. Ashish, sorry to interrupt.
Yeah.
I have a quick question for sir, Dr. Anuj Maheshwari, sir.
Yes, please.
Good evening, sir. I would like to learn from you why most of the diabetes persons are salt sensitive. What is the mechanism behind that?
Please repeat your question.
Is it just hyperinsulinemia?
Sir, please repeat your question.
Yeah. Why you mentioned in one of your important slides, diabetes is salt sensitive hypertension. That is the caption of
diabetes is
salt sensitive.
Yes. Diabetes is
why persons with diabetes are very salt sensitive?
Yes,
that is what I want to learn.
Yes. There are multiple reasons that diabetes is having the salt sensitive hypertension, because it is directly related to the insulin resistance. You very rightly recognize that hyperinsulinemia is one of the association with this because of what is hypertension becomes the salt sensitive. And it has also been seen that not only in the diabetic, if we go with the Indian subcontinent, in Indian subcontinent, majority of the patients are having the salt sensitive hypertension. Out of the India and European as well as in the American subcontinent, we can see many people, those who are having salt resistant hypertension. Salt resistant hypertension means if they are taking the excess of salt, it is not causing their blood pressure rise. But in India, we are having this salt sensitive hypertension. In India, not only in India, but also in China, but also in this is for two important reasons, because not only it is because of the insulin resistance, but also it is because of our specifically kidney reasons, in which we see that less of the potassium is lost from our kidney. That's why SGLT2 inhibitors is working more in our better in our country as compared to the Western people. Western population, it is reducing only 0.5 HbA1c, but in our population it is reducing very well HbA1c, maybe not any study is there, but maybe sometime 0.8 and 1 HbA1c reduction we can see with the SGLT2 inhibitor, because it creates a loss of the sodium as well as with the glucose molecule.
So besides this, do you agree that any activated sympathetic nervous system, I mean, it's disproportionately activated in many of the persons with
sympathetic nervous system, sympathetic overdrive remains one of the important reasons in Indian population, but it comes little later. It is not a thing which is associated since from the very beginning. As far as salt sensitive hypertension is characteristic of the Indian population, it is a characteristic of this people, those who are living in, especially in the subcontinent, and it is this characteristic way more reflect in the diabetic individuals. And as far as the sympathetic overdrive or sympathetic nervous system dysfunction is concerned, it comes later once the diabetes remains with us for a long time.
Thank you very much. It's a great answer. Thank you.
Thank you, Chandani sir, for making it an interactive session. And over to Kanan.
Thank you, Anuj, for the wonderful talk. We enlightened and entertained for the talk. We have been gaining a lot of information, knowledge from you, Anuj sir. Thank you very much. So let us move on to another important.
Thank you.
Yeah. We have more another important topic on HbA1c interpretations. We know that HbA1c is an important golden tool for diabetes management and prognosis and other things also. But there are certain pitfalls and variations. For this, we have excellent chairperson to chair the session, Dr. Alka Gandhi and Dr. Ashish Gopal. Madam is a consultant diabetologist at Namaha Hospital, and Dr. Ashish Gopal, MBBS, MD Medicine, and is a consultant in Saral Diabetes, Obesity and Thyroid Clinic. Over to you, chairpersons.
Thank you, Dr. Kannan, and thank you, Dr. Ashish, for this opportunity. Congratulations at the onset.
Hi, Gopal. Hi, Ashna.
Hi,
Ashish. Hi. So, over to chairperson.
So, yes, we have an interesting topic now. Yes. So, we have a very interesting topic now. We all know the role of HbA1c in diagnosis and management of our diabetes patient, but there are certain pitfalls, and we have to remember certain important points while we interpret this HbA1c. And to discuss this, we have with us a very prominent faculty in diabetes, that is Dr. Rakesh Sahai. He is an MD, DM, FICP and FAMS. He is professor and head of department, Osmania Medical College and Hospital, Hyderabad, and he's a consultant endocrinologist at Sahai's Endocrine and Diabetes Center, Amarpet, President Endocrine Society, Vice President South Asian Federation of Endocrine Society, and has many awards and publications to his credit. Welcome, sir, and
Welcome, Dr. Rakesh. Kindly unmute Dr. Rakesh, sir.
Sorry, I was muted. Sorry. Thank you, Dr. Ashish, for inviting me to be here, and thanks to chairpersons for the kind words of introduction. So the topic that I'll be speaking of in the next 15 minutes or so is about pitfalls in interpretation of HbA1c. So HbA1c, as we know, is a very important test used in the management of diabetes. Is my screen visible?
Yes, visible, sir.
Yeah. So thank you. So so as we all know about the importance of HbA1c, it is well known that it is one of the most important parameters used for monitoring control of diabetes. These are all the terms that I'll be using, but basically what I'll try to do in the next 15 minutes or so is discuss initially about the basic aspects about HbA1c, what is HbA1c, what are the components, and discuss how the measurements are done and all that. Then quickly discuss about the problems that can be there in interpretation of HbA1c and how we are moving forward. We have a lot of other sessions which are going to discuss about CGM and other things which are looking beyond HbA1c. So my job will be basically to discuss about HbA1c only. So as we all agree that HbA1c has been a very good standard biomarker for glycemic control that has been used for many decades now. And it became commercially available in 1978, and the ADA first started recommending the use of this in 1988. And in 1993, what happened was the landmark DCCT's trial, which actually showed that glycemic control does make a difference in patients with type 1 diabetes, and then subsequently the UKPDS trial, which showed that again that glycemic control is very important for people with type 2 diabetes. Both of these studies relied heavily on the HbA1c to show the correlation with the complications of diabetes, and also the fact that good glycemic control does bring about a reduction in the risk of complications, and that was based on the HbA1c only. So HbA1c became a very important measure of glycemic control after the publication of the results of these two trials. Now, beyond glycemic control, HbA1c has also been used as a diagnostic test for diagnosing diabetes. In 2010, ADA started recommending this as a diagnostic test. Whereas earlier there used to be a lot of debate on that, but it was not recommended for diagnosis. But now from 2010, ADA has recommended that HbA1c of more than 6.5 can be used as a diagnostic criteria for the diagnosis of diabetes. And therefore, from then on, we are using it both for the diagnosis and for the management. Now, 6.5 has been used as a cutoff because it correlates very well with the current cutoffs of fasting of more than 126 and a 2-hour value of more than 200, which are the plasma glucose cut points, and this correlates very well with the HbA1c value of 6.5, and that's the reason why this has been used as a cutoff point. Now, as a diagnostic test, it has certain advantages, although there's a lot of disadvantages in a country like ours where there's standardization is an issue. We all struggle with using this as a diagnostic test. But when you have a reliable assay available with the labs all standardized, then what happens is that the advantage is that it provides a better index of overall glycemic exposure and the risk of long-term complications, because it does correlate with the long-term complications. It offers less biological variability and pre-analytical instability, which happens with the blood glucose values. And it is not also affected by perturbations which can happen because of acute illness or stress. So So very often when you have stress-related hyperglycemia, we look at HbA1c because HbA1c tells us how the glucose values have been in the previous 3 months, and that is what we rely on in such situations. So here in all these situations, HbA1c is going to be a better diagnostic tool, and it is also convenient. It doesn't require any particular timing, and that's the reason why HbA1c stands out as a good diagnostic test also. Now coming to its role for monitoring, as we said, the UKPDS and DCT closely use this, widely use this test, and it represents, and what is understood is that it represents a weighted average of the glucose levels during the preceding 3 months time period. And if you look at how the structure of the hemoglobin is, you can see that total hemoglobin is made up of 97% of hemoglobin A and 2.5% of A2, and F is 0.5%. Now hemoglobin A itself has got A0 and A1. A1 is just a minor component, 5 to 7%, and amongst the again you have got A1A, A1B and A1C. So what we are seeing is the A1C component, which is the one which is non-enzymatically glycated by the glucose levels, by non-enzymatic reaction of glucose with the A1 with the A1C component, and that component is what is measured. That gives us a indicator of the average glucose levels. So what we see is that we see that you have this A1 is composed of A is itself composed of A1A, A1B, A1C. Of these, A1C is the most abundant minor hemoglobin component, and it is A1C is formed when the chemical condensation of hemoglobin and glucose occurs in the presence of high concentration of glucose in the erythrocytes. This process occurs slowly, and it's related to the concentration of glucose, and it is also related to the lifespan of the RBC, which is on the average 120 days. Furthermore, the A1C formation is directly proportional to the average glucose concentration, as I mentioned, and it also correlates with the lifespan of the RBC. Now, there are two steps in the formation of the HbA1c. One is the non-enzymatic the condensation of glucose with the A1C molecule, and the other one is that after that it undergoes a amidori rearrangement, leading to formation of stable ketoamine. So once that happens, then it remains stable till the lifespan of that RBC is there. So that's the reason why it doesn't. In the sense, it gives a better time integrated average. The amount of HbA1c formed depends on the ambient glucose concentration and the time to which the hemoglobin is exposed to the glucose, closely linked to the erythrocyte lifespan also. So these are the parameters upon which the HbA1c depends on. And as you can see, this pictorial graph shows the initial combination of the glucose with the shift base and the amidori rearrangement, leading to the formation of the stable product, which is HbA1c. Now let us look at the measures, the measurement techniques. We have different techniques, and as we know, the measurement technique is the most important thing. There are different techniques available, different labs do by different techniques, and that gives a difference in the readings that are there. So what is a good technique? So what are the different techniques that are available? Chromatography based HPLC assay is a very good technique that is available. Then you have got antibody based immunoassays, because there you have got antibodies which are binding by and these immunoassays are available. Then you have got enzyme based assays. So these are the three different types of assays available. The advantages of the chromatography based HPLC assay is that it's a very very reliable assay, and it has, however, it also has some disadvantages, is that it leads to sort of it overestimates a little bit the levels measured by this may be slightly higher than what you would see with the other methods of assessing. And so and then you have the antibody based immunoassay, which has got certain advantages. It has certain advantages also, but the disadvantage is that it takes a longer time for the assay to be completed. It requires technically greater skills, and the pricing of the kit is higher. Now you've got enzyme based assays, which are available, mostly used in the point of care devices, and there are certain disadvantages of this. While there may be some advantages, that it may not measure some of the common interferences with the common hemoglobin variants may not happen with this, but a disadvantage is that it's relatively more costlier than doing a HPLC based assay. Now, the other important thing that has happened in the last few decades is that in 1997 a standardization was attempted, and that was by the International Expert Committee. Recommendation was there for forming this National Glycohemoglobin Standardization Program, and this was started in 1996, and hence it has been, I mean, in the sense that it has used the UKPDS and DCCT trial based measurements, and whenever you are measuring by a lab, I mean by a kit that is standardized with the NGSP, which is aligned to the NGSP, your value that you're looking at is is aligned to the value that was seen in the DCCT and UKPDS trials. So that is the advantage of this NGSP reference range. And this when you measure in an NGSP certified lab, what you see is that a change in HbA1c of at least 0.5% is considered both statistically and clinically significant. And the other development that has happened in the last few years is that NGSP basically reports it as a percentage, the HbA1c, while IFCC is the international standardization which is being done again which uses SI units, and what it expresses is the millimoles of A1C per mole of HbA1a. So that is why it gives it in the form of millimoles per mole. And there are the values that you get is different. It's not in percentage, it's in millimoles per mole of HbA, that is HbA1c per mole of HbA. And while A1c is typically reported in the NGSP derived percentages in some countries like US and Canada, many other countries are now moving towards the IFCC derived international units, and in fact it's becoming a norm to shift towards the IFCC international units, and therefore we are also expecting most of our labs to report in both the units so that we get familiar to the other units. So just to make you familiar with the corresponding values of the two different systems, a 7% in the DCCT aligned NGSP reporting would correlate with 53 millimoles per mole in the IFCC system, and this correlates with the estimated average glucose, which can be calculated from these values as 154 mg per dl. So this is how we look at the correlation between HbA1c reported as a percentage, reported as millimoles per mole, and the estimated average glucose. So mind you, this is not the average glucose level, but this is the estimated average glucose. Just like you use the creatinine and estimate the eGFR, or the estimated GFR is calculated based on that. Similarly, you have an estimated average glucose which is calculated from the HbA1c level. So if you look at the interpretation of the IFCC compared to the NGSP, we can say that a level of 7 correlates with 53 on the IFCC, and a level of 8 correlates with 64. And if you're looking at the normal reference range, upper limit of 6% or 5.8% would correlate with 42. 42 is what it correlates with. So that's how we could interpret these IFCC based readings, which are measured in nanomoles per mole. And so what we are saying is that if you look back at the HbA1c, because it gives you a time integrated average of the last 3 months, but does it correctly show all the 3 months? So that doesn't happen, because what we see is that the previous month's glucose reading, the previous 30 days glucose reading, has at least a greater influence on the HbA1c reading, and 50% of that is determined by that, while another 25% is determined by the readings, by the average glucose levels in the 30 to 60 day period, and between the 60 to 120 day period, the average glucose readings contribute to 25% of the HbA1c concentration. So what it means is that when you are measuring, when you're looking at any value, it reflects more of the value, more of what happened during the last 1 month, while it also reflects something which happened in the the previous month and the previous month also, but the greater influences of the blood glucose values of the previous month. So what we see is that HbA1c has got several advantages. As we can see, it is very stable. It can be done regardless of any time of the day. It has less day-to-day variability, and also it predicts the development of micro and microvascular complications, as has been shown in these large trials, and everywhere else also we have been looking at that. So now coming to the pitfalls quickly. The pitfalls I could list out as 4 or 5 different pitfalls that are there, which have to be kept in mind, and so as to interpret it correctly. One is that we lack a standardized assay. So we need to have this NGSP standardized assays all our labs need to be accredited to NGSP, and the assays that is done should be traced back to the NGSP and to the DCCT value, so that we get a better estimation of the risk in our patient of development of complications. And as you can see, the CV is probably less with HPLC and even lesser with the electrospray iontophoresis mass spectrometry. That is the best way of doing it. But as you come down, the point of care instruments probably have greater variability, and that's how we look at the various tests that we have available at our disposal. Now, looking at the other parameter that is there is, while we are saying that it gives a good estimate of the previous 120 days, what happens is that in some situations, like when there is a person developing type 1 diabetes with a short duration of disease, or somebody having steroid induced problem, there it will not give an idea about what is the current status. In particularly in steroid induced diabetes, we are in fact trying to find out what happened earlier, and we are trying to look at the average values in the earlier months. While in type 1 diabetes, it erroneously gives us a low value and shows us that, gives us a sort of takes us away from the diagnosis of type 1 diabetes. That is one fallacy that can happen sometimes when you're looking at it at a longer term perspective. Now, there are several conditions which can affect the HbA1, as we said that because erythropoiesis is one factor, the alteration in hemoglobin molecule that can happen in some situations, and then erythrocyte destruction, which can be rapid in some situations, or it can be slower in some situations. When the erythrocyte destruction is high, then it causes a decreased HbA1c level, because what is happening is that there is rapid destruction of the erythrocytes, the glycated erythrocytes, and the new ones which are formed are not glycated. So therefore, there is a decreased falsely low HbA1c value seen in patients who have got a decreased erythrocyte lifespan, while this reverse happens when the lifespan is increased. Then the assays also can be interferences in the assays by presence of hypertriglyceridemia, which can lower the HbA1c levels, and presence of hyperbilirubinemia or carbamylated hemoglobin in presence in renal failure, or alcoholism, or large dose of aspirin. All of them can cause the increase in HbA1c levels. Then some of the hemoglobinopathies can go either way. You can have either increase or decrease. So that becomes a very dicey situation. So we should be aware of these conditions. We should be aware of these problems, and so that in a situation where you find a discordance between the HbA1c level and what you're expecting, then you can probably interpret it correctly and identify these problems that could be there. So, and also physiologically also there are certain changes, like with age there is a very mild increase in HbA1c level, which may not be very significant in a clinical setup, but this is nevertheless something which we should know. And race also, what we see is that Caucasians tend to have, for the same average glucose level, they seem to have a slightly lower HbA1c as compared to our population, and Hispanics, blacks, or Asians, we tend to have slightly higher HbA1c level. We probably do not know the entire relevance of this, but certainly it is important to understand this. And all the other conditions that, as I mentioned, that I have already discussed this, so I'll not spend time on this. As you can see, you can just have a glance at this and know these are the situations where you should be looking out for it. Like you could have it with drugs like vitamin E injection can cause a decrease in HbA1c because of the reduction in glycation. And similarly, hemoglobin variants can cause change in either direction. Vitamin C ingestion can also again cause falsely increase or falsely decrease also. So these are things which you should keep in mind, because these could be scenarios that you may be facing in clinical practice, and you should be aware that this could be causing a erroneous reading. And with that, I'll come to the other point, that is the accuracy of the assay also sometimes is not very good, because particularly it does not give an accurate measure of the average glucose levels. So what it gives is a range. So the average glucose levels can be, for 7% HbA1c, can be anywhere between 123 to 185. A range which becomes even higher when the HbA1c levels are higher. If you have got a 10% HbA1c, it becomes from 190 to 282. So it could be anywhere between that. The average glucose will be anywhere between that. We calculate the estimated average glucose, but that's not true. But if you look at the average glucose levels during that time period, it could vary in that big range. So that's why we can't accurately say that, okay, this is what the glucose levels were earlier. Now, other point that comes up is the glycemic variability, which has been understood from last few years. You have been seeing, because with the availability of the CGM devices, we are doing more and more glucose monitoring, continuous glucose monitoring, and we are realizing that there is a lot of glucose variability which decides the development of complications, and a new metric has come in which is called the time in range, based on the glucose values at different times of the day. So the time for which you are in the range is calculated as the time in range. And what we are saying is that the HbA1c also fails to address this fact about glucose variability, and also fails to address the hypoglycemia that can sometimes be seen in patients, because it doesn't go down, or it doesn't give us a good idea about the hypoglycemia that may be happening. So just to make it very simple, you can see these three graphs, and the extreme right is the one where the person is 100% time in range. He's maintaining absolutely normal. His HbA1c is 7%, and what you expect is something like this. But that doesn't happen in clinical practice. What we see is that patients have wide fluctuations in the glucose levels. There can be minor fluctuations, as you can see in the middle panel, or major fluctuations, as you can see in the left panel. But whatever it is, what we see is that because of this, because of these fluctuations, there is in the sense, if you do a continuous glucose monitoring, you see that there are differences between these two individuals and this individual. Whereas when you do the HbA1c, it's the same for all the three individuals. It's a value of 8%. So clearly what we see is that HbA1c of this 7% for all the three, but very wide difference in their glucose levels, the glucose fluctuations. The center person is having a HbA1c is having a 7%, a 70% time in range. The right person on the right has got 100% time in range, while the person on the left has got 40% time in range. And as we know, with a higher sort of variability, lower time in range, there is increased risk of complications, both the micro and macrovascular disease. So that's why we need the time in range.
Could you try again?
That's why we need what is the time in range to measure this, and this is again showing the same figure. But what we are saying is that with the same HbA1c, there could be wide fluctuations across the mean value, and these could be intraday fluctuations, and all these has significant impact on the development of the microvascular complications, and also on the progression of atherosclerosis. And therefore, we are moving towards using the time in range to understand this aspect. But HbA1c will continue to have an important role to play in the long-term management of diabetes, and we need to interpret the HbA1c values with these points in mind. So I would conclude by saying that HbA1c is a easy to measure parameter which is relatively cheap. It's a very good predictor of vascular complications. It helps to make management decisions in patients with diabetes, when you're managing patients with diabetes, although you would rely on the SMVG values to give you more information on how to go about with the management. Now, with all these advantages, there are, however, some limitations. That is, it provides only a measure of the approximate glycemia. It does not give you the exact values as we just saw in the discussion, what we discussed in the few slides earlier. And the other fact is that does not give us information about the glycemic variability in a particular individual, and also the risk of hypoglycemia that the person may be having. And finally, what we also know is that the measurement itself can be unreliable in certain situations. So we are trying to see that we get a more standardized measurement. Thank you all for the patient hearing. I'll be happy to answer any questions if there are.
Thank you, Dr. Rakesh Sai sir, for your great insight on HbA1c. I'll request audience if there are any questions.
It is very important topic that HbA1c is done in anemic patients, and it is coming fallacious reports. So in India, the females are already having anemia. So what is the take home, Rakesh sir, from you?
Yeah, so what we need to understand is that these fallacies are going to be there, but nevertheless, HbA1c is a very good parameter. You may not be able to do a CGM in every patient. You may not be able to do it all the time. Even if you do it in a patient for some period of time, you may not be able to do it continuously for a long period of time. So you should use the information that you get from the CGM to make adjustments in the therapy, but use HbA1c for the long-term management. And the important point is that you should keep in mind that these fallacies can be there, and when you look at it, you should keep all these in mind and make appropriate interpretation.
Thank you. Thanks a lot. And we should congratulate Rakesh sir for becoming president-elect. Congratulations to you, sir. And we are having Secretary RSSDI also with us.
the Dr. Sanjay Agarwal, who is also going to continue as a secretary, has been very efficiently managing and taking there to greater heights. So
thank you so much.
Wishing all the best.
Congratulations.
Look forward to work with all of you.
Yeah. Thank you, Rakesh sir.
Congratulations, both of you, sir.
Thank you. Thank you.
Thank you, Chairperson Alka and Gopal, for being with us. And thank you, Rakesh sir, for blessing the event. Over to Kanan.
Thank you. Well, let us move on to the other important topic, which is routinely we are facing in our clinical practice, pre-diabetes. So, the impact of cardiovascular disease in pre-diabetes. For this, we have the eminent chairperson to chat this session, Dr. Ashish, my close friend, and Dr. Jaiprakash Shai. Over to chairpersons. Dr. V.K. Abhichandran is my close friend in social media. And is MD.
Chairpersons are V.K. sir and Jaiprakash Shai.
Jaiprakash Shai, yeah.
So thank you very much, Dr. Kanan. It's a great pleasure seeing you in person on the screen.
Thank you, thank you.
We follow each other on the Twitter. It gives me great pleasure to invite on behalf of my esteemed co-chair, Dr. Sai, Honorable Dr. Sanjay Agarwal, a gifted and erudite orator par excellence. He is going to cover a topic of immense epidemiological and clinical importance, namely pre-diabetes and cardiovascular disease. With this brief allude, I would request my esteemed co-chair, Dr. Jaiprakash, to go through some very impressive CV you are about to read of Dr. Sanjay Agarwal, and then please hand over the session to him. Thank you. Yes.
Sai, you are there?
Or I can continue if you're not.
Yeah, you can continue.
It's a long CV. We are running short of time out.
But in brief, sir, this is one of the most impressive CV one can go through. It's a great honor and pleasure to have you. And I think without much wasting your precious time, I would hand over to you to start your brilliant talk. Thank you.
Thank you for the introduction. And I'd like to thank...
One thing I want to add that Sanjay sir is very Raja person. I have met him in IDEC and he is very ground to earth. He is very ground-headed person and he is very, very gentleman, and we enjoyed a lot your company in the IDEC, sir. Over to you, sir.
Thank you very much, Ashish, and congratulations on such a wonderful meeting. I think it's an excellent scientific meeting and I'm really proud to be part of this meeting. So thank you for inviting me, and I'll just start my talk straight away. Right. So I think the topic is well taken because of the fact that, we keep talking about the risk of cardiovascular disease in patients with diabetes. But the question that really comes up is how early should we start screening for cardiovascular disease? And that's very important because, do we start screening at the time when, patients have already had a clinically presented? I think we have somebody talking to the person. Hello. Can you be muted? Others be muted? Yeah.
RX, mute everyone.
Yeah. Thank you. So I think the question that really arises is how soon should we start a cardiovascular risk screening? Because maybe by the time patients have overt diabetes, you have really missed the bus to do an aggressive intervention, in terms of prevention of cardiovascular disease. So having said this, what is important? Let's look at the demographics, and you can see here that in patients with diabetes, there is an aggressive atherosclerosis, and 80% of patients with diabetes tend to have mortality from vascular disease. This could be 75% from coronary atherosclerosis and 25% from cerebral or peripheral vascular disease. And more than 75% of hospitalizations for diabetic complications come from vascular disease of one form or the other. And more than 50% of the patients with newly diagnosed type 2 diabetes have a coronary heart disease at the time of presentation itself. So probably we should start our cardiovascular screening much earlier than the time that patients come to us with full-blown diabetes. And if you look at the Framingham Heart Study, and they looked at the relative risk of cardiovascular disease in patients with or without diabetes, clearly you can see, irrespective of the gender, The presence of cardiovascular disease, whether it's cardiac, peripheral vascular, or cerebrovascular disease, is all high, almost 2 to 3 times in patients with diabetes. Now, this was an excellent study which enrolled about more than 1 lakh of people. And what they did find is that more than 50% of the patients with diabetes tend to have an associated hypertension and dyslipidemia. So clearly, diabetes really doesn't come alone. And over a period of time, it is saddled with other comorbidities. So if you see the pie diagram over here, almost only about 10% tend to have diabetes in its manifestation. Almost about 16% have presence of dyslipidemia along with diabetes, and about 18% has hypertension with diabetes. And the composite of diabetes, hypertension, and dyslipidemia is seen in more than half the population of people with diabetes. So a typical metabolic abnormality that we associate with type 2 diabetes is insulin resistance, high triglycerides, low HDL, and increase in small, dense LDL particle concentration. And added to this, now we know, is obesity is the mother of all problems and responsible for all the non-communicable diseases. Now, here's a phenotype that two phenotypes that we're looking at. And you're trying to look at the role of insulin resistance in relationship to NFLD, visceral adiposity, and in how this contributes to insulin secretory failure. And you can see here that, and you're looking at 3 subsets of patients, one with normal weight and prediabetes. The second subset is overweight and prediabetes, and the third is obesity and prediabetes. And individually, each one of them is responsible for an increased insulin resistance. But look at the composite of all of them. If you look at the first, group, you can see 6% as a composite will be responsible for insulin resistance. But the same, when the patient has got an overweight, it escalates to almost about 8 times to 24%. And when the patient has got obesity by BMI criteria, it goes up to almost double, 53%. So clearly, there is a role that, all these in the composite are responsible for insulin resistance. Now, if you look at the same model in terms of prediabetes, that's impaired fasting glucose, impaired glucose tolerance, and combined impaired fasting glucose with impaired glucose tolerance. Clearly, you can see here that as you look at it in totality, the whole composite tends to increase when you have both the impaired fasting glucose and impaired glucose tolerance together, almost 3 times as much. Whereas individualistically, it's almost about 30% each. So the entire thing is additive when it comes to the presence of prediabetes. This was an excellent paper. And what they did conclude was that insulin resistance is tightly correlated with obesity, which increase the free fatty acids and ROS level, both of which contribute to atherosclerotic changes and the development of macrovascular complications. So while we have enough data to show that tight glycemic control reduces microvascular complications from a futuristic point of view, it is important that we start screening for macrovascular disease much earlier in the stage of prediabetes, because it is not just good enough to have a good glycemic control. When you look at macrovascular disease, you have to look at the entire conglomerate of cardiovascular risk. That's hypertension, dyslipidemia, obesity, and glycemic control. All these together are responsible for macrovascular disease, which occurs much earlier in the course of patients with diabetes. So here's a complicated flow diagram, but what I'm trying to just show you the interrelationships of all this, whether it's adiposity, glycemic control, prothrombotic strain, hypertension, inflammation, all these ultimately are responsible for micro and macrovascular complications. But ultimately, the role of atherosclerosis in leading to atherogenic occlusive macrovascular disease is very high when all these things come together and lead to macrovascular complication like cardiovascular disease. But let me just put it in a nutshell over here. When you have a combination of hyperglycemia with insulin resistance and hyperinsulinemia, there's a host of pathophysiological pathways that gets activated. And you can see here that they're finally responsible for endothelial dysfunction, which leads to atherosclerosis and arterial stiffness. And along the way, you can see the multiple pathways through which this really happens. And once you've got presence of arterial stiffness and atherosclerosis, it's a matter of time that the patient will develop an occlusive atherothrombotic disease itself. Now, this is an excellent slide that I always love to show. And clearly you can see that by the time the patient develops clinically evident type 2 diabetes, there's a lot of changes that's contributing to cardiovascular risk before that. And genetics is something you cannot alter, but clearly weight gain, dyslipidemia, hypertension and prediabetes are all potentially modifiable risk factors which should be identified much earlier, which is responsible for insulin resistance and as a compensatory hyperinsulinemia. And all this entire group ultimately leads to aggressive macrovascular complications. We know that, hypoglycemia in the post-diagnosis are more responsible for microvascular complications. And this was an excellent paper by Ralph DiFranzo. And what it did show is that while we know that overt diabetes does have, cardiovascular risk, whether it's fasting or 2-hour post-meal glucose, the risk for prediabetes or impaired glucose tolerance or impaired fasting glucose is intermediate between the normal and overt diabetes. So we really don't have a low risk in presence of prediabetes, and we need to identify this much earlier on. Now, how low can we really see this? Is it really at the level of the prediabetes, or do we need to start screening even before that? And this was an excellent study by Epic Norfolk study, where they looked at the composite of A1C and risk for cardiovascular disease. And there are two subgroups of patients with coronary heart disease and cardiovascular disease events and all-cause mortality. And they sort of looked at subgroup analysis in different A1C subsets. And you can see they started as low as less than 5%, going all the way up to 7%. And you can see here that both the graphs never touch the baseline to 0%. So your risk actually, in principle, starts even earlier than the pre-diabetes state for people who are genetically predisposed to become, pre-diabetes and over diabetes. So your risk for cardiovascular disease occurs even before the stage of pre-diabetes. And this is also extrapolated by another study which looked at close to about 14,000 cases. And here you can see here that when you look at fasting plasma glucose with less than 7 millimoles versus more than or equal to 7 millimoles, you can clearly see the risk is higher in patients with less than 7 millimoles as compared to more than. But if you look at the patients with no known diabetes at the baseline, and here you're looking at subgroups between 3.9 to 5.6, 5.6 to 6.1, and 6.1 to 7, and more than 7. You look at this forest plot, and you can see here that there is a rising incidence of occurrences of cardiovascular disease, even at baseline or below the baseline when you look at all these different subgroups of A1Cs. Clearly, both the fasting and the post-meal glucose are equally responsible for occurrences. So it's not just good enough that I can target fasting plasma glucose or a post-meal glucose value. And now there is actually more correlation coming in with post-meal glucose values as well as postprandial lipemia, which has a higher correlation with cardiovascular risk as compared to the fasting. Now, this data comes from the Nurses' Health Study, and they looked at the risk of myocardial infarction or stroke according to the dysglycemic status. So while your control is non-diabetic patients throughout the study, you can clearly see that prior to the diagnosis of diabetes, patients have almost about 3 times risk for myocardial infarction or stroke, and this risk goes up after the diagnosis of diabetes and presence of diabetes at the baseline as compared to diabetes at the baseline. So at no point of time you can see that the risk is not there in pre-diabetes states. And this was also looked at from the Q-risk score, from the risk scores. So when you look at all the risk scores, and here you're looking at 3 risk scores, Q3, the AHCC, AHA, and the score 3. And they looked at the 3 subgroups, that's normal, pre-diabetes, and undiagnosed diabetes. And you can clearly see here that as per the different components of the risk score, the risk in pre-diabetes is more than normal and lesser than undiagnosed, and all across the board when you assess from the different risk scores. So let me then move tracks and talk that we have so far established that, we should not ignore pre-diabetes. The risk for cardiovascular disease is higher in patients with pre-diabetes as normal patients, and our risk screening should start early and should not be delayed, maybe 5 years or 8 years down the line. But by then you probably miss a bus, and the process of macrovascular disease has started early. And of all the potentially modifying risk factors, excepting for genetics, all the other risk factors are modifiable. So it is criminal not to screen for them and identify high-risk patients, because there are 5 alarming facts of cardiovascular disease in India. We develop premature atherosclerotic disease almost 10 years early. Comorbidities like diabetes and hypertension strike at a younger age. There is a greater prevalence of LV dysfunction at presentation. We tend to have smaller arteries, and obviously interventions are more difficult in our patients. And you can see the fallout of missing out early diagnosis of cardiovascular disease, because you end up with either atherosclerotic cardiovascular disease, heart failure, peripheral artery disease, strokes, and of course the incidences of microvascular, which it contributes in terms of retinopathy, neuropathy, and nephropathy. So the risk as a fallout of missing early, modifying the risk factors, is pretty high in terms of mortality and morbidity. So we need to aggressively have a risk scores. We need to look at modifiable risk factors, and obviously today we have enough tools to modify this in terms of lifestyle intervention, dietary intervention, as well as pharmacological interventions. So we should look at beyond A1C reduction to look at not only just A1C, but also blood pressure control, lipid control, weight management, having the right kind of food. So all this is very important, which is far more important than just A1C reduction itself. And we know that later in the course of the disease, if you try to intensify control, you don't get as much benefits as when you modify the disease itself at the early phase. And this comes from various UK PDS, Accord, Advance, and the VADT. This talks more about better improvement in terms of microvascular disease when diagnosed early, as well as the benefit in terms of cardiovascular disease may not be seen early, but in terms of long-term studies, you can clearly see the benefit of early intervention, also in terms of mortality. So while we keep talking about when we should start, and we know that the benefit really occurs in terms of long-term studies when intervention has happened early in the course of the disease itself. So let me sort of walk you through some of the risk factors that we always talk about, and which has an important role to play when you want to reduce the burden of cardiovascular disease in pre-diabetes. So we have the traditional risk factors like age, sex, family history, which are non-modifiable but have an important role. But smoking, hypertension, and lipids are potentially modifiable risk factors, which increase the risk for cardiovascular disease. And these at times can be also gender specific. But these are some of the other risk factors we don't talk about. And that's basically the duration of diabetes, low GFRs, metabolic syndrome, recurrent severe hypoglycemia. We are now talking about NAFLD, NASH as a potential independent risk factor, and obstructive sleep apnea, which has a strong association with fatal MI and stroke. Why I say this, that we need to diagnose early, because there have been a host of trials which, right from showing a non-inferiority to superiority, that pharmacological intervention can be initiated early, and we may see the benefits in terms of reducing the cardiovascular disease risk burden. And our entire algorithm of treatments have changed, right from lifestyle, metformin, and independent of the A1C, you try to look at whether the patient has presence of atherosclerotic cardiovascular disease, CKD, or heart failure. And obviously, your choice of agents differ with the presence of any of these potential problems that the patient may tend to have. As I said, that do we have the data that if you do multiple risk interventions, will it make a difference? And this comes from the two trials, the STENO2 trial and the Look Ahead trial. And you can see here that if you have patients with no diabetes, diabetes is 1 to 2 risk factors, 3 to 4 risk factors, 5 to 6 risk factors, and 7 to 9 risk factors. Clearly, as the number of risk factors go up in patients who did not have previous coronary heart disease, your risk for non-fatal to fatal MI tends to go up. as well as if you look at patients with presence of diabetes with no diabetes, you can see here that the risk of non-fatal MI or fatal MI is higher in patients with presence of diabetes. And these are some of the, from the Steno 2 and, conclusions that if you intensify treatment of all the risk factors together, then you will strike a much larger benefit than probably modifying each of these risk factors alone. And this was also seen by the Interheart study, which looked at 9 modifiable factors, which account for 90% of the first MI risk worldwide. And clearly you can see here at the extreme right that when you have all 9 risk factors which are modified, then they have a far better benefit as compared to each of these risk factors when addressed alone. So I'll conclude my talk by saying that what did we understand from my talk? Patients with diabetes are at an increased risk for coronary heart disease. Is there a good data? No question, there is. Are all patients with diabetes to be treated as coronary heart disease equivalents? That is questionable. We don't have convincing data about it. Can we identify populations of patients which need more intensive care for aggressive intervention? Sure. Look at the age, duration of diabetes, lifetime risk versus short-term risk, total risk burden, and the coronary artery calcium score. Should we sort of promote, screening for risk in all patients? And that's a key question, whether asymptomatic patients should be screened. It basically depends on the entire cardiovascular risk burden that the patient carries. And if there is a high risk burden, then even asymptomatic patients should be screened versus low risk burden, where you probably may be able to pass because the risk benefit ratio may not be really in favor of it. And obviously, we need to put aggressive prevention strategies into place if we have to reduce the burden. So in a nutshell, the process of the risk for coronary artery disease starts very early in the course. And you can see this life course model. And we have to look at cardiovascular risk assessments in our patients. So look at glycemia, look at obesity, physical activity of the patient, advocate more active life, modify the lipid levels, address the hypertension, procoagulant state, endothelial dysfunction, and obviously there is a whole bit of inflammatory theory to this entire thing. So thank you very much for your patient listening. I'll stop here. Thanks a lot.
Thank you very much, sir, for that brilliant talk. And may I humbly share a paper or two while I was trying to acquaint myself with your important topic. I went through the literature and exactly echoing whatever you have taught us was a paper, updated meta-analysis published in BMJ 2020 by a group of Chinese researchers. They maintained that prediabetes was associated with an increased risk of cardiovascular disease and all-cause mortality. And a more important paper was, shared in ACC last year, 2021, by Michel and his colleagues. And they looked at prediabetes associated with increase in MACE, MACE. And they found that there was almost 18% MACE incidence compared in prediabetics compared to persons without prediabetes who were having around 11%. And more important finding they had to share with us was that even if this prediabetics reversed to normoglycemia, they still harbored higher risk. So what are your expert comments on that kind of outcome?
Yeah, see, basically the thing is, even if you sort of look at prediabetes and you reverse the glycemia, as I just showed you, that it's not just only glycemia that is contributing to the cardiovascular risk. You have to look at all the other modifiable risk factors alone, also along with glycemia. And this has to start screening. It's like this, you have the risk factors. Your diabetes is just sort of taking it to the next level. And if you're not addressing the potential risk factors, and you're just controlling the glycemia, you're going to come back to still at a higher state because you're not addressing the rest of the risk factors.
Comprehensive.
So you obviously have to address everything, which is getting magnified by the presence of glycemia, hyperglycemia.
So, and there was another interesting observation that pre-diabetics had more complex coronary anatomy and required a higher number of longer stents. So this is from another paper. And I think if there are any questions in the chat box, any comments by if my co-chair has joined, or may I also share with you what I've learned from your brilliant talk? The first thing I believe is that prediabetes may not be as benign as it seems. So it's more nasty disease, carries an increased risk in CVD. And I think we have to shift our focus on preventing prediabetes rather than just be obsessed with prevention of diabetes. And you very elegantly draw home that point. So thank you very much, sir, for your brilliance.
Thank you so much.
Can I have one question, sir? Like Sanjay Garwal, sir.
Yeah, please go ahead.
Yeah. Sir, we know that the SGLT inhibitor, we don't have any data on prediabetes, sir. But Indians are predominant for all cardiovascular complications, mainly subclinical atherosclerosis, other diagnosis of prediabetes. So what is the role and the impact of these SGLT inhibitors, especially on prediabetic population among the Indian context, sir?
So we don't have enough data of SGLT2 inhibitors in the prediabetes. So if you look at the MACE outcomes, excepting for empagliflozin, it hasn't shown really benefits in terms of MACE outcomes versus SGLT1 analogs. Your data is more robust when it comes to heart failure and kidney disease. That's where it has a bigger data. But in terms of collateral benefits, what you're getting is weight reduction. That's important. Adiposity, NAFLD, NASH, there's a whole bit of data that is coming in for role of SGLT2 in all these conditions, particularly adiposity and central adiposity. There's a whole bit of data that is there, and that's more pertinent to our Indian population. Benefits in terms of, marginal benefits for blood pressure that we are looking at, and endothelial dysfunction. So there is a surrogate benefit that you tend to get, which sort of reduces, which helps in terms of the reduction of the cardiovascular risk. But if you look at the trial data, it doesn't have a very clear benefit when it comes to MACE outcomes.
Thank you, sir. Thank you, sir.
Dr. Kanan, may I just humbly share with you, there is a trial initiated last year, 2021 end, with SGLT2 inhibition in older obese adults with prediabetes. So probably some interesting future data.
Maybe. Thank you. Thank you, sir. Thank you, sir.
Thank you, Sanjay sir, for excellent talk. And thank you, Chairperson Vinod sir, for giving your insights and making the event so wonderful. Over to Kanan for next topic.
So, friends, we move on to the next topic, the role of C-peptide estimation in diabetes, when and how. For that, we have our esteemed chairperson, Dr. Bhavesh and Dr. Rajesh Yadav. Bhavesh is a consultant diabetologist, Patel Diabetes Center from Odisha. And our Rajesh Yadav from a diabetes and a metabolic physician in Well Lab Diabetes Center in Odisha and Das Diabetes Center, Mumbai. Over to chairpersons. Both the chairpersons couldn't be able to see.
So welcome Tejas and welcome the chairperson. Bhavesh, is there any?
Hello.
Karan, you can continue.
Okay, it's a pleasure and pride to introduce our friend and Dr. Tejas Shah in this esteemed forum. Tejas is the diabetologist and director IVA Diabetes Care Center, Mumbai. He's an honorary diabetologist, SL Ragiza Fortis Hospital. It's a Diabetes Care Center, Malad and Andheri. Visiting teaching faculty for fellowship diabetology at Dr. Patel Medical College, Mumbai. He's a founder and president of the United Diabetes Forum. He's organizing scientific committee and faculty of multiple forums with various spectrum of years. And speaker at various national conferences like CID, RSSA, IdeaCon, Diabetes India, Diacon and IdeaCon. He's a practicing diabetologist, almost completed for 23 years duration. Welcome, respected speaker. We are waiting for the enlightening of topic.
Thank you. Thank you very much for the introduction, Chairperson, and thank you, Dr. Ashish, for inviting, and congratulations for a wonderful event. I also want to specially mention for keeping this topic particularly. It's something which we do not discuss much nowadays. It is not being spoken about much, but something which is very, very relevant in today's for us in clinical practice, and it will always have its own importance. I'm going to talk to you about the role of C-peptide estimation in diabetes, when and how. It is an important marker. It is an important test that we have been doing right from our PG days. We all have learned about C-peptide and how it differentiates between type 1 and type 2. I'm going to update you something about the role of C-peptide per se in the management also. So C-peptide, as we all know, is a measure or it's a co-secretion from the pancreatic beta cell. It is more or less produced in equimolar amounts to the endogenous insulin. And the difference is that it gets excreted at a much constant rate. The half-life is much more longer as compared to insulin, where the half-life is much shorter. It's only 3 to 5 minutes, while the half-life of C-peptide is overall much longer, almost 15 to 20 minutes. After cleavage of proinsulin, mainly it's the insulin and the 31 amino acid C-peptide which gets secreted into the circulation in equimolar amounts or in equal amounts. So for years, it was known that C-peptide is an important co-secretion of insulin which from the beta cell. After cleavage of proinsulin, what happens is that this gets released into the circulation along with insulin. In 1967, it was discovered mainly, and it was that time thought that it, like insulin, C-peptide would also have a role primarily in glucose or lipid metabolism. But subsequently, it was found that it does not have any per se role in there. And for a number of years, it was considered to be a waste product of insulin synthesis until the 1970s, when again more data came related to C-peptide, and it was then found out that it is more or less a useful, more better indicator of beta cell function, and something which would help us in differentiating between type 1 and type 2 diabetes. Several studies which demonstrated that patients with type 1 diabetes who have even a smaller amount of reserve of beta cell or a lesser amount of the C-peptide comparatively do better over a period of time than those patients who are completely or totally C-peptide deficient. The possibility that C-peptide may have its own direct effect was further evaluated later on in the 1990s, and more or less there were studies specially done later on to look at the importance of C-peptide by administering C-peptide to patients with type 1 diabetes, and more or less it did show some positive results, and thereby further studies were later on done. So what is recommended per se for C-peptide? The role of C-peptide at present is mainly in the diagnosis of type 1 diabetes, mainly to distinguish type 1 from type 2 diabetes. We know that patients with type 1 diabetes with lesser insulin secretion or no insulin secretion will have a negligible C-peptide or lesser value. It is still considered to be one of the important tools for research rather than a therapeutic tool. The AD also concluded that C-peptide estimation should be used as the most appropriate outcome measure, mainly to look at the preservation of beta cell function. And in recent guidelines developed by ACE and AAC, the levels of C-peptide recommended they've cut off a certain number of the values of C-peptide which would differentiate type 1 and type 2 diabetes. This is a representation of how C-peptide levels would differ in different conditions. A patient where they looked at 4 different classes of patients, where they looked at type 1 diabetics, type 2 diabetics, latent autoimmune diabetic, and patients who were not diagnosed but recently diagnosed with diabetes or undiagnosed with diabetes. And clearly, if you see the difference in values of C-peptide, a type 1 or a patient with LADA would have a lesser concentration of C-peptide, more or less than 0.4 or 0.3, while a patient with type 2 diabetes characteristically showed a higher value of C-peptide as compared to type 1 and LADA. So when both C-peptide and insulin are getting secreted simultaneously, why does C-peptide become a more preferable tool to judge beta cell function and not insulin assay per se? The reason is that the degradation rate of C-peptide in the body is much slower as compared to insulin. As I told you, the half-life is almost 20 to 30 minutes compared to insulin only 3 to 5 minutes. And therefore it affords or it gives us a more stable test window to look at or to judge the beta cell response. In healthy individuals, the plasma concentration of C-peptide is around 0.3 to 0.6 nanomoles in fasting state, and a postprandial increase goes up to 1 to 3 nanomoles. Half of all the insulin that gets secreted by the pancreas is metabolized in the liver by the first phase metabolism, and more or less C-peptide has negligible hepatic clearance. Even after in distribution in the peripheral circulation, C-peptide is cleared at a much constant rate, while insulin clearance is very, very variable, and therefore the measurement of insulin is exactly sometimes not very, very accurate. And so, of course, patients who are taking exogenous insulin, measurement of C-peptide would avoid the pitfalls mainly of cross-reaction of assay between exogenous and endogenous insulin, and therefore becomes a more accurate marker to assess the beta cell functions. Does it have any role in terms of prediction of the need for insulin? There have been studies, there have been some trials which have looked at whether a C-peptide response or the C-peptide value can predict which kind of patients would require insulin early or which kind of patients would need more insulin. There was an early prospective cohort study which looked at the peak glucagon stimulated C-peptide level, and it showed that a level of less than 0.6 nanomoles was associated with more chances of patient needing insulin later on. Also, the time to insulin treatment would be associated also with a lesser C-peptide response. That means a person whose C-peptide response is lesser would maybe require an insulin treatment much more earlier. A stimulated C-peptide concentration of at least 0.2 nanomoles is used as a cutoff value which detects or which would predict a poor beta cell reserve, and therefore that would tell us which kind of patients would need more insulin therapy or more intensive insulin therapy from the very beginning. Additionally, a fasting C-peptide value of less than 0.25 nanomoles has been shown with ICA positivity, has been shown to be again a useful marker to detect which kind of patients would need insulin treatment. Apart from that, C-peptide has been used as a cornerstone for assessment of non-diabetic associated hypoglycemia, and in detecting causes like insulinomia or factitious hypoglycemia. There is also evidence suggesting that C-peptide may be a useful tool for predicting future levels of glycemic control, response to hypoglycemic agents, and the risk of future diabetic complications. How do we measure C-peptide? It has been there are different ways of measuring C-peptide. Plasma or serum has been traditionally been used. It can be checked in the fasting levels, or it can random C-peptide levels have also been used at some places. And the most commonly used test is to use either a standard mixed meal tolerance test following or a glucagon stimulated C-peptide test. What happens is that, and also urine has been used, a urine sample measuring urinary C-peptide and a urinary C-peptide creatinine ratio has found to be a non-invasive alternative for certain patients, especially for children. But of course, there are certain fallacies associated with each kind of these tests. The most sensitive or the most commonly used or recommended test is a glucagon stimulation C-peptide test. Again, the patient may complain of nausea sometimes because of the glucagon injections. Apart from that, the mixed meal tolerance test is more of is also being used, standardized. It's a more of a time consuming, with the means in liquid form sometimes are not very easily available. In the olden days, tolbutamide tolerance test was also used to assess C-peptide, which was considered to be very, very sensitive. Random non-fasting C-peptide is also being used, but it needs to be confirmed sometimes with proper stimulation testing. Urinary C-peptide and urinary creatinine C-peptide ratio is also one of the marker or one of the tests which has been tried for as a non-invasive method. Of course, it can have again its fallacies, because in patients with renal disease, sometimes these results are not very, very accurate. Glucagon stimulation test is done in a different way. A patient cannula is inserted, patient's serum C-peptide, and prior to injection of glucagon is taken, and then injection of 1 milligram glucagon is given over a period of 10 seconds, and samples are collected at 2, 4, and 6 minutes post glucagon injection to look at the response. What are the problems that are associated with these kind of measurements? Let us understand that the majority of the C-peptide is mainly metabolized by the kidneys, with 5 to 10% getting excreted unchanged in the urine. Therefore, in patients with certain chronic kidney disease or in certain conditions, this may not give us a very accurate measurement of C-peptide. There can be sometimes cross-reactivity with proinsulin, which has to be less than 10% in concentration. There are anti-insulin antibodies that are present, which bind both proinsulin and C-peptide, which can sometimes give a high C-peptide false reading in certain conditions. And also, considering C-peptide, it is important to be aware that sometimes the local assays use certain assays which might not be absolutely possible to detect the C-peptide accurately. So we use C-peptides mainly for different ways. It has a diagnostic implication, it has a prognostic implication, it has therapeutic implications. Diagnostically, we mainly use to define or to differentiate it between type 1 and type 2. For patients who need to be put on subcutaneous insulin therapy or pumps, it is a useful marker. It can differentiate sometimes younger onset diabetes from or MODY from type 1 again. Prognostically, it is used as a marker for duration of diabetes. The lower C-peptide sometimes tells us for a longer duration of diabetes. Low levels are associated with more microvascular complications. As we know, it has been seen in certain trials, especially with type 1 diabetes. Therapeutically, lower baseline levels have been associated with increased need for insulin. Sometimes higher levels sometimes are present in patients who respond better to metformin and glibenclamide in combination. Therefore, more or less, the measurement is sometimes used to assess which kind of patients would respond better to oral drugs also as compared to insulin. The normal level for C-peptide is fasting is 0.3 to 0.6 nanomoles. The postprandial levels may rise up to 1 to 3. Higher levels are seen in obese and overweight individuals. And as I told you, the biological half-life is much longer in patients with type 2 diabetes. Excretion-wise, almost 50% or more is excreted, removed by the kidneys, and 5% of the total C-peptide gets excreted unchanged in the urine. Blood levels of C-peptide can be sometimes falsely elevated in patients with chronic kidney diseases and may be cleared in patients on hemodialysis also. There can be variable clearance. In terms of clinical usage, as I told you, diagnostically, we can use it to differentiate between type 1 and type 2 and from between more younger onset patients, like to differentiate it from MODY and LADA. Prognostically, it helps us to detect the duration of diabetes or to assess the duration. It has shown association with glycemic variability and HbA1c levels also, and lower levels of C-peptide per se makes sometimes a patient more brittle, and the response to insulin sometimes varies. Therapeutically, we know that decreased baseline C-peptide levels are associated with increased need for insulin. Decreased baseline levels are more associated with shorter time to insulin treatment. Higher levels are sometimes present in patients who respond better to oral drugs or OHAs. That has been seen, and therefore correlation with decreased HbA1c following initiation of GLP-1 RA therapy is also been seen in clinical data. A higher C-peptide level, we need to understand that it can be present in certain conditions like insulinoma or excessive sulfonylureas or non-insulinoma pancreatogenic hypoglycemic syndromes. CKD sometimes shows a false high C-peptide levels. Insulin resistance rate like obesity and Cushing's will demonstrate a higher C-peptide. A lower C-peptide is diagnostic of type 1 diabetes. Sometimes factitious exogenous insulin injections patients may demonstrate this, which would be a factitious low level. Hypoglycemia due to insulin like growth factor, we need to differentiate from insulinoma, will show characteristically a lower C-peptide level. Insulin independent hypoglycemia again, or rarely something like a Hirata's disease. Therapeutically, it has been tried or it has been used sometimes to look at markers. There have been studies, or the DCCT analysis also showed us that for patients who had a lower C-peptide, the chances of complications were higher. The intensive treatment group, those patients where the C-peptide was greater than 0.2 consistently showed a reduced incidence of retinopathy and nephropathy, compared to patients who had C-peptide were less than 0.2, developed a higher incidence of retinopathy and nephropathy much earlier as compared to the intensive group. Some studies have shown an improvement in peripheral neuropathy for patients with type 1 diabetes with this. The theory behind this is that more or less in patients with neuropathy and type 1 disease, there is a decrease of sodium potassium ATPase activity in the peripheral nerve tissue, and it is associated mainly with inactivation of the sodium channels, and intra-axonal sodium accumulation occurs. C-peptide has been shown in physiological concentration to show an improvement per se in sodium potassium ATPase. It also has shown to have increase of nitric oxide synthetase activity, thereby causing an improvement of endothelial function, improvement of nerve blood flow. More or less, it decreases the sodium retention. It has shown to have some improvement in the insulin-like growth factors also, and more or less have shown to cause an improvement in the peripheral nerve function for patients with type 1 diabetes. There has been again theories that C-peptide may have a positive role in reducing the progression of chronic kidney disease. There has been some areas where they have shown to cause a decrease of proteinuria. It causes a decrease of glomerular hypertrophy. It's shown to cause an improvement in per se in the GFR or increasing GFR per se by its effect, and thereby some further studies or some further data is required to show that C-peptide may have a therapeutic role in halting the progression of chronic kidney diseases. This is one of the study which looked at the levels of C-peptide and predicting whether it can help in predicting the effectiveness on DPP-4 therapies. 56 patients who received DPP-4 metformin were evaluated for 1 year later. Fasting, HbA1c, C-peptide and weight were recorded at 3-monthly interval. And patients who responded better in the DPP-4 metformin arm showed better weight loss, showed a baseline, even levels of C-peptide were more predictive in this case. And those with a higher value of C-peptide of more than 0.02 responded better to DPP-4 and metformin versus compared to the duration of diabetes, which was not exactly a very good predictor. So to summarize, C-peptide is a useful indicator of beta cell function. It allows discrimination between insulin deficient or insulin sufficient individuals. Various methods of sampling are available, like a urinary C-peptide to creatinine ratio, a fasting C-peptide, or a glucagon stimulated C-peptide. Owing to its sensitivity, reproducibility, and convenience of the test, glucagon stimulation testing is considered to be the ideal one to measure C-peptide levels. C-peptide has shown to correlate with diabetes duration of disease, as well as the age of diagnosis. Interestingly, C-peptide has been demonstrated to be associated with microvascular complications in the long run, and further studies are needed to show that alongside HbA1c, sampling for C-peptide may be used as a diagnostic and monitoring tool. Thank you very much.
Thank you very much, sir. It's a wonderful talk and excellent session on C-peptide. I'll cover the entire journey and you've given a clear-cut insights on C-peptide regarding why C-peptide measuring and comparing with insulin is an entire physiology, including the degradation as well as half-life on comparing with insulin. And also the important message on C-peptide, a cornerstone on the non-diabetic associated hypoglycemia is one of the important messages that we want to take home, sir. It's very important. And also given the multiple measurements also given regarding the C-peptide levels at various components both in type 1 diabetes and LADA also. Thank you very much for the excellent talk, sir. So I have one question, Dr. Tejas, sir. Whether C-peptide any variation between the fasting or prandial level, it should be done in fasting or prandial level, both the levels we supposed to do, sir.
So as the literature suggests, the best way to check C-peptide is the prandial one. Glucagon stimulated C-peptide is ideally the one which gives the best possible or is the most sensitive to detect. The fasting C-peptide also, though, is done routinely, but still there can be patients who may have a very low fasting C-peptide, but the glucagon stimulation one would show a much higher value. So the ideal one to check is the postprandial one or the post-glucagon one.
Thank you, sir. Thank you. Ashish?
Yes, you have given an excellent talk regarding C-peptide because there are so much dilemmas in the clinical practice and you have unlocked the queries today. So thanks a lot for giving the excellent talk.
Thank you.
Over to Kanan. Thanks the chairpersons for joining.
Thank you.
Dear friends, let us move on to the very, very important talk by our own mentor and teacher. He's a superstar in diabetes. Our immediate past president, Dr. Bansi Saboo sir, talk on paradigm shift in the management of diabetes through our TIR and CGMS technology. For this, we have esteemed chairpersons, Dr. Sandeep Surya sir and Dr. Payush Dasar sir. Sandeep Surya sir is a well-known friend in social media, senior diabetologist, is advanced diabetes care and critical care center, Holy Health Hospital, Nisar, and Payush is consultant diabetologist and endocrinologist, Desar Diabetes Clinic and Advanced Diabetes Care Center. Over to chairpersons.
Yeah, thank you, Dr. Kannan. And I think Dr. Bansi Saboo is the personality who needs no introduction. He is chief diabetologist and chairman at DiaCare. He is ex-president of RSSDI, and he is always dynamic
and exploring the new thing. And the same thing, the paradigm shift which has happened in the field of diabetes from a simple fasting constant sugar to HbA1c to SMPG to CGMS. So how this paradigm shift in the diabetes management to TII, time in range, and CGMS is going to be taught by Dr. Bansi Saab. Over to you, Bansi Saab.
This is a recorded version.
Yeah, thank you, Piyush, for introducing. Sir is traveling and he will join soon. And he will, RX, please play the recorded version.
Thank you, Dr. Ashish, and thanks, Chairperson, for kind words of introduction. And thank you, Ashish, for giving me an opportunity. I'm going to talk in next 20 to 25 minutes, the paradigm shift in diabetes management with advent of continuous glucose monitoring. I don't have any financial disclosure for this particular talk. We all know that if you cannot measure it, you cannot improve it. And this is true for diabetes management. Unless we measure it, we can't get a good improvement in diabetes control. There are three pillars to manage dysglycemia. With DCCT and UKPDS, we could understand that chronic hyperglycemia is to be treated. And we should try to achieve a good glycemic control. If we get lesser and lesser A1C, we get less and less complication. So, but it is in hypoglycemia which is limiting factor. You can't achieve a tighter glycemic control. Even to get below 7 also sometimes leads to a lot of hypoglycemia. So if someone wants to achieve even below 6.5 or 6, it's really sugar. But with the newer insulin analog, with the newer sulfonylurea and many more newer anti-diabetic agents which may not cause so much hypoglycemia and no hypoglycemia, but still it is the glycemic variability which is also very important. It also is increasing risk factor for diabetes complications. So achieving a tighter glycemic control along with less glycemic variability, and to measure that we have time in range. So out of 24 hours, how much time someone is getting between 70 and 70, that is also very, very important, other than getting a good control. If one of our patients is doing like 4 times sugar, a routinely type 1 diabetic patient is doing pre-meal sugar and even at sugar too. And you can see all 4 reports are relatively well controlled, but if I do the continuous, actually it is not. Pre-lunch there is a hypoglycemia, there is a post-lunch hypoglycemia and midnight hypoglycemia too. So it means by doing a random glucose monitoring, it looks like getting a photo. While if you do a continuous glucose monitoring, it's like a continuous videography. So is HbA1c alone is enough? No, probably alone HbA1c is not enough. We have to have a continuous glucose monitoring to know that there is no hypo and hyperglycemia. Also, because you may have 2 different type of patient with the same A1C, but you may find that one patient who is developing hypo and hyperglycemia, while other patient, even with the same A1C, there is no hypo and hyperglycemia. I can give you one more example. These are 4 different type of patients with almost all of them have 8 A1C. Now, suppose a patient comes to you with A1C of 8. We would like to treat this patient and we would like to increase the medication. But if I do the continuous glucose monitoring, you will find one patient with 8 A1C, it's only the fasting hyperglycemia. The other patient actually fasting hypoglycemia. So both these patients are to be treated completely differently. While other patient whose post-lunch and post-dinner sugar are high, and one other patient's maybe only post-dinner sugar is very, very high. So you may have 4 different varieties of patient with the same A1C. And if I get a continuous glucose monitoring, you will find that which patient is to be treated by what way. And that is what a precision diabetology comes in picture. And that is what the continuous glucose monitoring can be very, very useful for getting a tighter glycemic control without getting hypoglycemia. So what's the rationale behind doing this continuous glucose monitoring? As I told you, you may have 2 different type of patients with the same A1C, but still the glycemic variability or glycemic excursion could be very, very high. But so continuous glucose is beneficial for those patients who are not meeting either their A1C goal, having frequent low glucose level. They are unaware of their low glucose levels. They want to reduce their A1C target without increasing hypoglycemic events, or they have widely variable blood sugar level. These are the children or adolescents who are willing to use, and they should be using, if they can afford it, device every day. So the classification at present, we have real-time CGM, which is also available in our country. We have flash monitoring, which is intermittently scanned CGM, which is also available. We have professional CGM, which is blinded one when patient is not getting the continuous report, but while patient comes back to us after 1 week or 2 weeks, we can get his report of last 7 days or 14 days. And we have integrated CGM, which is also available in our country, but with pump, even the patient is putting on a continuous glucose monitoring on the pump itself shows you also the graph of continuous glucose monitoring too. Now, what's the scientific evidence that how continuous glucose monitoring can help our patient? This is a paper which talks about in 1983 when DCCT was there to achieve a tighter glycemic control of less than 7. How many patients were getting hypoglycemia? It was 62 per 100 patients here. They were getting HbA1c good control, but the mean A1C of these patients before the trial was 9 and they could achieve 7.2. But for that, the hypoglycemia rate was 62 per 100 patients. After 25 years, in 2008, the patients, again type 1, they were on basal bolus therapy, but these patients were on a continuous glucose monitoring. And you can see significant risk of hypoglycemia is reduced from 62 to 20. And at the same time, these patients were already relatively well controlled, 7.6. Now from 7.6, they could achieve 7.1. So you can understand how difficult it was, but because of continuous glucose monitoring, they could achieve it. And at the same time, the risk of hypoglycemia was much less. After 8 years, these patients were integrated with pump therapy too. And you can see in pivotal trial, these patients who were having relatively HbA1c well control, I mean 7.7 mean HbA1c, they could achieve 6.9, but the risk of hypoglycemia was 0. It was 0 in 100 patients here. Now, we all know about the type 1 diabetic patients. They are really getting benefits because of continuous glucose monitoring, but do we get benefit with type 2 diabetes? Some of these papers which we have written, this was in JAPI by Unni and myself, where we have talked about the can we have the use of continuous glucose monitoring in type 2 diabetes patient? This is what we had used, emulative glucose profile with a consensus statement, which shows that yes, it is really useful with many experts across the country who are part of it. We had also done one more paper with Dr. Mohan, which he has talked about the retrospective continuous glucose monitoring in optimizing the management of type 2 diabetes in our country. This was consensus where I was the part of it, where more than 35 international experts were there. And in 2017, we had come out with an international consensus on a use of continuous glucose monitoring. The same after 2 years, again, I was the part of it and we could come out with a time in range. Those who are using continuous glucose monitoring, what was decided that they should achieve more than 70% of the time between 70 to 180. And that is what TIR. But it's not acceptable if they go below 70, even not more than 5% of the time. It is not acceptable for them, even if they go more than 25% of the day, more than 180 milligram. And this is acceptable in type 1 and type 2 diabetes if the target range is more than 70% of the time between 70 to 180. If these are the patients who are elderly or high risk for type 1 and type 2 diabetes, these patients, even it is not acceptable for them to go below 70 even for 1% of the time. But still, it is advisable for them to have more than 50% of the time their sugar should be in range of 70 to 180. So they are not acceptable for them to go in hypoglycemia. If they have more hypoglycemia or they get more hyperglycemia, grade 1 or grade 2, then the therapy should be changed. But at the same time, not by increasing the risk of hypoglycemia. If a type 1 she is becoming pregnant, the target range is becoming slightly tighter because in pregnancy we want 63 to 140 is better rather than going up to 180. So it should be again more than 70% of the time, they should be in range of 63 to 140. In type 2, getting pregnancy or gestational diabetes or any hyperglycemia in pregnancy, again a tighter glycemic control between 63 to 140, but more than 90% of the time they should be in this range. The time in range is a target for type 2 diabetes. That one paper which I have written that yes, it is also one of the very important target. Only getting A1C may not be sufficient even for type 2 diabetes also. If we get for time in range for these patients, it is really required. In this consensus, we could get that those patients type 2 who are on insulin therapy or who are on hypoglycemia, they should be doing their continuous glucose monitoring to achieve a time in range. But even for type 2 routine variety of type 2 diabetic patients, getting their continuous glucose monitoring or even intermittently using continuous glucose monitoring is also useful for them to achieve a tighter glycemic control without getting hypoglycemia. Do we have validation of time in range? Yes, there are some papers which show that the patients more in time in range, less the microvascular complication, lesser the time in range, more they are in microvascular complication. Then 2019, when time in range concept was there and it was endorsed by almost all the major organizations of the world, even by Diabetes India too, the American Association of Clinical Endocrinology in 2020 only, they have written that using continuous glucose whenever indicated to against patient in reaching glycemic goals safely, even for type 2 diabetes. So they had put 11 principles of comprehensive management of type 2, and in that they had using a continuous glucose monitoring is really useful for type 2 diabetes too. And on that, we had also written one more paper, use of ambulatory glucose profile for improving monitoring and management of type 2 diabetes. And even before 2017, we were having also, when Sadikot was there, we have written one consensus guideline for glycemic monitoring for type 1, type 2, as well as for GDM patients too. This was one more paper recently published with Anup Mishra and Dr. Jyoti Dev, that what should be the frequency? If type 2 diabetic patients, if we want to get their continuous glucose monitoring, how frequently they should do it. And at least what we want, those patients who are not very good under control, they should get their continuous glucose monitoring every 2 or 3 months. But relatively well controlled, even it be 6 months, but preferably once in a year for every patient. If they can afford, they should get their CCN too. So at this point of time, I will say that these 3 glucose monitoring technology, they are actually complementing each other, and they are essential for all type 1 and type 2 diabetic patients, whether it is finger stick testing and random blood glucose monitoring, whether it is A1C, which is 3 monthly, or by doing a continuous glucose monitoring. They all 3 technology are complementary to each other. Let me give an example for type 2. We all know about the type 1 diabetes. This is one of our patients in 2018. He had come to us talking that my sugars are very uncontrolled with A1C of 9.2. And 2 of the doctors already previously, they told me to take the insulin injection. I am not ready to take the insulin injection as I am having 6 years of diabetes with 9.2 HbA1c. Patient was already on triple drug with a glimepiride 4 milligram, with metformin 2000 milligram, and with vildagliptin twice daily. We explained the patient that ideally you should be on insulin if, as far as all guidelines is talking, with 9.1 with triple drug therapy, patient should be on insulin too. We explained the patient, let us put you on continuous glucose monitoring. I understood that patient is eating too much. By the history also, and by getting his report after 5 days, we could see that patient sugar are post-meal as well as fasting, everything is high. Again, to control this fasting, we need to add either insulin. But what we have done, if patient was not ready for this, I explained that once in a week, let me give you a GLP-1 analog, let me give you SGLT2, and let me stop your gliptin. And what we have done, we had put the patients on a 1.5 milligram once in a week injectable dulaglutide along with glimepiride reduced from 4 milligram to 1 milligram. With metformin twice daily, we continues and added SGLT2 inhibitor too. And I asked the patient that after 3 days, you please give me call. Patient sugar was relatively well controlled. I thought, let me reduce it from 1 milligram to 0.5. And then patient had come back to me after 10th day. I had seen his sugar is absolutely well controlled. On that day, I stopped his 0.5 milligram glimepiride again, and the patient was continuous with a continuous dulaglutide, which I explained that you have to take again after 2 days, because on 30th he has taken. So we wanted to give him again on after 7 days, that is on Tuesday on 6th. So patient will take on 6th, and I continues him on a metformin and SGLT2 inhibitor on 6th. Again, patient had taken 1.5 milligram, and patient had come to me on 8th Feb, and you can see the sugar is absolutely well controlled. So what I want to tell that, the patient who was actually, as per the guideline, patient was required injectable insulin, but what we had done is injectable GLP, and this we could do only because we have this technology of using continuous glucose monitoring, and that could motivate the patient that yes, this is going to help. And after 6 months, the patient sugar is absolutely well controlled. Even HbA1c is less than 6. For 2 years, patient continued on the GLP-1 with SGLT2 and metformin. The patient's weight is reduced almost by 15% in 2 years. In first 6 months, it was very high. Now we stopped even after 2 years, we stopped the patients only put on metformin and SGLT2. Patient is still continuously maintaining the diet control, and recently before some time, we had stopped even his SGLT2 also. Now patient is only metformin once in a day at bedtime with HbA1c of less than 5.10. That is what we can say, that almost patient is reverse diabetes and with minimal medication is still maintaining the sugar, lifestyle modification and minimal medication. And this all we could do because of this advent of continuous glucose monitoring. So it's really changed the paradigm. It really changed the way we were treating the diabetes. Is completely changed with the use of continuous glucose monitoring, not only in type 1 diabetes, but in type 2 diabetes too. You may have different type of patient, this patient with a fasting hyperglycemia, post-dinner, post-lunch, post-breakfast, and all these patients you can, tailor-based therapy you can make for these patients. So continuous glucose monitoring helps us for discovering unknown hypo and hyperglycemia, for observation of glycemic variability, assessing the percentage in time and time out of range, severity of hypo and hyperglycemia, provide actionable information which can be derived by CGM report, highlight the impact of behavioral variances. It analyzes glycemic effects of new intervention effectively and efficiently. It also gives us the care for diabetes patient getting digitalized, because during this COVID time, some of the patients who were using continuous glucose monitoring, even distantly, they can send you the reports and you can still manage them on a digital platform. So CGM enhance patient self-management, adherence, and confidence in diabetes management, not only for the patient, but also for the doctors. With this, I once again, thank you, Dr. Ashish, for giving me an opportunity, and thank you everyone who are listening. Thank you very much.
Thank you, Bansi sir, for blessing us. And Kanan, over to the chairpersons.
I think it was recorded lecture. So if any questions, Ashish, how to take up questions?
You can manage it. Use.
Yeah. So is there any questions from the audience? And
sorry, sir.
No, Chairperson. There are no questions in the chat box.
Yeah, so just to summarize that part, Dr. Bansi Sabhu's part, that we should go ahead with the newer technologies and they are going to help us. And as he has beautifully shown us, the graph which from uncontrolled to a nicely controlled and improving the time in range is going to change the scenario of type 2 diabetes. So over to you, Dr. Kanan, for proceedings.
Yeah. Thank you very much, respected speaker, Professor Bansi Sabhu, for the wonderful talk on the recent updated glucometrics on time in range. And we are in the era of precision diabetology. We are practicing the modern medicine. So this concept is very, very useful in our routine clinical practice to prevent the complication, both macro and macro complication. Thank you very much, sir. So let us move on to the next topic. Another important topic on the remission on diabetes, for which we have the esteemed chairpersons. Is a pleasure and pride to invite the chairpersons in this August audience. We have Dr. Imran Alps and Dr. D.S. Barani to chair this session. Chairperson, slides are there?
Yeah. Thank you very much. Our next talk will be by Dr. B.M. Makkar. And Dr. Makkar doesn't need any introduction. He's a well-known personality on national and on international platform. And he is also the founder and director of Dr. Makkar's Diabetes and Obesity Center in New Delhi. He's also an honorable secretary RSSDI, ex-chairman RSSDI Delhi chapter, also on the member executive board of Diabetes India, and also an honorable secretary of Indian Obesity Network. Also a member of ACE International Committee in 2014 and 2016 and 17, and was invited by special invitation by the American Diabetes Association, member of EASD and Canadian Obesity Research Network. He has various publications under his name, and also a certified trainer for stage diabetes management program from International Diabetes Center, Minneapolis. So Dr. Makkar will be talking on remission of diabetes, one of the current trend, and being a
Sorry to interrupt, but Makkar sir is traveling, so not joined the session.
Okay, no problem. Whenever he is free, Priya, you can talk to him. And Imran,
yeah,
you can be with us for the next talk also.
He can run with his recorded lecture.
He has given you recorded, Riya?
No, sir.
So we will be catching him whenever he's landing. He's in the flight.
Yes. So the next session is Dr. Minal Mohit.
No, Bansi sir has joined. Bless us. Bansi sir.
I am there, boss. मैं तो कब से join हूँ? I can see Minal मुस्कुरा रही है.
Good evening, sir. Good evening, sir.
Sir, good evening.
Very, very good evening to Dr. Kanan, Kiran,
Yes,
Imran, Parikshit. I can see everyone.
Yes, sir. Thank you, sir.
Thank you, sir.
Tell me, sir.
Thank you, sir. Thank you, sir.
To paradigm shift to the TIR, sir has given us the recent advances. So, Kanan, any message from Bansi sir you want in the chat box?
I think our mentor has delivered all the important relevant points to our audience here. So there are no more add-on messages over here.
So now time in range had become a popular concept in our country. I don't think anyone have any doubts.
Yes.
So time in range is very important and everybody should do CGM in appropriate patients. That was the message, and give the best treatment possible. So, moving on to the next topic. Thanks a lot, Bansi sir, for blessing the event.
Thank you, sir. Thank you. Thank you.
The next topic, biomarkers. Ashish. Shall we move to the next topic, Ashish? Yeah. So, dear friends, we are moving to yet another important topic, that biomarkers on diabetes, by our Professor A.K. Das. For this to chair the session, we have the eminent chairpersons, Dr. Dimit and Dr. Dimit is Fellowship in Endocrinology, Diabetes and Metabolic. Is a consultant endocrine diabetes and metabolic physician in Surat. Dr. Parikshit Goswami is a consultant diabetologist and metabolic physician in CMC, one of the prestigious institutions, CMC. Over to you, sir.
Thank you very much, Dr. Ashish, and once again, I heartily congratulate you for arranging NDID 2022. Moving ahead, can I have a speaker introduction slides?
The speaker is Dr. Minal Mohit, ma'am. So please introduce them.
Okay.
Show me the slides. Lias, please display
Yes,
the
yes,
slides.
I'll share.
Everybody knows the Dr. Minal Mohit, who is one of the leading diabetologists, endocrinologists from city of Jaipur. He has done his MBBS, MD, FD, FEP, and many accreditation across the world. And she is heading a department of endocrinology. Her affiliation at Manipal Hospital, Jaipur, and director Shashakt Endocrine Center, and a lot of achievements to her credit, like mentor of Team India, pioneer of Cloud Clinic venture amidst COVID-19, governing council member of RSSD Rajasthan chapter, founder of Women Practitioner Forum, and many, many more. I hand over session to Dr. Minal Mohit, ma'am, please.
Minal, thank you for joining.
Thank you, Parikshit, for introducing me so kindly with all your kind words. Ashish, first of all, congratulations for so wonderful organizing the Conference 22, NDID 2022. So heartiest congratulations for the successful event, and thank you for inviting me here. So kindly allow me to share my screen. The topic that has been given to me by Ashish for this evening is steroids and diabetes. So steroids and diabetes, that would be my topic for the evening. Steroids affect anybody who is receiving the molecule, may it be diabetic population, may it be a non-diabetic population. So how do the two populations differ in their behavior when they are administered steroids? So steroid-induced hyperglycemia in people with diabetes and in people without diabetes. And as we know that this molecule was very rampantly used for COVID management, and we really cannot escape this molecule, though we know that it is going to rise the sugars. So let's go through it quickly in the next 20 minutes. So the agenda would be, how does steroid induces hyperglycemia? And though we all know it, yet we overlook it. And then how do we manage it as physicians? So that would be the agenda for the sessions. So first, let's have a look at steroid-induced hyperglycemia. So most of the population that is hospitalized, you will find that almost more than 10% of the inpatients do receive steroids. And out of these 10% of the population, 40% of the times it is a respiratory disease. Though we do have onco department also very frequently using steroids, we also have the gynae department who's giving us references because they are administering betamethasone. So we do have other population also, but as we know, COVID pneumonia was one of the major indications in the past 2 years for patients receiving steroids. If we look at the general population, you will find that almost 1% of your total population is already receiving steroids. As a result, almost 25% of the burden is always moving with steroids on their prescription for more than 6 months. So steroids is one of the widely prescribed molecule. It can be prescribed for anti-inflammatory roles. It is prescribed even in the transplant patients for the immunosuppressive roles. So this molecule is very widely used, and this molecule has various preparations available in the market, and almost all we are using at different times. Just having a glimpse at the potency of the different molecules and how do they differ in their duration of action. Hydrocortisone, as we all know, is the most physiological molecule. It is 8-hourly acting, so we administer it 3 times a day. Then we have the equivalent in the ratio of 1:5, that is prednisolone. We have methylprednisolone. And the longest acting, the dexamethasone and the betamethasone. Betamethasone, as we just discussed, is most commonly used in the gynae practice. And dexamethasone is another molecule, long acting, which is very often prescribed. So depending upon their duration of action and the dose, their effect on blood glucose levels differ. So beginning with hydrocortisone, which is a short-acting glucocorticoid, you will find that the moment it is administered, the sugars start rising within an hour, and they peak around 3 hours, and the sugars just settle down within 6 hours. If it is administered 3 times a day, there will be 3 peaks. If it is administered twice a day, there will be 2 peaks. And this molecule is most commonly used in adrenal insufficiency, times of acute illness or stress or surgeries. Methylprednisolone is most commonly used as pulse therapy. Then we do have prednisolone, which is commonly used for a very long time. These molecules, they do act for almost 12 to 16 hours. And as a result, you find one peak around 8 hours. The sugars start rising slowly. So if the dose is administered in the morning times, you will find that the sugars start rising by pre-lunch session or even the post-lunch sessions. And by the time, evening time, the sugars do settle down. These are the molecules which are most commonly prescribed steroids for their immunosuppressant roles, anti-inflammatory roles. They are used in organ transplants and the respiratory diseases. Dexamethasone, which is one of the most commonly prescribed molecules during the COVID pandemic. It is one of the longest acting as well. The action lasts for almost 24 to 36 hours. Now, what are the guidelines about pandemic COVID-19 and the steroid usage? The guideline says if the disease is a mild one, go for inhalational route and just go for 5 days of steroid treatment. If the disease is moderately severe, then you can use methylprednisolone IV or oral, but the duration is again 5 to 10 days. And the dose has to be 0.5 to 1 milligrams. If the disease is very severe, then you can double the dose and the duration is 5 to 10 days. So remembering these guidelines, because though these were not very strictly followed, but these are the guidelines as per the national bodies. So now look here, almost 32% of the non-diabetic population receive steroids and they do land up with hyperglycemia. And out of this 32% of the population, 18% never go back to the non-diabetic level. That is, they become diabetic forever. That is, unmasking of diabetes does happen. So let's just revise the definitions just to avoid confusion. Whenever we use the word steroid-induced hyperglycemia, we are talking about patients who are already diabetic and the sugars have worsened because of the steroid administration. When we talk of non-diabetic population having hyperglycemia, we talk of the word as steroid-induced diabetes. And when we talk of steroid-induced diabetes, we always mean we do not know whether the patient will go back to the non-diabetic level or will remain diabetic for the times to come. So what are the predisposing factors or the risk factors which will tell you that which patient will have hyperglycemia, which patient will have diabetes, and which will not go back? So let's have a look at the risk factors. If the patient is already diabetic, that is 100% universal that a patient already diabetic receiving steroids will have hyperglycemia. A patient with a family history of diabetes, patient with a previous gestational diabetes history, patient with previously impaired fasting or impaired glucose tolerance, patients with PCOD or obese population, patients with ethnicity which is more vulnerable, or if there is history of hyperglycemia in the previous usage. So these are the risk factors which will tell you that these patients are bound to have steroid-induced diabetes or steroid-induced hyperglycemia. What is the pathophysiology behind this? The glucocorticoids, as we understand, will cause increased glucagon release, inhibit insulin. At the same time, there is also inhibition of the incretin effect. There is inhibition of the capillary recruitment. There is inhibition of the glucose uptake by the muscles. And there is increased proteolysis, that is catabolic status. There is increased lipolysis, and there is increased gluconeogenesis. So all this sum up to hyperglycemia. So hyperglycemia results from protein breakdown, causing protein getting converted into glucose. That is, there is gluconeogenesis. The pathophysiology of gluconeogenesis is through enzymatic pathways. Then there is decreased glucose uptake by the muscles, causing further release of blood glucose in the rise in blood glucose. There is increased glucagon, there is insulinopenia, and there is increased lipolysis. So this is the pathophysiology, how glucocorticoids cause rise in blood glucose. Now, what will happen on the blood glucose? If you are giving a single dose of glucocorticoid, that is prednisolone, is administered, you will find, as we talk, because this is an intermediate acting steroid, the rise in blood glucose will be by late morning or through evening. By the time the patient gets up in the morning, the steroid hyperglycemia is usually not seen as a fasting hyperglycemia. It is mostly a postprandial hyperglycemia. But if you're dealing with long-acting steroids, that is dexamethasone, you will find that the hyperglycemia persists throughout. So there is fasting as well as postprandial hyperglycemia. How do we diagnose? Now, whenever you have a patient who's planning to receive steroids, always go for a baseline glucose level checking and also educate the patient on self-monitoring of blood glucose, because if the steroid is administered as a tablet form as OPD prescription, then you must counsel the patient for self-monitoring of blood glucose. Then if the blood glucose any point of time is above 180, then ask the patient to increase the frequency of self-monitoring. And the standard criteria holds for the steroid-induced hyperglycemia as well. That is, if the fasting blood glucose is above 126, or at any point of time randomly the sugars are above 200, or if the HbA1c is above 6.5, then that patient is having steroid-induced diabetes. So the diagnostic criteria remain the same. Now, what are the targets? Once you have known that the sugars are rising, the patient is bound to have steroids. So what are the targets? Again, the targets are almost the same. Whenever the patient is hospitalized, try to keep the sugars between 108 to 180. These targets can be liberal, as we always individualize the targets. So even in such population who's receiving steroids for some cases which are terminal, or people with dementia, frail older population, people at higher risk of falling, or people who have variable appetite or dietary intake, you can keep the targets liberal. That is, you can always individualize, but the standard guidelines recommend that your sugar target should be between 108 to 180. Now, how do we do it? In people without knowing that they are already having diabetes. No diabetes history, so at least monitor once a day. And if you find any sugar rising above 216, this is the figure taken from the British Journal guidelines. So if the sugars are rising above 200 at any point of the time, increase your frequency of monitoring to 4 times a day. And if the sugars are persistently high, then of course you have to start the treatment. If the patient is already diabetic, then right from the beginning, monitor 4 times a day. And if the sugars are consistently above 200, in spite of the presently ongoing treatment of diabetes, then we need to up-titrate the management. So this is the part 1, that is glucocorticoids have been widely used for different reasons, different medical conditions, and they may be very good molecules in terms of their immunosuppressant effects and anti-inflammatory effects, but they always come with a double-edged benefit of harm of hyperglycemia rather. So we have to diagnose early that steroids are causing hyperglycemia and we need to manage them quickly. So how do we manage the steroid-induced hyperglycemia? So preferably we keep them on insulin. Though we do have OHAs in pipeline, we can use sulfonylureas, we can use pioglitazone, but these are molecules. OHAs will have their limitations that we will discuss in the next slide maybe. Preferably we use human insulins. We can use even NPH at this point of time, and we can also use the basal insulins, which are the most preferred molecules as they are 24 hours acting, and thus long-acting steroids are also going to cause hyperglycemia, which is going to persist for 24 hours. You can preferably use MDI, that is the basal bolus regime, which will also control the postprandial hyperglycemia, because as we discussed, that steroid hyperglycemia is more of a postprandial hyperglycemia. In patients who are already diabetic, OHAs need to be stepped up. You can especially increase the morning dose because we know it is a postprandial hyperglycemia. You might need to increase the before dinner dose also, but very rarely we do that. We are initially giving a step up to the morning doses. Patients on insulin therapy, the morning doses are increased by 10%. The patient who are on basal bolus plan, again, you can increase the basal dose by 10%. Every 2 to 3 days, you can go on increasing till you get your targets. If the patient is on pre-mix formula, then again, there's a 10% increase recommended in the morning doses and not the pre-dinner doses. In type 1 children, again, the recommendations are just the same. Give a 10% rise in the basal dose if it is a basal bolus plan. If the child is on a pre-mix formula, then give a 10% rise in the morning dose. In the basal bolus plan, again, you can also give some rise in the lunch and the evening meal dose because it is again a postprandial hyperglycemia. So the strategy remains, if the patient is treatment naive, you can try OHAs like sulfonylureas or even glitazones. You can always try the intermediate acting insulins. If it is a treatment experienced patient and the patient is being administered short acting steroids, you can combine them with intermediate or long-acting insulins. If you are planning to start a long-acting steroid, at the same time, add some long-acting insulin along with a prandial insulin. So that is the treatment strategy. OHAs, as we were talking, yes, you can use sulfonylureas, you can use glitazones to increase the insulin sensitivity, but OHAs will have a limited efficacy because of their slower action. They are not very flexible. You cannot titrate them easily and quickly. And the action will not coincide with the peak of steroid action. So this is a limitation of OHAs. So preferably we try to keep the patient on insulin as far as the patient is on steroids. Insulins will have immediate onset of action. They will be easy to titrate, unlimited efficacy, greater flexibility and predictability. And of course, they will target your postprandial hyperglycemia as well as your fasting hyperglycemia. So insulins are always a better choice. Again, revising the protocol. If there is a steroid hyperglycemia, fasting sugars above 126 and a random above 200, just start with insulin. Again, if there is a preprandial blood glucose value which is less than 200, you can continue the same treatment. But if it is rising above 200, increase the monitoring. Think of OHAs if it is a new patient. If the sugars are still rising, not controlled with OHAs, shift the patient quickly to insulin. Which insulin? Again, if it is an intermediate acting or a short acting steroids, you can add a NPH, that is a human NPH. If it is a long acting steroid, you can always think of basal analogs, which are 24 hours acting. If still the sugars are not controlled, you can also go for basal bolus administration, that is a multiple daily injection regime. So how do we titrate, up titrate or down titrate? Just a rough guideline, of course. If you're thinking of a dose of prednisolone of around 40 milligrams per day or a dexamethasone, which is equivalent to 8 milligrams per day, so 4 is 0.4, 30 is 0.3, 20 is 0.2, and 10 is 0.1. So this is a rough guidelines. How do you calculate the dose of insulin when you are given a reference that this patient is now being administered prednisolone 40 milligrams a day? So you think of some basal insulin, whichever is your choice, that you start with 0.4 units per kg per day. And then, of course, you can up titrate and down titrate because the patients are always individualized and the response will always differ. So as per the British guidelines, all patients with type 1 or type 2 receiving steroids should be having blood glucose monitored through the glucometers, of course, and non-diabetics should be monitored at least 4 times a day. The targets are 108 to 180. In case there is a hypo risk, you can always down titrate and you can keep the targets a bit liberal. In patients who are on insulin, already on insulin, then the insulin dose has to be adjusted every 2 to 3 days. Initially, you can go on increasing or decreasing by 10 to 20%. So if the steroid dose is increased, you can always increase your insulin dose. If the steroid dose is tapered down by the oncologist or by your nephro team or whichever is the primary consultant, you can always bring down your steroids. Even your pulmonologist will keep on tapering the steroids here and there. So whatever is the percentage change in steroids, correspondingly, half of it you bring down or bring up your insulin. For example, if the rise in steroids is by 50%, your insulin rise should also be 25% higher. If you bring down the steroids, bring down the insulin proportionately. Most importantly, in patients who are on basal bolus plan, you might not always require to change your basal dose. You always, more oftenly, you need to change your bolus dose because it's a prandial hyperglycemia. So from 50-50, you can change your formula to 30-70. So keep your basal as 30 and keep your prandial as 70% and then divide this 70% prandial into 3 meals, that is the breakfast, lunch, and dinner. Always you can up titrate and down titrate depending upon the patient response. In patients who are only on basal, then you might need to add a prandial with lunch or the evening meal. So that is always individualized. Now, this is the algorithm. How do you approach the patients? So if depending upon which sugars are rising, there's a fast rise because of short-acting steroids and this rapid-acting insulin proportionately as 0.1 units per kg. So just going like this, if there's a short-acting steroid, a fast rise in sugars, and a rapid-acting insulin, there will be a rise in postprandial sugars. So accordingly, adjust your prandial insulin. If there is an intermediate-acting steroids, you might need an intermediate-acting insulin. The dose we always know is according to the dose of the steroid. So it is 0.2 or 0.3 or 0.4. Accordingly, if there's a postprandial rise, add a prandial along with it. If there is a long-acting steroid, then accordingly add a long-acting insulin, right? So this is the algorithm. And preferably, if you are using a very long-acting insulin, then that is going to give you a 24 hours control. So the formula to remember is, as the primary consultant is tapering or up titrating steroids, play with your insulin accordingly. So this is the strategy. A new patient planning to start steroids, non-diabetic, HbA1c less than 6.5 means non-diabetic. So just monitor the sugars. If it is above 200, monitor more intensively and add insulin. If the HbA1c is less than more than 6.5, that is already known diabetic. Monitor 4 times right from the beginning, depending upon the risk factors as we just discussed, known history of diabetes, family history of diabetes, gestational diabetes, obese patients. These are the patients who will have very high hyperglycemia with steroids. So right from the beginning, add insulin according to the dose of the steroid. Now, consider the up titration and down titration as per the guidelines. Preferably use insulin. Non-insulin therapies will not give you a good glycemic control as long as the patient is on steroids. So these are the guidelines for the long-acting insulins, long-acting steroids, long-acting insulins, and for the short-acting insulins, you can use prandials. Doses we just revised for 40 units of 40 milligrams of prednisolone, it is 0.4 units per kg of basal insulin. So just to summarize the last slide, maybe. Treatment with insulin should be considered the degree and pattern of hyperglycemia and the type, dose, and schedule of glucocorticoids. So it is the steroid which is the guiding force. Your primary guide is the steroid. And of course, the patient. Patients are always the primary for all of us. And the treatment should be adjusted based on the glucometer readings because we cannot wait for the lab reports to come every time, and the capillary blood glucose is always accepted. Moreover, it is essential to instruct the patient and the family for the OPD treatments to keep monitoring their sugars and keep adjusting their insulins. Steroids are widely used and we cannot do without them. They are very good molecules at places where we just really want only steroids to be in action. But then everything has two faces. They come with their added complications and side effects. That is, hyperglycemia is one of the most complicated challenges for all of us. As a result, we need to know how do we face this challenge, and we have an equally strong weapon to manage the glucocorticoid-induced hyperglycemia, and that is insulin. We must know our insulins well, and we must know which insulin to use, how and where. So long-acting insulins for the longer-acting steroids, along with the prandial insulins. So steroids along with insulin will give us a good glycemic control, and our patients will be soon out without any side effects. With that, I think I thank you all for being here this evening and listening to the session. And once again, Ashish, thank you so much for inviting me here.
Thank you very much, ma'am, for an excellent talk. I couldn't see any questions in the chat box.
Thank you, Meenal. And the very important topic during COVID era, which we have faced. So I hope the Meenal have given you the gist of managing the diabetes in this stage. Over to the chairperson.
Can I have a question, Dr. Meenal?
Yeah, please, sir.
We are after the COVID era, we are using a lot of dexamethasone and prednisolone, methyl prednisolone. So with this compound, we are getting a huge number of secondary diabetes. But how about this incidence and prevalence of secondary diabetes, hydrocortisone? Because hydrocortisone is short-acting. In that case, if there are any incidence or any idea about that, Dr. Meenal, ma'am?
So this is very right. The hydrocortisone is a short-acting, and also it is one of the most physiological hormone that is we are using it. But hyperglycemia will happen if we are exceeding the physiological doses, because physiological doses are only 7.5 milligrams per day, which is released from by the adrenals. So the moment you exceed the physiological doses, it is the end results are just the same. That is giving you hyperglycemic peaks. And any patient who's having hyperglycemic peaks with hydrocortisone, or for that matter, any steroid, is vulnerable for hyperglycemia, vulnerable for diabetes. That means he or she is at risk of diabetes sooner or later. So there are incidences where patients have been reported to stay with hyperglycemia. They just did not recover. There are patients because of their lifestyle changes and lifestyle management, they did recover. So though I do not have exact data as such that how many of hydrocortisone-induced hyperglycemic patients and how many of the dexamethasone-induced diabetic population we have, but we do have patients who did recover after steroids also. They could control because of, maybe in remission, I would use the word maybe in remission because of their lifestyle managements. But they are at high risk still. With all the steroids, the results are almost the same.
Thank you, Meenal, ma'am.
Dr. Meenal, a quick comment.
Yes, sir.
A very recent publication in endocrine practice, which actually tried to divide the patients depending on whether they were on prednisone less than 10, between 10 to 40, or more than 40 milligram per day. and then they were either on a basal insulin or a basal bolus, as you have already discussed that. Had actually come to a conclusion that for a broad discussion, you had gone into a heavy nitty-gritty, but a broad discussion is the dose of insulin required. Basal bolus, the dose required, how many units of insulin per kilogram body weight per 10 milligram of prednisone. And then in the other group, that dose was only basal insulin. And the dose generally is 0.1 unit per kilogram body weight, insulin per kilogram body weight per 10 milligrams of prednisone used. In the overall dose, that is the basal bolus together, the dose is 0.296 onwards, depending on whether the dose of prednisone is 10 or more than 40. So that is something which probably can be useful for maybe our ICUs, where we can put those charts so that we can easily follow that. That's more precise depending on the weight of the person as well.
Exactly, sir. This is what we discussed, that depending upon the dose of prednisolone, if it is 10, we go by 0.1. If it is 20, we are going by 0.2. And as you rightly said, that anybody less than 10, that is 7.5, is actually physiological release of steroid from the adrenals. So till the 7.5 milligrams of prednisolone being used, there is hardly any effect on the negative effect, I should say. But as you go on increasing the dose, and especially if you are giving it for a continuous 2 weeks, the adrenals go into a shunt. There's actually a shunt effect. There's a stunting effect. So the adrenals go into a state of shutdown. So it's only if anybody is on steroids for more than 2 weeks and more than physiological replacements, then of course there is a rise in blood glucose.
Certainly.
And that blood glucose might not recover once the steroids are taken off also. So that is what is the story that we are talking all about.
It's a matter of chase of sugars.
Yes, there is.
A good presentation, Minal. Good presentation.
Thank you, sir. Thank you so much.
Thank you, Minal. Move on to the next topic, Kanan.
Thank you, Ashish. Thank you so much.
Kanan, we are getting
so, dear friends, let me move to another important topic. We are practicing the diabetes technological era. So, setting a technology savvy in diabetes clinic. For this, we have eminent chairpersons, Dr. Prabhat Agrawal and Dr. Jaideep Ravel. Dr. Prabhat from SN Medical College is a professor of medicine, Agra. He completed FRCP Edinburgh, FRCP Glasgow, and FICP, FIACM, and MAMS. And Dr. Jaideep Ravel is the Director and Chief Diabetologist of Ravela's Diabetes Nutrition Care Research Center. Over to respective chairpersons.
Thank you, dear, for a nice introduction. Today, now we have very learned speaker from Mumbai. He needs no introduction. Just for a social introduction, I want to invite him. Dr. Rajiv Kohli is a medical director and consultant diabetologist from Mumbai, and he's also consultant at Nanavati and Raja Hospital. He is a speaker for many. I'm audible. Yeah, he is a speaker for many international national forums. He is invited faculty for Diabetes Fellowship Program at D.Y. Patil. He is a founder member and secretary of United Diabetes Forum, the vice president of the Indian Podiatric Association, very active member of Indian Podiatric Association. He is currently having secretary for the RSSD Maharashtra, and he has so many publications and trials to his credit. So I invite Dr. Kohli for his deliberation.
Welcome, Rajiv bro. Welcome, Rajiv bro.
Thank you so much. Thank you, Jaideep. Thank you, Karnam. Thank you, Ashish.
Welcome, Rajiv.
Thank you so much, Ashish. So Ashish has given me a good topic. He himself is very tech savvy. 1 minute, let me see. 1 minute, just hold on. I've got a lot of presentations out here. 1 minute. Just a minute. Just a minute, guys. Just hold on with me. My computer is giving me something. So in a tech savvy, so-called tech savvy, I'm not so tech savvy. can't find my presentation. Just a minute, guys.
There is a lot of presentations. Daily 10 to 4 presentations.
That is the problem actually, but let me just.
पर्दा सरक गया है, हिंदी में लिखना है। पर्दा सरक गया है और लेंस नहीं डाला।
Sorry, there's some. Dialogue box only. I'm going to go very fast and we're going to talk about how we make our clinic to actually not only improve our practice but also give a good quality of life to our patients. No conflict of interest here. We have to realize that the society is changing. Our patients are more techno-savvy than us. And there's a huge importance of technology in diabetes management. And today they have invaded us actually. First and foremost is digitization of the clinic. So what do I mean by digitization? Is have files in an electronic format, converting media to an electronic form, turn this into this kind of a thing is what I mean by digitization. And digitization is keeping information in a very discrete units of data that can be separately addressed as such. And digitization has taken over, and for us, COVID has been a huge blessing in disguise that all of us decided to get digitized during the COVID era. Now, what was the current clinic that we have? We have doctors like this. This is Dr. Revale in his young days. No IT infrastructure, manned by doctor himself and a maximum of 3 to 4 assistants. And this is what we have, patients waiting outside. This is the interface we have. And can we do better? Can IT in a user-friendly way make process a lot simpler and effective? Now, this is a sample patient who, before coming to me, somebody has recommended him to me. He has swelling of foot and he decides to first Google. Most of our patients would Google us, would Google our symptoms, Google our prescriptions, everything. So he Googles. So when he Googles, you have to make sure that you are right there in terms of SEO so that people find you right up there as somebody who's there on the digital space. And the world has become very, very flat. So as soon as he Googles me, he finds me right up there. And he can directly go onto my website and then look at all the things that we do in the clinic per se. Now he schedules an appointment. Now the appointment could be scheduled online, could be scheduled offline. But before he comes for an appointment, he has the opportunity of having a pre-consultation communication. So he can put in all his, whatever, all these all these things take 5 to 7 minutes from our staff. And this could be done by the patient at home itself, that his basic information about himself and about where he lives and all these simple factors. So at the reception desk, it's become very, very easy. We just have to give him a tablet or an iPad, and we have everything in there as such. Obviously, we now know that we don't require a real physical interface, and vitals can be recorded, and everything can be given in an animated real-time format in a new clinic as such. That is what we would call as a smart savvy clinic. Consultation can also be digitized. You can show him his trends as we are showing him here. We can show him his trends on all his anthropometry, on his biochemical, all his laboratories. We can show him his trends. We can give him a paperless prescription so he walks out without a file, without a paper, or we could even email it to him, to his pharmacy, or to his email ID as such. So that's how EHR helps. Its documentation is the integral part, and data is the new gold. Easily assessed, shared quickly with other professionals, it improves clinical decision making and disease management. Patient privacy and confidentiality are some ethical concerns we have with EHR. A lot of difference between EHR versus paper records, and EHR clearly wins when we talk about a smart savvy clinic. What is the benefits of the smart savvy clinic is that you have online medical records, data is encrypted and securely backed up, easily recovered, and you using permission-based data access. So there's a cloud computing which occurs continuously. Scalability, you can scale your cloud storage to whatever you want, and you can also use it for a lot of your research activities as such. Mobility, you can be anywhere. Like right now I'm in Delhi and I could consult my patient from here itself, which I did today, by having an EMR and a cloud backup as such. And patient could be anywhere across. Secondly, a lot of intuitive EHRs are there. Like if you have a patient who has not undergone a fundus for long, or who has not undergone a foot evaluation, or his vaccination dates are close by, the EHR itself will pull up those records and give it to you that, or flag it off to you that these patients require these XYZ tests or XYZ services as such. So physicians can remain connected with patients as well as your colleague. People who refer to you or whom you refer to can be sent a PDF or could be sent a link on about the patient. Repeat diagnostic tests can be avoided, and that becomes very, very easier. It can be, if you have a large space like a hospital, you could integrate it with the pharmacy, with the pathology and the radiology. And today you, as Dr. Bansi was speaking about CGM, you can integrate it also with the CGM or with other Bluetooth enabled SMBG devices that we have. So telehealth and telemedicine both describe the use of technology to exchange information to improve a patient's health status. Telemedicine is the definition is the use of telecommunication to support healthcare. Today, fortunately, we have since the start of the pandemic, the telemedicine has evolved, and teleconsultation has been approved as a normal form of consultation. In terms of referral portal, you could invite referring doctors to the referral portal so that those doctors could also view what is happening to their patient. You could have a scheduling of your appointment, and suppose you are referring it to somebody in a real time, it can be sent. Messaging can be done, even chart and all kind of bar diagrams can be done. There can be real-time status updates between doctors throughout the process. You have integrated patient development software where you can have a real-time status, and the outcome can be sent to referring doctor to close the loop. So this improves patient recall and compliance. Biggest benefit for the doctors that it helps doctors better manage patients' health. Cloud-based patient education programs improve patient recall and compliance because they allow people to access procedure explanations and video, and whenever they're thinking about their health, it can be done. So it becomes very, very easy form of e-learning. You can also have a central source of patient education. That's something which I have seen. I have not yet integrated into my EMR as yet. But if suppose you have a patient who's GDM and she's waiting in your clinic for the last 1 hour, you could send her all the pre-gestational,
gestational advices, pre-conception counseling, everything to her while she's waiting. So by the time she walks in and is with you in your cabin, the time is not wasted in explaining the same thing. SMBG, how to initiate insulin, how to inject insulin, types of insulin. Now we have drugs which we have to give half an hour before breakfast, empty stomach, how it works, what are the side effects. All these can be a central source of patient education. And while the patient is there and while the patient has left the clinic, you can use this for a lot of patient education as such. So again, you have patient education, you have an education library, medication library, you have email notifications, and My Recovery is also there. So these are the benefits of Smart Clinic. It also helps us as a marketing tool in terms of getting access to our patients who can come up to the website and probably also leave a testimonial, because many a time patients look at a lot of reviews of us before they come to us. So that also helps as such. Again, I would say that these are the various things or headings that one can have in a smart clinic, and especially in terms of payment. You can digitize your finances. Today, my Form 4 is integrated in my EMR. So there is no need for the CA's job becomes very, very easy. All the payment is done either digitally or otherwise. The payment is digitized and you get a Form 4 as well. Follow-up strategies, you can put dates, you can have reminder dates. As such, right now, it's not equipped to send on WhatsApp, but your SMS alerts can go, and that itself would help in proper follow-up and compliance of our patients. So SMS health alerts and reminders can come in, which can keep in touch with your patient via an SMS. So again, WhatsApp is there. I'm just going very, very, social media is a very important parameter and a great tool for connecting with our patients. And you need to be there everywhere in all kinds of personal and professional online presence. So whether it's Facebook or LinkedIn or Twitter, you need to be there. So again, a lot of diabetes self-management, education and support, and technology has integrated it. I'm just going to go into certain diabetes self-management, which is there across the globe. You have a lot of mobile apps, which can have an interactive mobile app and a meal planner. You can have all these things which are very cost effective. Now we all have all these kinds of trackers which can be there, and it can be integrated to a EMR. So that when the patient comes, we realize how much he's done. We can have all these parameters, whether blood glucose logs, insulin, carbohydrate, activity, and mood being assessed. You also have a lot of apps which can directly be connected. Today, you have another cheaper real-time CGM which can be connected to an Android base, which can be connected directly, synced to us and to our EMR, so you can know what is happening to our patient. So a lot of benefits have been there in terms of apps and digital services, and habits can change, and that's what I would realize, that diabetes finally is a sort of behavioral therapy. And if we can integrate all this, we can have a good use of technology for diabetes treatment as well as diabetes complications. Thank you so much for the patience. Over to you, Kannan.
Chairpersons?
It's over, Raju?
Yeah. Over. Yeah.
Okay. Okay, that was a great presentation. After a long time, we have seen the presentation without any clinical trials, and it was more of the practical aspects. So I hope this presentation really helps delegate to digitalize their clinic. So I think from my side, there are no questions. If there are any questions.
No questions, Chairperson, no questions.
Okay, great. So thank you very much. Thanks, Raju. And thank you, Ashish, for inviting me as a chairperson.
Thank you, Raju, for the wonderful talk. Thank you.
Thank you.
Okay. Ashish, are you there? Yeah. Dear friends, we are moving yet another important topic on diabetes technology. For this, we have technology king. We know about Jyotidev Kesdev, Professor of Technology King. We're going to talk on interpretation of CGM and TIR. For this, we have the eminent chairpersons, Dr. Ami Singhvi and Dr. Kotika. Ami Singhvi is a consultant diabetologist and co-director of Sangvi Eye and Diabetes Care Center, Mumbai. And Latika Progod Madam is Director and Diabetes Care Center, Kulova, Mumbai, and visiting diabetologist, diabetes and obesity. Over to respective chairpersons.
So very good evening to everyone, and thank you, Dr. Ashish, for this opportunity. So it's an absolute privilege and honor to be introducing the speaker for this session. As Dr. Kannan rightly mentioned, the king of technology. I have the privilege of introducing Dr. Jyotidev, who is from Trivandrum, and he's the chairman of Jyotidev's Diabetes Research Center, Trivandrum, Kochi, and a managing trustee. He's editor-in-chief of International Journal of Diabetes and Technology, publishes a monthly internet-based free diabetes newsletter for the last 13 years. Is the first author for the Indian guidelines on vaccination, insulin pumps, and glucose monitoring. And JDC is an IDF recognized center of excellence in diabetes care and center for education, and is accredited for RSSDI certified course in diabetology for doctors. Sir actually needs no introduction. Over to you, sir, on the topic of interpretation of CGM and time in range.
Hello. Thank you, dear friends. And greetings from Kerala and happy Onam to all my dear friends. First of all, let me express my gratitude to Dr. Ashish Tenkra and the team, International Congress on New Dimension in Diabetes, for inviting me and giving me a very relevant and a very passionate topic, and that is time in range hemoglobin A1C and the role of continuous glucose monitoring. So these are my disclosures. I know that there are many, many doctors. Somewhere I read that there is close to 100,000 doctors graduating every year in our country. So there are many new doctors who may not be familiar with the evolution of technologies. We started using the CGMS gold, CGMS, the term is meant for the device and not for the technology. And this is the first device which we started using in 2004, and then came iPro, then came the FreeCell Libre Pro, then FreeCell Libre, the Guardian Connect. So technology is improving. Technology is advancing fast. And this is the ambulatory glucose profile, which is the downloaded data. And this looks like a 24-hour model graph, but this is the data of 14 grays of continuous glucose monitoring. And this is the shape. I will say that this is the overall pattern, and an experienced doctor can recognize that this is type 2 diabetes, which is well controlled. And this is the usual picture in type 1 diabetes. In type 1 diabetes, glucose is all over, and it is a roller coaster ride. And from AGP, you can easily recognize whether it is type 1 or type 2 diabetes. The history of ambulatory glucose profile and the current recommendations on the percentage time in range, the continuous glucose monitoring evolution, all of them probably goes back to International Diabetes Center and these two scientists. They are still very active. Roger Massey on the left and Richard Bergenster on the right. It was in the year 1987 in diabetes care, AGP as a story appeared from the original author, and that is Roger S. Massey. And there he had this information from downloaded data from glucose meters. Remember, it was in 1987. Continuous glucose monitoring devices were not around. The AGP is very often now compared with some devices. So dear doctors, AGP is not the name of any device. AGP is the downloaded information, and this is the graph or the pattern which is created. And nowadays, of course, in 1987, there was no algorithm, but over time, when it started from 1987, Bergenstahl joined the group, and in 2008, with the introduction of statistics and the profile graph, the IDC suggested that AGP should be recommended internationally for standardized glucose reporting. But it took decades for the ACE to endorse AGP in 2017 and subsequently by the American Diabetes Association in 2019. But still, I remember whenever we discuss about how to analyze continuous glucose monitoring, this often used to be the question from the doctors, from the diabetes educators, from the dietitians. How do you go around with this big data? There is a lot of information. There is a lot of information. So how to interpret this easily so that I can translate the information into either prescriptions or advices, rather than spending 1 or 2 hours describing and analyzing the data and then having conversations with the patients. And this was resolved with the international consensus. And now the ADA and the similar organizations recommend this is a model AGP report. So the AGP report will have 3 components, and in the upper panel you have the percentage TAR, and in the middle panel you have the classical ambulatory glucose profile. Now it is a color-coded chart, and then at the bottom you have the daily glucose pattern, so that you can have a meaningful counseling based on the daily graphs. And you remember the earlier days when we used to analyze the AGP, where you have the median, you have the 25th, you have the 75th percentile, the 10th, the 90th, and when it is widely spaced as seen over here, it indicates that there is a significant inter-day glucose variability. And this is a median curve in the middle. There is a blue line over there. And when it is going up and down, it indicates intra-day glucose variability. And if you have to analyze whether you need to change what is the exact impact of a carb-rich diet and how you can go into, how will you modify it? Are you going to make changes in the diet, or are you going to recommend some exercises, or are you going to make changes in the selection of a rapid-acting insulin, or modify the dose, or you going to change the timing of insulin, because even the rapid-acting insulins may not be that rapid enough. So many patients will require even an analog insulin to be injected 20 or 30 minutes before food. So all these decisions can be taken analyzing the continuous glucose monitoring. And I will say that from the ambulatory glucose profile, you probably can take 3 decisions, and then you can have it implemented, you can have it executed. And this is the reducing the variability. So we have before and after pattern over there. And then you can decide on how you can improve or modify, or whether you can make it more flattened, and that is improving the stability as shown here, and then reducing the overall glycemic burden, that is the overall exposure to the glucose can also be reduced. So when we are having a conversation with a patient or with a doctor, for example, a doctor can be there in practice for more than 20 years, and he probably will be very, very happy with using just the hemoglobin A1C for making decisions. So here you have 3 beautiful girls. They are, of course, they are not the same. They are not the same. The same can happen with hemoglobin A1C. They may all look the same with the same hemoglobin A1C as 7%. But when you are analyzing the continuous glucose monitoring data, the glycemic variability could be entirely different. For example, for this person A, the percentage time which is acceptable is just 18%, despite an A1C of 7%. Whereas on the patient on the right, 100% of the time, it is within 70 and 180 milligrams per deciliter. So there can be huge differences in the glycemic exposure, despite the same hemoglobin A1C of 7 or say 8%. And this is exactly the reason why, despite control of diabetes, patients can still develop the devastating complications. Remember, we were using Benedict's reagent as the only tool for monitoring glucose, and this was existing for more than 50 years. For almost half a century, we were all dependent on Benedict's reagent. And I still remember boiling this and using a test tube and deciding the dose of insulin based on urine sugar values. In 1987, the American Diabetes Association was convinced glucose meters were there in existence for a long time, but it took time for even ADA to endorse self-monitoring of blood glucose. And it is still the gold standard. But now we are, not gradually, we are rapidly shifting to continuous glucose monitoring because of the available evidence and information. So if somebody is asking you, there are some patients who will irritate you with some questions. And why you people are changing all the time. Yesterday you said that the glucose value is this much. And today you are saying that the normal glucose is this much. And this is the answer. This is the answer to such silly, irritating questions. Modern medicine is different from traditional medicines. In modern medicine, there is a research. In modern medicine, we keep on changing. We keep on improving. And this is meant for betterment. This is meant for improving the lifespan. This is meant for improving the quality of life of those affected with diabetes. This is a case of a doctor from another specialty, and she visited us with a diabetes of more than 15 years duration with a hemoglobin A1C of 10.5%. She is already on multiple medications, including insulin. We just recommended her to be on Freestyle Libre, continuous glucose monitoring using the flash glucose monitoring technology. Of course, every time she needs to scan either with the reader or with the app in the mobile phone. Of course, it is still not available in India. And we shifted her to a basal bolus regimen. And we also introduced her to liraglutide. Look at the pattern. Look at the graphs. These are the screenshots from the Libre reader on how, over a period of time, we could stabilize the glucose levels. Because she had a lot of issues, including the terrible pain of neuropathy. And this is after exactly 1 month. The percentage time in range is 84%. And the time below range, that is the time spent in hypoglycemia, is 0. It is possible. It is possible if you have a multidisciplinary team and if you have a learned person. And this is a doctor. You need to support her only for the initial 10 or 15 days. And most of the time, the patients themselves will be empowered for making decisions. This, I would say, has been a transformation. At the ATTD meeting, when the TER consensus has been agreed upon and published, where our own leader, Dr. Benshi Sabu, was an integral part, and she is still an integral part when this got published. And this, I would say, was a revolutionary change in the management of diabetes. The expert committee selected the following 10 key metrics. The number of days the CGM has to be worn, total 14 days, of which 70% of the data should be available. And this translates to at least 10 days of meaningful recording from the continuous glucose monitoring. Then you have mean glucose as the third metric, the GMI or the glucose management indicator, which is the average glucose which is interpreted from the CGM, which is different from the estimated hemoglobin A1C. And then you have the GB or the glucose variability, which should be less than or equal to 36%. And then you have all these metrics. I know that you are all very familiar with the acceptable range, that is in range between 70 and 180. Then you have level 1 hyperglycemia above 180, level 2 above 250. Level 1 hypo is below 70 and level 2 time below range is below 54. If somebody is questioning you when you are recommending a continuous glucose monitor, if somebody is initiating a debate with you, why should you do this? Where is the evidence? We do have evidence. We do have a lot of evidence, both old and new. TIR, even 10% change. When there is a 10% reduction in the time in range, there is an increase in retinopathy by 64% and nephropathy by 40%. So a lot of similar information is emerging. And this is a summary of those recommendations. In people who are non-pregnant with both type 1 and type 2 diabetes, the percentage time in range which is recommended is more than 70%. It doesn't mean that you have to stop at 70%. Minimum recommended is above 70%, which corresponds to roughly 17 hours in 24 hours. And the time below range, that is below 70, should be less than 4%, which corresponds to less than 1 hour in 24 hours. And the time below 54, which is level 2 hyperglycemia, should be less than 15 minutes in a day. And for those who are old, remember, old age is not nowadays defined by age. It is defined by the biological age or the functional age of the individual. Even a 40-year-old with multiple comorbidities can be considered for the TR targets as an old person. And for them, you need to target only for above 50%, replacing the 70%, between 70 and 180 milligrams. And remember, in higher risk, in those with a higher risk of developing hypo-induced complications, you need to be very careful in preventing hypoglycemia. And these are the TR targets for pregnancy, which is very, very strict and stringent. Because in pregnancy, we cannot take a chance. And we do have the recommendations for type 1. The lower limit is 63 and the upper limit is 140 in pregnancy. And I'm very happy to share with you the information that some of the publications of technology, and this is the original research from our center on continuous glucose monitoring, and this is referred to in the clinical practice guidelines by the American Association of Clinical Endocrinology. And similarly, some of our own original publications from India, we are now proud to announce that this is now acknowledged by the ADA, the EASD, the ADA in 2021, as well as in this year, in 2022, standards of medical care in diabetes. So now you have a question. Though we have the international recommendations, don't we require something which is very specific for our own population? For South Asia, we do have the recommendations on percentage time in range. I don't have the time to go into the details, but only to mention, only to specify that this is a non-reimbursable market. And we need to have our own recommendations, not only for the upper limit and lower limit, but also for the frequency of repeating CGM in type 2 diabetes and to generate an AGP report. In supposedly normal, acceptable individuals, you need to repeat at least twice a month, once in 6 months. And for those where the TPR is above 4% or above 5%, you need to probably repeat it more frequently. I request my dear friends to submit your original research, not only on technologies, but it can be anything on diabetes, and the International Journal of Diabetes and Technology, which is published by Walters Kluwer. So let me once again thank you, all of you, my dear friends, for your patient hearing and for giving me this opportunity. Best wishes to Dr. Ashish Shankara and the team.
Thank you, Jyoti.
Thank you. Thank you.
Thank you, Dr. Jyoti. It was an excellent presentation. Right from monitoring, which was in the generation when we went to medical college with Benedict's test, right up to AGP, and how it has transformed the life of people with diabetes. Now we can, with precision, monitor their blood sugars and see where are the defects and how we can control that. Are there any questions in the chat box?
Jyoti, one question that in pregnancy, in which patient do you recommend this?
Can you repeat it? Can you repeat it, Dr. Ashish?
In pregnancy, what group of patients we should use?
Zainab, please now. I have to sit for a meeting.
Yeah, Dr. Ashish is an excellent question. In pregnancy, currently the recommendations are for pregnancy and type 1 diabetes. So in type 1 diabetes, you should be definitely monitoring. But in general, in pregnancy, whether it is GDM or pregnancy along with type 1 or type 2 diabetes, the monitoring should be very stringent. And when continuous glucose monitoring is executed, in all the 3 types of pregnancies, the lower limit is 63 and the upper limit is 140, replacing the conventional 70 and 180 milligrams. But currently for the international consensus, the data is existing only for pregnancy and the type 1 diabetes. But for the answer to your question, it is for all the types of diabetes in pregnancy, but the exact statistics for type 2 diabetes and for GDM will be evolving only in the next 1 to 2 years.
I have a question, Dr. Jyoti Dev, Dr. Meena Chabra. I have a question.
Hello, Dr. Meena Chabra. How are you?
Yeah, excellent talk. Doctor, I have a question. Since you've done so many, what is the incidence of falsely low sugar, particularly nocturnal sugars are shown low? So a lot of our patients, when they cross-check and they get upset because, so is there some data that there's, if it's low, it shows very low?
Yeah, I'll be very brief and fast in answering to your question, Dr. Meena Chabra. You know that continuous glucose monitoring has been evolving. So we have been using it since 2004. And now we have the generations. So if you look at Dexcom, it is the 7th generation of the Dexcom sensor. So with every new sensor, you have also the algorithms also improving.
Okay.
So, earlier we used to have a huge difference in the data and there were false hypos. But now, please remember, there need not be just false hypos alone. There can be even false hyper as well. So the CGM data need not be always lower by 20 or 30 milligrams per deciliter compared to the glucose meter data. It can even be higher by 10 or 20 milligrams per deciliter. And it all depends upon the algorithms improving. So I would say that if you are having type 1 diabetes, then don't depend only on CGM. Even though the CGMs have improved a lot, I would say that a lot they have improved in accuracy. But still in between, when the glucose is stable, you have to compare with the classical glucose meter. But remember, they are very good. They are very good. And once you are an experienced user, you will yourself get to know that when it is going to be wrong. When it is going to be wrong. And nocturnal hypoglycemia, I would say that it is after the advent of CGMs, we started recognizing, realizing, and diagnosing a nocturnal hypoglycemia. Before that, actually, we didn't know. And now we have very reliable data pertaining to nocturnal hypoglycemia. So I would say that currently the 2 CGMs which are widely popular, the real-time CGM, which is a Guardian Connect, generation 3 in India, 4 is yet to come. And I am told that it will be arriving in India within 1 to 2 months' time. So very fast it will be arriving, especially along with 780G. And also the standalone sensor will also be arriving soon. And then the Libre. These 2 are having a mark of almost 9.4. So you can be confident with the data. And within another 3 months, newer CGMs are also arriving. So don't worry of the nocturnal hypoglycemia. And when you are calibrating, be very careful. That is one reason why you can have a false nocturnal hypoglycemia. Calibration is very important. Thank you. Thank you.
Thank you.
Sir, can I have a question? I am Dr. Kannan here.
Hello, Dr. Kannan. How are you?
Fine, sir.
I can see Jayanta, my dear friend.
Thank you. Thank you. So for the excellent TIR results, sir, whether we want to calibrate the CGMs for 7 days or 14 days to rule out the excellent TIR results.
Yeah, so that is a very pertinent question. So if you look at the 10 metrics that has been originally recommended by the international consensus of ATTD, ADA, AST together, you can do CGM for 7 days or for 14 days. So you know that the Guardian Connect, you can use it only for 7 days, and for Libre and Libre Pro, you can use it for 14 days. But for a meaningful calculation of percentage TIR can be calculated with just 1 day data. But for making a meaningful calculation, you need to do it for 14 days, of which the data should be available for 70% of the time, and that translates to 10 days. So you have to have 10 days of data. So with just 7 days of doing a continuous glucose monitoring, you cannot actually have a meaningful calculation to decide on treatment outcomes. So that you requires more data. And if you are having 14 days of data, it is said that that is reflective of the next 3 months of TIR.
Yes.
Hope I am clear. Thank you.
Thank you. Thank you, sir.
Sir, how do you see trends? One last question, Dr. Jyoti Dev. How do you see trends in...
Yeah, very good. Because you know that in type 2 diabetes, the trends are very useful. So looking at the trend, you would have different zones, more prone for hyperglycemia, and the classical peak after a meal. Is it 1 hour after a meal or 2 hours after a meal? And as you said, a nocturnal hyperglycemia. And in type 2 diabetes, I would say that the trend and the shape is very classical and remains the same. But in type 1 diabetes, I would say there is no pattern. But looking at the shape, as I have said in the beginning in the lecture, looking at just the shape or the pattern, you can identify whether it belongs to a type 1 diabetes patient or a type 2 diabetes patient. And that is the reason why in type 1 diabetes, you cannot do a CGM for 7 days or 14 days. CGM is meant, and it need to be either a real time or it need to be intermittently scanned CGM, which is available in real time. And that should be throughout the year. But in type 2 diabetes, if you go by the recommendations from South Asia, that panel, in controlled patient, you can do it twice in a year. That is once in every 6 months. And if the time below range is more than 5%, that is significantly more than the recommended time below range, you need to be repeating it more frequently. It can be once in 2 months or once in 3 months. So that is why the pattern is also important in differentiating between the two.
Thank you.
Thank you.
Very, very nice lecture. Just before you end, if we your information regarding TIR and CGM is very updated and you're all knowledgeable. Only thing, the biological age, if we consider instead of chronological age, I think the elderly population will be much higher than what we calculate at present. So, is it for research or for the political or administrative calculations, so we can take this biological age as the right age for the elderly, for to decide the cutoff of elderly?
I think, my dear Jayanta, we need to do research and you need to find a way out how to calculate the functional age of the person, because there are different methods available now. But in clinics, as you know, we all make an approximate calculation of the biological or the functional age of the person. So I have seen many at the age of 40 or 45, you know that they will have multiple complications, and the age here is dependent upon the propensity to develop hypo-induced complications. So if somebody is having a propensity to develop multiple hypo-induced complications, they can even die. So that is when you will reduce from 70% time in range acceptability to down to more than 50%. And it doesn't mean that you have to stop at 50%. If the person is improving in his biological age, because when Dr. Jayanta, for example, is treating a person, then he might have an advantage of reducing the age. The biological age may improve. Then you can probably improve the percentage of time.
This is a very fantastic concept, and I think every vital monitoring, there should be a calculation of biological aging. At least that can make the person conscious that biologically I am that old.
Absolutely. Thank you so much.
Very, very nice presentation. Yeah. Congratulations.
Thank you, Jyoti. I think so. We should keep full day program for you once for technology.
Thank you. Congratulations for the nice program. Fantastic.
Thank you, sir. Thank you, sir.
Over to you, Kanak.
So, dear friends, shall we move to the next session now? We have an interesting section on eye disease. That is the role of optical tomography in diabetes eye disease. For that, we have three eminent chairpersons, Dr. Ravi Agarwal and Dr. Himanshu Shukla and Dr. Avijit Bishnoi. Over to chairpersons. Dr. Ravi Agarwal is having owning eye hospital from Pekko and Laser Center, Jabalpur. Himanshu Shukla Eye Hospital, Jabalpur once again, and Dr. Avijit Bishnoi, the eminence ophthalmology is Anustri Netaralaya, Chiskali and Retina Center, Jabalpur. All the three consultants from Jabalpur. Over to you, dear respected chairpersons. Avijit, are you there? Yes. Avijit sir, you have to unmute, sir.
Avijit, you unmute yourself. Avijit? Avijit? Yeah, Kanan, you can continue.
Yeah.
You introduce him.
Yeah. So it's a pleasure and pride to introduce our esteemed speaker, Professor Kiran Shah, in this August audience. A consultant physician and diabetologist, the Department of Medicine, Grand Government Medical College, and GG Group of Hospitals, is the head of the unit, Diabetes Clinic and Thyroid OPD. He is attached to Diabetes and Thyroid Care Center. The consulting room, Diabetes, Thyroid, and Hypertension Multi-Speciality Clinic in South Mumbai. He is having a global hospital parallel. He is a consultant in Wokath Hospital, South Mumbai. And also, he is another consultant in Srimad S.R. Mehta and Sir K.P. Kodak too. And he was awarded a lot of awards, including the Best Poster RSA Award in 2015. He's the second best poster challenges in.
Yeah, Kanan, Avijit has joined. Hi, Avijit.
Hello, hi. Sorry for the technical glitch.
Yeah, so you can continue with the awards of Kiran. Awards from here.
Welcome our eminent speaker, Dr. Kiran Shah, sir. Blessed all you know, but about his awards, he has got the third best poster RSSDI. Second best poster challenge in diabetes 2017, Diabetic Awareness Initiative Awards 2018, and 24 national and international peer-reviewed journals published. About the chapter contribution, he has authored chapter on optical coherence tomography and useful tool for retina problem diabetic update 2019 in RSSDI. So warm welcome to you, sir. Over to you. Thank you, sir.
Good evening. Thank you, Dr. Kanan, Dr. Avijit, for this kind introduction. Thank you, Dr. Ashish, for giving me this opportunity to be speaking today on optical coherence tomography. I hope my slides are visible.
Yes, sir.
Yeah, right. So just my disclosure is that I'm a diabetologist, and I found that all the three respected chairs are all ophthalmologists. So I will restrict myself as an as a diabetologist to understand what we need to know about the optical coherence tomography. It's an ocular imaging which has played an indispensable role in the screening, diagnosis, management, and monitoring of diabetic macular edema. The OCT provides us with structural details of the retina, and it has both quantitative and qualitative significance. The OCT is more sensitive to small changes in the retinal thickness. Diabetic structural changes in the fovea can be detected early with OCT, which may not be evident on an ophthalmoscopy or a fluorescent angiography. The image what is shown is this is what we actually get to see in a routine OPD or otherwise in the hospital, a standard report from the Zeiss Cirrus high definition OCT device. So OCT is basically non-contact, non-invasive micro-resolution cross-sectional study of the retina. It correlates very well with the retinal histology. These are the layers of the retina. That's the vitreous in front of it, and that's the choroid. And what we are interested out here as a diabetologist is the normal foveal depression. That's a schematic diagram of the retinal layers corresponding roughly to what would we see on a high-definition line scan through the macula. It has further been broken down. The first layer which is visible on the OCT is the internal limiting membrane, which appears as a hyperreflective line on the vitreoretinal surface. And the last of the image layers on the OCT is a retinal pigment epithelium, which contains melanin and is capable of very potent light scattering. The dark areas correspond to the nuclei. The bright areas or the white areas are the plexiform or the nerve fiber layers. With respect to the macular pathology, as diabetologists and physicians or endocrinologists, we are more interested in the edema, the hard exudates, the hemorrhages, at times the retinal detachment, the fibrosis, and the calcification. So the interpretation, while interpreting the OCT, it helps us in both qualitative analysis and quantitative analysis. Qualitative analysis refers to interpreting to scan to see if there is a disease and to understand what the disease might be. These are 6 scans of 6 different individuals or OCTs of 6 different individuals. And these are the common terminologies which have been used by the ophthalmologist. Just to understand these terminologies, this is a neural tissue where it has been squished just to appear as a normal anatomic variant. Here, the intraretinal fluid appears as a speckled appearance. In here, the intraretinal fluid, there is a diffuse outer thickening which looks like the fluid has been confined to the outer aspect of the retina. Here, the cysts are different from what we see earlier with respect to the speckle configuration. In here, there is subretinal hyperrefractive material along with the subretinal fluid. And here, there is pigment epithelial detachment, subretinal fluid, intraretinal fluid, and subretinal hyperreflective material. Now, given these kind of descriptions, we usually come to a final conclusion in terms of diagnosis. This is the normal OCT scan. This patient has got diabetic macular edema, that's retinal vein occlusion, very classically seen in post-op, post-cataract surgery, cystoid macular edema. That's keratoneovascularization. And then finally, we have age-related macular degeneration. Now, with regards to quantitative analysis, this practically means that it refers to measuring the thickness of the retina. And let us just interpret this particular report, which I have divided into 3 different zones. The upper part basically talks about the patient details, but what we are more interested is this word OD and OS, where OD means the right eye, whereas the OS means the left eye. And if both the eyes have been scanned, then it is called OU out there. That's a topographic representation that measures the thickness of the retina right from the internal limiting membrane, that's the first layer, to right up to the last layer, that is the RPE or the retinal pigment epithelium, at almost 1,000 points all across, hence offering a precise location of the edema by the overlying image. The device also uses a calorimetric scale where red or the hot color indicates areas where the retina is thick, where the blue are the cool colors, which indicates that the retina is thin. Just to show an example, here we have the OD, the left eye out here, particularly showing the hard exudates. There is loss of normal foveal depression. Similarly, the other side of the eye, the right side is also showing us the diabetic macular edema and the pigment epithelial detachment. So that's how it appears as which eye has been scanned. In the first part, the OS was scanned, the other part, the OD is scanned, and the corresponding fundus images of the same patient. Now let us interpret the middle part of the report. This represents the statistical analysis of retinal thickness. The number in each sector represents the average thickness of the whole retina in that sector compared to the age-matched normative database. The green color basically indicates that the OCT is within normal limits, and it is different from the green in the statistical analysis in the topographic map. That's the important calorimetric band labeled as a diversified distribution of normal. Anywhere between 5 to 95% is considered to be normal. Anywhere between 95 to 99%, it is considered to be a bit thicker retina, which is slightly yellow. And what is more important is the pink color out there, which is almost 99%, which is considered to be very, very thick retina. Similarly, if you can appreciate the dark yellow color, it appears that the retina is thin, whereas the red color practically indicates that the retina is very, very thin. And finally, we get the images as to what the scans have been done. And with that, the ophthalmologist usually writes the diagnosis, which we get as a full final report. Now, keeping this as a normal report, let's have a look at a few examples or a few patient cases. In here, we can see there is diabetic macular edema in the one eye, that the other eye is practically normal out here. The thickness, central retinal thickness is 505. The area or the color, the topographic area is pink in color. In this particular image, both the eyes have got a diabetic macular edema. Both of them are pink, and then you can appreciate the central retinal thickness being around 622 and 549 respectively. This is the third image, but what is more important is the color out here. As said earlier, the earlier image was showing, or the earlier report was rather showing the pink color, whereas here it is showing much of a red color, and this patient has got age-related macular degeneration. It is very, very thin retina. The area is completely, one can appreciate out here. It's very thin out there. In this particular eye, the image, you can see that there is macular edema in one eye. However, the other eye, the scan doesn't seem to be coming. There's no technical error or there's no machine-related error. When we look at the fundus images, we can appreciate that the left eye is particularly showing hard exudates, which are appearing the macula, and that's the macular edema out there. You can see the microaneurysms as well as, whereas the other eye, the right side is particularly showing vitreous hemorrhage and there is blood in front of the retina. So the scan does not seem to be coming through. Similarly, we can see that the one eye is completely normal, whereas the other eye seems to be showing some kind of retinal picture out here, but otherwise the scan doesn't seem to be coming. In the same way, the right eye seems to be completely normal. This is a fundus image, whereas the left eye shows high-risk proliferative diabetic retinopathy. You can see fibrosis, you can see new vessels, and there is complete loss of integrity as far as the retina is concerned. Now, what was missed in the upper part of the report was this macular thickness, which is, or the macular cube, which is 512 and 128. This number practically, the 512 practically tells us that the number of cuts which have been taken from top to bottom running vertically in that particular plane, as well as 128 means the number of cuts which have been taken horizontally. What we see in the final image or the final report is one single cut. But at times, one single cut is not enough. And what we need to interpret out here, for example, this particular fundus images as well as the fluorescent angiography, you can see the dye leaking, the microaneurysms. You can also see areas of avasc which are completely vascular ischemia. But what is more in proliferative diabetic retinopathy? But at times the OCT may show you a complete different picture. You can see there is macular edema, the pink side, but here the scan doesn't seem to be coming through. It is almost white out there. And when we see, it appears to be like sponge-like macular edema. But on the OCT scan, this particular video, towards the end of the video, one would appreciate that this particular patient has got a macular hole. You can see the two layers of the retina separating out, and that's the final image out there as macular hole. So one single cut is not enough. While appreciating the OCT, we need to go through the entire scan to get the final diagnosis. Similarly, in this particular patient, you can see as the scan is passing through, you can see the hard exudates, you can see the epiretinal membrane, and towards the end of the video, one would see a lamellar macular hole. But it is quite different from the earlier macular hole. Here, at least the two parts or the two ends of the retina would be seen to be attached to each other. They are not completely separated. So that's a big difference between the lamellar hole and the otherwise the other macular hole. In this particular case, which is we classically see in many of our patients having advanced stages of diabetic nephropathy or even in-stage renal disease or in dialysis, as the scan passes through, now you will appreciate all the hard exudates shining yellow, diabetic macular edema, the cyst inside, very classically seen in all our patients with diabetic nephropathy. This is one of our cases with type 1 diabetes mellitus, and you can say that when we saw him in 2019, there was the central retinal thickness is all green out there, so that the vision was not very much compromised. The periphery did show some kind of swelling out there, but 6 months down the line, he comes to us and you can see the hard exudates, you can see the hemorrhages out there in the right side. The left side showed more number of hemorrhages and also the hard exudates. And when we repeated the scan, you can see there is a big difference with respect to the central retinal thickness. There seems to be edema. You can see hard exudates all approaching the central part of the fovea, and definitely this patient would need immediate treatment with respect to preserving his vision. What is more important in this particular case is that the patient actually had the right side had some visual complaints, and then the patient was diagnosed to have type 2 diabetes mellitus. So at times what we get to see are these hard exudates, and then that's the time. So that actually tells us the importance of screening our patients. Even newly diagnosed type 2 diabetes mellitus patients can have microvascular complications. And I would say or add a line saying that all patients with diabetes should undergo an eye or an ophthalmology checkup with respect to diabetic retinopathy. This is something which is very commonly seen in our routine practice. We use a triple drug combination, more commonly glimepiride, metformin, and pioglitazone. And this is where at times the pioglitazone can cause macular edema, apart from all the goods and the certain other adverse events related to the pioglitazone. One most important complication associated is the diabetic macular edema. Here, the OCT reveals a diffuse macular edema, but there is no loss of foveal counter. The pioglitazone was stopped, no anti-VEGF or any laser was given. And 4 weeks down the line, one would say that the OCT reveals spontaneous and fast resolution of diffuse macular edema with improvement of visual acuity after stopping the pioglitazone. This is a case of non-resolving diabetic macular edema. This is a medical tourism patient, and you can see Despite the fact that this patient was seen in 2015, I always like to put up this particular known case of type 2 diabetes only since 2 years, and look at the amount of anti-VEGF and the steroids which have been given and the cost which has been gone through this particular patient. And despite this, there was no resolution of diabetic macular edema. So when we got to see it in our hospital, was this a case of refractory diabetic macular edema? And that is where we get to see both the eyes. You can one would appreciate the macular edema, both the sides. And then when I asked him, when went through the history, you can see the patient smiling out there, medical tourism. He couldn't understand what is the word pioglitazone. So he's telling me this is on my mobile. The tablet is 15 milligrams 3 times in a day, which he's been taking. And the reason why he was taking is because he was very lean and he wanted to put up some weight, but the weight did not come through, but definitely the macular edema came inside his eyes. So the only treatment now is that if you stop pioglitazone, just imagine the cost out there of dexamethasone and the various other Macugen, Ozurdex, which has been used, and the cost of pioglitazone. So you stop pioglitazone and you recall the patient back, and you can see that there is complete, you can see the normal OCT scan. And this is why one should appreciate the fact that pioglitazone can cause diabetic macular edema, and that should always be kept within our mind. This is the patient with where the diabetic macular edema, and OCT is also used not only to scan these patients, but also when the first dose of anti-VEGF to monitor the treatment. The first dose of anti-VEGF is given here. There is no improvement after a month, and the second dose of anti-VEGF was given. Again, there is no improvement. Third dose of anti-VEGF is given, and then subsequently you can see the OCT reverting back or the central retinal thickness decreasing. So OCT helps even us and the ophthalmologist to understand whether how many injections of anti-VEGF are possibly going to be used out there. So it helps us to monitor the treatment, which is very important as far as the management of diabetic macular edema is concerned. One would appreciate the branch retinal vein occlusion out there, and that's the OCT. That's what's the baseline. And in this particular case, only one anti-VEGF injection was needed. And after 1 month, that's gone. The edema is completely resolved. Now, the most important part as a diabetologist, can we use SGLT2 inhibitors in the management of diabetic macular edema? I have used all possible empagliflozin, dapagliflozin, and canagliflozin with respect to patients in diabetic macular edema. These are just a subset of 10 patients. The data is unpublished, but you can appreciate that the blue line out there particularly shows the central retinal thickness before the SGLT2 inhibitor was used, and the red line is subsequently after 24 weeks. 16 to 24 weeks, and you can see that the central retinal thickness has gone down. Just to highlight a couple of cases based on SGLT2 inhibitors, of the 10 cases, here's case number 7. One would say that before starting the SGLT2 inhibitor, at least 4 anti-VEGF injections had gone. Now, after starting SGLT2 inhibitors, only one anti-VEGF was given, and then subsequently there is no anti-VEGF which has been given. Similarly, in case 9, there were 4 anti-VEGF shots which were given. But after starting the SGLT2 inhibitor, one would appreciate there is no. So I'm not saying that the SGLT2 inhibitor is a replacement for the anti-VEGF injection. Anti-VEGFs are always going to remain the gold standard. But if we can add SGLT2 inhibitors, definitely what is important is the total number of anti-VEGF injections and the associated adverse events will come down. So this is my paper which has been accepted this time at the International Diabetes Federation, Lisbon. SGLT2 inhibitors in the management of diabetic macular edema in patients with type 2 diabetes, a prospective study. The results imply that the systemic SGLT2 inhibitors may be an additional treatment option to anti-VEGF treatment for the eyes with diabetic macular edema, and that it can decrease DMEs and the amount of anti-VEGF injections. This is very classically seen. We always give fitness for cataract surgery with respect to diabetes, but what is more important is this particular complex cystoid macular edema, which is very classically seen within the first 1 month of the surgery. And we need to always appreciate that the sugars need to be very well controlled. It's just not that giving clearance as far as cataract surgery is concerned. So that's the same image, which is in the earlier one is a black and white. This is more of a color image. But what is important that post-cataract also patients can develop this kind of a macular edema. Here is a sponge-like macular edema and the vitreous hemorrhage out there. That's the reason the scan on the other side doesn't seem to be coming through. Asteroid hyalosis, these are not actually hard exudate. They are basically floaters inside the patient's eye. And when we look into the OCT scan, that is how it appears, as if there are asteroids falling from the sky. So what is important out here, they are basically floaters. They do not affect the vision, but if the vision is affected, definitely vitrectomy is needed in this particular patient. And that is how the scan would look through. There is normal, and then you can see these asteroids which are going on. That's how the scan appears as a final report. With respect to the position statement from the American Diabetes Association, there has been a widespread adoption of the OCT to assess the retinal thickness and intraretinal pathology and wide field fundus photography to reveal clinically silent macrovascular lesions. OCT is a non-invasive imaging modality. It can perform micrometer resolution cross-sectional images of the retina in a precise, reliable, and a reproducible manner. OCT may assist in a patient selection with DME, identify what the treatment is indicated, who can benefit from the treatment, guide its implementing, and allow monitoring of treatment response. With that, thank you very much for this particular talk. Once again, Dr. Ashish, thank you very much for this invite, and I would appreciate if there are any questions, I'll be more than happy to answer them.
A wonderful talk, sir. I appreciate the amount of efforts which you have done and produced this wonderful talk. It was totally appreciated by all the ophthalmologists also, because the details which you mentioned are mostly seen not in just a general ophthalmologist, but in a retina specialist. So accomplishing such a wonderful presentation is really commendable. One thing which I would like to add, because Dr. Denga has provided such a wonderful platform where the ophthalmologist and the diabetologist are now interacting. There are few indicators like the values of A1C, C-reactive protein, and often the hemoglobin level, which should a clinician should always try to look on. Because a patient having anemia or high CRP values or an impaired A1C values is more prone to develop retinopathy. So these patients, if you identify through reports, should create a red flag sign on them, and a mandatory examination from a retina specialist should be made. So that's what I would like to mention. Apart from it, over to you, sir.
Kiran sir, can I have a question, sir? Can I have
Doctor. The only difference is that I work with Dr. Natarajan at Aditya Jyot, and you are also Dr. Natarajan.
Kannan Natarajan, yes, sir.
Thank you.
Yeah. Sir, I think we are having a lot of biomarkers regarding diabetes. Sir. We have CVD biomarkers, we have obesity biomarkers, we have then kidney biomarkers. So any retinal biomarkers to rule out any early retinopathy changes in diabetic patients, sir?
I think Dr. Avijit can answer this question, but as a diabetologist, what I would appreciate is the fact that every patient, the whole purpose is we do not screen our patients for diabetic retinopathy.
Yes, sir.
The patient usually goes through undetected. We will screen for nephropathy. We look into the ECG. We look into the brain. We look into the feet, but the retina is never appreciated.
Is a mirror for other. Is a mirror for
that is the reason why either the patient is referred back from the ophthalmologist to the treating diabetologist or the endocrinologist, or otherwise the patient then comes to us, and that is when we see. So with respect to biomarkers, I would say that all patients should be screened day one when you see, or actually refer them to an ophthalmologist to see whether there is any diabetic retinopathy or not. But the question pertaining, I'll just try to keep it with respect to pioglitazone, because that's one drug which is very commonly used as far as we are concerned. Anybody who has a very rapid weight gain, somebody who has developed a rapid drop in hemoglobin or anemia, somebody who's developing pedal edema, all these kind of patients should actually be screened for diabetic retinopathy. Or somebody who's already having advanced stages of diabetic retinopathy, please do not initiate pioglitazone, because these patients are very likely to develop diabetic macular edema, which is much more, which will affect the vision much more as compared to the whole without the glitazone out there.
Thank you very much, sir. Excellent answer. Thank you, sir.
One more thing, sir, I would like to add. Actually, 2 lectures before, one eminent speaker who was very, very good in the tech aspect of the medical field was speaking from Sangvi Diabetic Care Institute. He was about the technical part. I would like to particularly mention, not about anything else. Few diabetologists have now started screening the patient on basic fundus cameras, which are now available. They are non-mediatic. The patient does not have to undergo a pupillar dilatation, and a screening is easily done. But this practice is actually not very much appreciated by the retina people, because once the disease reaches to moderate or severe level, then you are able to catch it on the fundus cameras. But the disease which is of the mild and moderate level is often missed. And then these patients often present to us with the status of having severe non-proliferative disease or a proliferative disease. So this practice should be abolished. And in fact, if the diabetologists want to go really on the technical part, then OCT is one of the very good tool which they can definitely have at their centers.
Thank you. Thank you, sir. I think no more question in the chat box. I think, shall we close the session, Abhijit?
Sure, sir. Thank you, sir. Thank you,
Abhijit, and thank you, Kiran.
Thank you, sir.
Wonderful discussion and talk. Abhijit, thank you, and Kiran. Kanan, make it fast now. Next.
Yes, yes. We have only 15 minutes more. So, dear friends, we have got a very, very important topic, which is routinely practice of clinical practice, dyslipidemia. So, today's topic is on when to stop the combination therapy for dyslipidemia. For that we have...
Kanan, why the beautiful lady's photo is missing? Rukia?
Hello.
Why your photo is missing? Okay, we can see you, no problem.
Okay.
So, Kanan.
Yeah, Doctor, it's a pleasure to invite Dr. Sona and Dr. Rukia as esteemed chairpersons for today's topic. Consultant diabetologist is the founder and director of Dr. Sona Patronage Specialty Center. Over to the respective chairpersons.
Thank you. Thank you, Dr. Ashish, for inviting us today for this conference. And since morning, it's been a great day having such amazing talks. So taking the talk further, I would like to introduce our next speaker, Dr. Nozay Yusuf. Can I have his slide, please? So Dr. Nozay Yusuf, he is an MB BCH University from Egypt, and he's a physician and also cardiologist at Ames Shams University. He's a senior consultant physician in the cardio-diabetes department in Egypt. He's the founder and director of Cardio-Diabetes Secrets International Group. He's a president of the Egyptian Cardio-Diabetes Association and also a fellow of American College of Cardiology and member of the American Diabetic Association. So we have a speaker with us today from an African continent, Egypt, and let us understand how is cardiology and taking the next topic for today. Over to you, Dr. Nozay Yusuf.
Thank you very much. First, I would like to thank Dr. Ashish and his board and our chairman for inviting me to this elegant scientific conference.
Welcome, Ashish.
Our talk today will be on when to start combination therapy in treating dyslipidemia. And all as we know that dyslipidemia we start with statin, but today we wanted to start both statin and ezetimibe together. So when to start? I have no disclosure to show. This is our agenda. First, we'll start the burden of atherosclerotic cardiovascular disease all over the world. And we know that more people die from cardiovascular disease all over the world. Around 18 million will die, which represent 31% of all diseases worldwide. From this number, 85 will be due to heart attack and stroke. And unfortunately, more than 70% of these numbers of diseases occur in low and middle income countries like Egypt and India. Ischemic heart disease will be responsible for about 16%, while stroke will be representing around 11% from all these groups. First, we wanted to see and define the major atherosclerotic cardiovascular event, which include recent acute coronary syndrome within the past 12 months, history of MI within 12 months, history of ischemic stroke or symptomatic peripheral vascular disease. Our patient, we will concentrate on high-risk conditions and very high-risk conditions. I am very sad that to say all high-risk conditions are very, very, very common in our communities. Age above 65, history of coronary artery bypass surgery or percutaneous coronary intervention, PCI with a stent, diabetes, hypertension, CKD with estimated ejection fraction from 15 to 60 milliliter per minute, current smoking, persistent elevation of LDL above 100 in spite of statin treatment. So all these are very common in our community and we see it on daily basis. Second, we will go to the guideline recommendations and current treatment gaps. We have 3 conditions. It is this is from European Society of Atherosclerosis 2019 about secondary prevention patient with very high risk or primary prevention of individual with very high risk without familial hypercholesterolemia or with familial hypercholesterolemia. On all these conditions, we should have LDL at least 50% reduction from baseline, and the goal will be less than 50 milligram per deciliter. Another 2 conditions mentioned for patients with atherosclerotic cardiovascular disease who experience second vascular event within 2 years. So LDL should go below 40 milligram. While in high-risk patient without any other causes like hypertension and diabetes, ischemic heart and others, so we can go LDL to 70 milligram. And if we go back in 2016 and 2019, we should know that we are aggressively treating the high cholesterol. In very high risk group, we will decrease up to 50 milligram per deciliter and less than 50 milligram depression. While in high risk patient, we can see up to 70 milligram per deciliter LDL and more than 50% decrease. Now we will see Da Vinci study, which is published in 2021 about modifying the therapy in secondary and primary care. In 18 countries with cross-sectional observational study, about 3,000 in primary prevention and almost 3,000 in secondary prevention. In Da Vinci, the very high risk group patient prescribed moderate intensity statin monotherapy, which resulted in poor LDL goal attainment. And this is as we see here in this graph. And the second, in high risk patient, and in a high risk patient, moderate intensity statin monotherapy also lead to suboptimal LDL goal attainment. So, about the implementation of guidelines in our practice setting, in April 2021, the statement from the European Atherosclerosis Society Task Forces, they issued practical guidance for combination lipid modifying therapy in high and very high risk patient. And they said, if the patient is on statin, yes, so we will go for LDL. If it is more than 70 milligram per deciliter, so no increase in statin intensity if not on high intensity statin. But if in moderate intensity statin, we should shift to high intensity statin. If yes, LDL is more than 70, so switch to high intensity statin plus ezetimibe. But if the patient is not on a statin, so LDL more than 100, we will start high intensity statin. If not on a statin, if you are on a statin, we should shift to high intensity statin plus ezetimibe. Also in 2021, the International Lipid Expert Panel has issued practical solution focusing on immediate combination therapy. Immediate combination therapy. And they said, if patient with acute coronary syndrome and receive PCI, if no, so measure LDL. And LDL less than 100, statin treated, or LDL less than 120 and no prior treatment. So both of these conditions will have single lipid lowering treatment, maximally tolerated statin therapy, high intensity statin. Then we will continue if LDL from 100 to 300 milligram per deciliter, the statin treated, or LDL from 120 to 300 milligram with no prior treatment. So dual lipid lowering therapy, maximally tolerated statin plus ezetimibe. And lastly, if any patient with LDL above 300, so we will have triple therapy, maximal tolerated statin therapy plus ezetimibe plus PCSK9 inhibitors. This slide, I like it very much because it will show us the efficacy of our medication. In moderate intensity statin, only 30% LDL reduction. In high intensity statin, 50% reduction. But if we put ezetimibe, so it jumped to 65%. We should know that PCSK9 inhibitors will reduce LDL 60% only alone. But high intensity statin with ezetimibe reduce 65%. So what is the benefit of high intensity statin with ezetimibe? We can go now for PACE study. PACE study, it was published in Journal of American College Cardiology in 2013, but is very, very effective because it showed the efficacy and safety of ezetimibe added to atorvastatin versus atorvastatin up titration or switching to rosuvastatin. This is a framework of phase 1, and this is the result. Providing, if we shift to atorvastatin, ezetimibe 10 milligram, it provides greater additional LDL reduction versus doubling atorvastatin to 20 or switching to rosuvastatin 10. Here, this is a graph showing adding ezetimibe to atorvastatin 10 milligram will reduce it minus 22. While in doubling atorvastatin dose from 10 to 20, it reduces only 10. While if we switch to rosuvastatin 10, it reduces it to 13. So from 22 to 10, very significant p-value, and from 22 to 13, it is very significant value. This is a frame of space 2. And here, with ezetimibe plus atorvastatin 20, we have additional LDL reduction. Adding ezetimibe 10 milligram to atorvastatin 20, this will show us minus to 17, while doubling atorvastatin to 40, it would reduce it 7 only, while switching from rosuvastatin 10 to ezetimibe 10 plus atorvastatin to reduce it 17, same, and doubling rosuvastatin from 10 to 20 only to 8 only. And this, we show here very significant p-value. The common question will be rise up, is it safe to go low level of LDL? Our answer will find it in 2015 from the New England Journal when it published the Improve It study, which is landmark study. Alone, it can change the guidelines. They divided LDL to less than 30 milligram, from 30 to 50, from 50 to 70, and more than 70. This is the 4 colors. And they show the side effects: myalgia, increased CK, adverse reaction, discontinuation, increase in the liver enzymes more than 3 times, gallstone, neuroconjunctive function, hemorrhagic stroke, congestive heart failure, hospitalization, non-cardiovascular death, cancer. All these side effects are not significant, no significant value between these column and the colors of these columns. So the less than 30 milligram LDL is same side effects as more than 70 milligram LDL. And this will also show us the more significant value for adding ezetimibe to statin. More benefit will be observed in cardiovascular with diabetes, and more than 2 cardiovascular events with LDL more than 135. So, Mr. Chairman, I would like to conclude and summarize that world biggest killer is ischemic heart disease, higher mortality rate in developing countries. Recent ischemic European guidelines recommend aggressive LDL targets, and real-world data show most of these patients were prescribed moderate intensity statin, resulting in poor LDL goal attainment. Different practical guidelines recommend high-intensity statin plus ezetimibe combination. In clinical trials, ezetimibe atorvastatin show higher LDL reduction, a higher percentage of achievement of LDL targets compared to statin monotherapy. Lower rate of LDL control at population level in real life studies is low. So the therapeutic inertia from doctors and poor treatment adherence from patients are significantly and prevalent barriers to increase the treatment exposure. Single pill combination is a very good idea. And now we conclude that we can start statin ezetimibe from the first day of treatment in dyslipidemia and type 2 diabetes, dyslipidemia and atherosclerotic cardiovascular disease, dyslipidemia with metabolic syndrome, and also as in familial hypercholesterolemia. Thank you very much. And I would like to invite you, all of you, for our 5th Egyptian Cardio-Diabetes Association International Annual Conference. It will be held in 2022 September, and you can observe it on the site of our association. Thank you.
Thank you, Dr. Yusuf. You really made this very dry and boring topic very clear, crisp, and understanding in terms of what are the guidelines and practically what are the differences in even whether to increase the dose or to add an ezetimibe. I think that is always the confusion, whether you want to up titrate the dose and go up to the maximum level, or do we want to just add another agent, and adding the other agent, like you rightly said, does not increase the risk of side effects, and we require a lesser dose as well. So it was very crisp and clear, and thank you very much.
Thank
Dr.
you.
Dr. Ashish and Dr.
Yes.
Yes.
Yeah, Noshi. Thank you. You have given a wonderful talk, and your conference is on 21st and 22nd September.
Yes.
Yeah.
So we have to come to visit to you in Egypt very soon.
I think I always make more impression and stress about making the LDL very, very, very low. So for myself, I would like my LDL to be less than 30 milligram per deciliter. If we all of us insist to go very low LDL and continue the same dose forever, so we will be younger than our age. If you want to be young than your age, so please, please do it and continue the full dose to receive the maximum benefit from statin. Okay. If you are 60, your arteries will be 50. If you are 50, your arteries will be 40, like this. So it is marvelous.
That is very, coming from a cardiologist who sees the arteries inside, is very heartening to know that we need to keep our LDLs very low. I would like to ask you a question that would you go ahead with a dual combination straight away, or just start with a plain statin first and then keep on up titrating or adding the ezetimibe?
No, we have said that we will start combination high-intensity statin ezetimibe from start in diabetic dyslipidemia, in dyslipidemia with atherosclerotic cardiovascular disease, and in dyslipidemia with metabolic syndrome. These three clinical conditions, we must start from start. From day one, high-intensity statin plus ezetimibe.
Okay. And what do you think is the role of bempedoic acid, which is the new molecule for reducing the LDL?
You mean the PCSK9 inhibitors?
Yes.
No.
The
bempedoic acid is not a PCSK9 inhibitor. It's another class of drug. So I think that's for another day, because that's beyond statins, and his topic is statins. And most countries don't have bempedoic acid or PCSK9 inhibitors. They are in trials.
I agree with you that bempedoic acid is not available anywhere. And I think also in Egypt is not available commercial. So
yeah, only studies are going on with the PCSK9 inhibitor.
Yes.
And with bempedoic. Bempedoic has been launched in India. I don't know if it's available in your country for residual LDL risk reduction. Yeah. Thank you, doctor. Thank you. So what do you do for your statin intolerant patients who have severe myalgia? You give only ezetimibe, or do you have in your country pitavastatin, which they claim causes less myalgia than atorvastatin and rosuvastatin?
Yes.
And actually, in one study which showed that
I couldn't be able to see Professor
the real statin intolerance is only 6%. 6%, which is in my whole life career, more than 30 years, I only went to one case of myalgia, true myalgia, and the patient was not able to walk. And after stopping the statin, all the CK and his muscles come back, and he walked already. So we have the ezetimibe, the fibric acid derivatives, and then the near future will be bempedoic acid. And the PCSK9 inhibitors now started commercially in Egypt, but it's very, very expensive. So I think if it is insured, we can cover some patient, but most of the patient take PCSK9 inhibitors because of the high cost.
Yes.
I remember one word of Dr. Eugene Braunwald in 2018 in European Society of Cardiology. He said, I would like to receive all people above 30 years one injection of PCSK9 inhibitors every 6 months. So this will show us how much our godfather for cardiology said we should low LDL as much as we can.
Yeah, I think Ashish, can I say something? It's about, we in India have bempedoic acid from many pharmaceutical companies.
Yeah, now we have it.
And you know, we can use in two situations where with statins we find, but it rarely happens, as you said, the Professor issue, that where the HbA1c is slightly going up, then we can use this, or when it is very rarely found, it is not shooting fibromyalgia. I have one last point, Ashish, if you allow me. It's about the fact that today aggressive lowering of the LDL is important in extreme cases like 240 or 35. Do you use, what are the drug combinations you use in your armamentarium today? You have beyond ezetimibe, statin, what else you use to bring it down to 40?
I think if we use atorvastatin or rosuvastatin plus ezetimibe in good doses, at atorvastatin 20 or 40 and rosuvastatin 10 or 20 with ezetimibe, and to continue strictly taking the medication. So within 3 to 6 months, I have many cases that even LDL with no other risk factor from 130, it goes to 55 within 3 months.
Correct. Thank you. Thank you.
Thank you.
Thank you, Noshi, for joining and giving us the important.
Thank you very much, Dr. Ashish,
enlightening the topic of cholesterol
for this excellent and conference. And I am very happy to be with you.
Thank you, dear friends.
Thank you.
We will be joining soon with you next your conference. Best of luck for your conference.
Thank you.
We have now Professor A.K. Das sir, that he will be blessing us with his very excellent topic. Over to you, Kanan.
It's a great pleasure and honor to introduce our esteemed professor, our teacher, and also our mentor, Professor A.K. Das, going to talk on the importance of biomarkers in diabetes, a keynote lecture. For that, we having 2 chairpersons. I think we have chairperson has logged in, Ashish. Yeah, I introduce. Yes, my chairpersons, Dr. Meena Madam is there. Meena Madam is MBBS, MD, Internal Medicine. She's a senior visiting consultant and diabetologist at Sir Gangaram Hospital, New Delhi. Over to you, Madam. And Suhas also there. Suhas from Pune, Kanan. Yeah. Yes,
sir. I'm there, sir.
Yeah, sure. I'm sorry, sir. I'm sorry.
Suhas, sir, I'm there. Yeah.
Suhas is a collaborator in many projects. Yeah, he's a pure municipal corporation. Welcome, sir. Welcome, sir. Over to respected chairperson. The King of Pune. King of Pune. Yes, sir. Yes, sir. Welcome, sir. Welcome, sir.
Sir, you are gracious.
Thank you. We need blessings, sir. Yes, sir. Thanks, sir. Thank you. So do we start with your, or you want to give some introduction, sir? Meena? Meena, madam? Dr. Sodas, you can introduce, sir.
Oh, yeah, please.
Yeah.
Absolutely, Ashish, it's absolutely a great pleasure that you have incorporated me in this conference, going on very smoothly and excellent. And it's a great honor to introduce Professor Ashok Das, who is a teacher and highly revered person in the field of diabetes and endocrinology, not only in our country, but across the globe. And he is an MD, PhD, various other degrees. He is a consultant physician, endocrinologist, Pondicherry Institute of Medical Sciences, New Medical Center, Pondicherry. He is a patron of the Research Society for Study of Diabetes in India. He is a co-chair of the famous ICMR INDIAB study, which is ongoing, a very extensive diabetes study in our country. He's a chair of the diabetes in the Young Registry, former national president of both RSHDI as well as API, the premier bodies for us, former dean of Indian College of Physicians, the ICP, and former professor and head of the endocrinology department, JIPMER and PIMS, Puducherry. Over to you, Professor Das, sir.
Thank you very much. Can I have my slides? I have given my slides to be focused. Nilam, can I have my slides now?
Ria?
Nilam?
Yeah, Ria is there, sir. Ria?
Yes.
Yes.
Yes, sir. I'll share it.
Dear friends, I'm extremely thankful for all of you for having gone with me, because I could not present at 5:30 because of something very, very pressing. I am not able to describe to you, so I could not join. I requested Ashish to join a little later, and I was told by my colleagues that it was followed by Dr. Rajiv's talk, and it was good. So let me, without taking any time, Chairman Sahab, Suhas, I'll start the topic right away. Now, it's a relatively new topic. And this is Ashish has given to highlight what are the latest advances in the biomarkers in the diabetes mellitus. Now, I have an agenda for this talk. We'll discuss regarding the importance of biomarker and what are the biomarkers associated with diabetic nephropathy pathogenesis, biomarker in type 1 diabetes, biomarker in diabetes which are related to cognitive dysfunction, like memory, like perception, things like that, cognitive. Characteristics of the biomarkers, clinical studies, and summary. Dear friends, before I proceed further, I must tell you that biomarkers, for that matter, know the things from some markers is the order of the day, and we call it the most important contemporary issue that is confronting us. How do you diagnose disease or diagnose measurements, diagnose complications before they set in? Is there any markers for that? And biomarkers have become absolutely important today in the management of many diseases, including diabetes. I have two confessions to make. Number one, we do not have many biomarkers for that matter. But whatever biomarkers we have, we may not be, especially me. Dr. Meena must be using plenty, Suhas must be using plenty, and Kanan and Ashish, but we do not use it very, very efficiently. Hence my talk to highlight the contents that I showed here. Dear friends, what is the application and importance of biomarkers? Number one, the biomarkers by rule are sensitive. They can tell you whether glucose control is there or not there. It is a measurement marker. They are predictive. They can also say the coming things cast their shadow. Supposing you have a pregnant mother whose GDM is whose H1C is almost 24, 25, and we have seen that they will predict the child is going to deform. And there is a management guideline for that. Meena, am I correct? Therefore, it is not only sensitive, it is predictive, it is robust. They have to be robust, they have to be stable. Number two, preferably we need biomarkers which are non-invasive. They are non-invasive. Number two, and they can be preclinical importance. Like I said, the coming things cast their shadow. If before the complication comes, they give their shadow, yes, complication is coming. That is the biomarker's function. And also clinical importance. And this is specific, as much as possible, be specific for the condition they are preempting. Number two, they help in easy detection of cases under complication. Here, the point in focus is diabetes, assessment of acute and chronic conditions, and they also stratify the risk, and they help in selecting the therapy and observation of disease progression. I'll give you 2-3 examples here to make it very clear, then we'll go slowly. Then we'll go very fast to finish it in time. Now, I have got 20 minutes. I will not take full 20 minutes. I'll finish in 18 minutes. I must tell you that if you have a person, I just give a very, very raw example, person who has got acanthus nigricans, who is obese, you know what therapy to give. It is metformin, pioglitazone. I've given a simple example. So it helps in therapy. Now, pre-diabetes and type 2 diabetes, there are some reference values for the diagnosis. Like we know for the pre-diabetes, we have the fasting plasma glucose between 100 to 125, and WHO said 110 to 125. and no H1C 5.7 to 6.4, and 2 hour between 140 to 199. I'll tell you how biomarker works. If a person has got fasting plasma glucose 122, 120, it is a marker that this person is going to develop IFG, impaired fasting glucose. If the numbers are closer to 200, not yet 200, remains at 189, 190, it is a marker for prediabetes. Therefore, the markers are not the disease yet manifest, Professor Suhas, but they say the disease is going to come. Similarly, we have also observed in our studies, in the I7 India study, other studies, if you have a high level of triglyceride, you have a high level of LDL, there is a marker that the diabetes may be coming in. Am I clear? Am I clear? So these are the things we have seen in clinical practice. Person having a very high LDL level can be primary, but can it be also most often because of diabetes, which is going to come. Next. Now, what are the established biomarkers of diabetes diagnosis and glycemic control? These two well known to all of you. The established biomarkers of glycemic diagnosis and control are, number one, that they all protein glycation factors. HbA1c, glycated albumin, we do not use it very often today, but serum fructosamine is again coming back because some companies introduced for the GDM and for the pregnancy diabetes, fructosamine assay, which are full fruit and is being used, giving 15 days control. But there are some advanced things which are used for research, like the skin collagen fluorescence and the advanced glycation end products, which are also markers of diagnosis. There is fractional excretion of the glycation-free radicals is also a marker, and the glycation oxidation and nitration-free abducts and anti-CCP antibody is also taken as a marker. Now, the plasma proteins CML, CMA, 3-DGH, and DT are also taken as the marker. So these are the investigational biomarkers, except the top three I said, other biomarkers. This is also well established today in the literature. These three markers are in the development for the diagnosis and for the risk prediction. Next slide. Next slide, Ria. Now, what are the biomarkers of glycation in clinical use? A1C gold standard, I will not go further. Glycated albumin is also important because when the A1C is compromised because of anemia, because of thalassemia, because of abnormal protein, because of any conditions, glycated albumin provides us medium-term glycemic control. It is coming in a great way, and we'll be going to use it in the conditions where the H1C is going to be fallacious. I give two examples: very low serum blood hemoglobin or abnormal hemoglobin. Serum fructosamine, also marker of the 2 weeks of glycemic control, easily implemented and correlates with the A1C. Now, the AGEs can provide risk prediction of diabetic vascular complication. If somebody has advanced glycation end products manifested as such, or by the collagen fluorescence, then one can see that it is going to be a marker of diabetes complication. And fractional excretion of glycation-free radicals or glycation-free molecules is a marker of diabetic kidney disease. The glycation oxidation and nitration-free redox are also for the diagnosis of not only arthritis, but arthritis in diabetes. We know that anti-CCP antibody, we always looked at, there is a marker of joint disease, arthritis. Plasma protein CML, CMA, 3DG are not related to diabetes. They're markers of the autism. Next slide. You can go a little fast. Now, glycated proteins and fructosamine correlate to hyperglycemia. The cartoon shows how they are related, how they are formed. I will not go details of it. Next slide. But please remember that glycated proteins and fructosamine are correlated to hyperglycemia. And the cartoon shows that how they get linked to the glucose and produce the glycated protein and fructosamine. Next slide. Now, if you look at a person having impaired energy metabolism, low energy metabolism, and biomarkers, what are the things you should look for? The number one marker for impaired energy metabolism is the increase in the branch chain amino acids, BCAA, and also increase in the mTOR activation. There can be lowering of the insulin receptors and increase in the insulin resistance. Now, if you have a person who has got genetic predisposition to impaired energy metabolism, you will find that whatever nutrition is taking, there's a nutrition excess. So therefore, it has been said that impaired energy metabolism and biomarkers for type 2 diabetes resides in the BCAA, mTOR activation, lowering of the insulin receptor count and increasing the resistance, and of the nutrient excess. Next. Next, please. Now, there are 3 clinically validated biomarkers. You know about it. Maybe that 1,5-anhydroglucitol is not very much used by everybody. And you know, the fructosamine requires about 1 to 2 weeks. Glycated albumin also requires 1 to 2 weeks. But very soon you can get the result from the 1,5-anhydroglucitol. It's a good biomarker. Length of the glycemic observation, fructosamine is 2 weeks. For the glycated albumin, 2 weeks. And 1,5-anhydroglucose also for 2 weeks. But we get result very fast. And it reflects the level of the fasting glucose, postprandial glucose, and coronary diabetic complications. And the determination by enzymatic method is available that makes it cheaper and easier. And optimal detection range also has been worked out. Next slide. And point of care testing also available. Point of care testing is available. Now, if you look at the diagnostic performance of this test of the 1,5-AG or the fructosamine or the other things, you will find that the sensitivity and specificity varies between 78% to about 83 or 84%. That means they're good tests, but they has not been fully utilized. Now, I'll give an example. Glycated albumin is a very important test if you want to use it in diabetes, but it is not yet thoroughly investigated how to use it. In contradistinction, glycated hemoglobin has been used enough. Glucose tolerance has been used absolutely fabulously. Next slide. Now, next we'll discuss what are the biomarkers. But I discussed about the diagnosis and the management issue. Now, how are the biomarkers associated with the diabetic nephropathy pathogenesis? Next slide. Now, the pathogen nephropathy, next slide, please. The nephropathy markers associated with diabetic nephropathy pathogenesis are the markers of oxidative stress, inflammation, and the RAS activation. Like oxidative stress, we have the various parameters like the DNA injury, protein injury, lipid injury, and finding of the pentosidine, AOPP, GST, DNPH, etc. For the inflammation, we have all the inflammation markers like the IL-8, TNF-alpha, IL-6, and many others which you do not use. I will not go into that. And for the RAS activation, we have the level of the angiotensinogen. We do not use it in the clinical practice, but Zhang, in one of the reviews in 2018, have described that these are the biomarkers which can be used for the diabetic nephropathy. Next. Now, biomarkers which are associated with diabetic nephropathy pathology how they manifest it. If there's a podocyte injury, one can get prodosin or synaptopodin, which is not used in our country, but used for research purposes elsewhere. Podocyte injury also can produce nephrin. If there is basement membrane injury, one can type for collagen, and endothelial cell injury can give rise to von Willebrand factor. Endothelial cell injury can give the VEGF. VEGF is used very, very routinely. And mesangial expansion fibrosis can be manifested by TGF beta 1. And mesangial expansion fibrosis also can be known from the PEDF. So, dear friends, what I want to impress on you by this small talk today, that biomarkers are going to come in a big way. We do not look at the podocyte injury unless you do a biopsy. But from these features I described, podosin, synaptopodin, nephrin, one can get some idea about the podocyte injury. One can get from the type for collagen in the blood, basement membrane injury, von Willebrand factor, endothelial cells injury, VEGF, etc. So what I mean to say that there are some ways of getting this, the things coming or not coming from the biomarker. You can get some idea from these biomarkers. Next slide. Now, what are the biomarkers associated with the renal function change? I'll give you two examples. Now, so much is glomerular dysfunction. You find changes in the TRF, CR, and IgG. Now, if there is a renal tubular dysfunction, you find alpha-1 microglobulin. Renal tubular dysfunction, you find change in the RBP. And today we use lot test with the NAGAL, NGAL, and NAG, and they produce renal tubular dysfunction. So all that I mean to say, today one can find out glomerular dysfunction and tubular dysfunction from the biomarkers. Next. Now, there are some novel biomarkers for the diabetic nephropathy, which are using more and more. One is urinary transferrin. Glomerular injury, it dictates. Urinary TNF-alpha, again glomerular injury. Glomerular tubular engine together is urinary type 4 collagen. Urinary fibronectin for the glomerular injury. And urinary NAG for tubular injury. So these are used in our, of course, in the clinical practice also elsewhere, may not be as much in our country. Next. Now, coming to the biomarkers in type 1 diabetes, we have discussed about type 2 diabetes and nephropathy. Let us see type 1 diabetes. Next slide, please. Now, we have the genetic markers for type 1 diabetes like HLA-DR, HLA-DQ. We have the T cell biomarker like the cell count of the CD4 and CD8. We have the autoantibody biomarkers like GAD65, insulin autoantibody IA2, ICA512, etc., etc. We have beta cell dysfunction biomarkers like DNA markers, messenger RNA markers, and the protein markers. So type 1 diabetes is a disease which is an immunogenetic disease. So you can have biomarkers in the genetics where you find the HLA. You can find the markers in the immunology, as I have described the GAD antibody to the seroantibodies or the cellular antibodies. Next. Now, can we predict type 1 diabetes by using serum biomarkers? Now, it is a very difficult game and very dangerous game, but people have tried in the newborn. Those who have history of type 1 diabetes, they look at the genetic testing. If they have a family history positive, they have a HLA-DR-DQ genotype, and they have other minor genes like transporter, gene transporter, etc. They give a weighted risk score, not final, but weighted risk score. And this risk score can say high risk, like more than 5%, moderate risk, 1 to 5%, low risk, less than 1%. Now, why this is done out? Because there are drugs today which can be tried in these people to prevent the disease by giving immune prevention trials against the autoantigens. Like we have GAD vaccine. GAD vaccine can be given in the potato, and that potato can be fed to the child. We have the viruses which can produce, like autoantigen, they can produce the type 1 diabetes. So we have got vaccines in the prevention trial, like the diet containing vaccine, and the virus vaccines are also available. So the type 1 diabetes prediction is possible by the genetics makeup and the autoantibodies, and intervention is available. Next slide. Next slide, please. Now there are a lot of prediction in the autoantibody and the type 1 diabetes prediction, like the more than one antibody, that is 2 or 3 autoantibody, the phenotypic antibody, and looking at the genetic makeup, one can predict. So this is one of the things that is getting ground, that type 1 diabetes can be predicted, and by giving trial of modifying the autoantibody mediated injury by like giving steroids to prevent immune destruction, or to giving cyclosporine. There are so many studies available, cyclosporine, pericyclosporine study, and etc., which can prevent type 1 diabetes for certain extent. And the insulin requirement also can come down in type 1 diabetics. Next. The fourth one I want to discuss is about the markers for the diabetes-led cognitive dysfunction. I will be very vocal this time to say that many of the diabetics develop dementia. So much so that diabetes has been termed as a Alzheimer type 3. So therefore, do we have any marker that who is going to develop this cognitive dysfunction? I will again hasten to add the data is not 100% foolproof, but what has been shown, I'm showing before you. Next slide. It has been shown that, next slide, please. There are some markers. Please change the slide. That, there are some things which are pointers to the impairment of cognition and dementia. Like somebody has got hypertension untreated, dyslipidemia untreated, CVD, PAD, and coronary artery disease, all arterial disease. He is possibly going to develop dementia if he has got genetic predisposition like ApoE4, HP11 genotype, or raised glyceriin genotype. This is a special genotype he will develop. Now, there are some diabetes-related changes like lot of GV, glycemic variability, hypoglycemia, hyperglycemia, hyperinsulinemia, retinopathy, nephropathy, long duration diabetes can develop cognitive impairment. Now, it can also, can I go back? Okay. Can you go back previous slide? It can also, if you have risk factors like old age, education level, depression, physical activity, smoking, family history, can produce cerebral structural and functional changes. So all that I mean to say, from these things, one can imagine that there are some factors which are amenable to treatment, like hypertension, like controlled diabetes. So therefore, it has been said that if somebody has diabetes, you are 10 years to his chronological age. Even if he's 80, he is diabetologically speaking, is 90 years of age. So if you have controlled diabetes, you don't have to add this 10. So therefore, it has been shown that hyperglycemia can give rise to glucose neurotoxicity, advanced glycogen end products. Insulin dysregulation can give rise to ID reduction, impaired insulin signaling, and they can ultimately give rise to the cerebral dysfunction. Next, and cognitive dysfunction. Next slide. Now, there are so many biomarkers which are not very much in the realm of clinical practice, like plasma CRP oblique IL-6 oblique TNF-alpha. There's acute phase protein, and it indicates subclinical inflammation in the brain and can produce cognitive dysfunction. Beta amyloid phosphorylated protein called phosphorylated tau. Beta amyloid deposition is the hallmark of the Alzheimer's disease. So this amyloid is a biomarker. P13K, BDNF, advanced glycogen products. So these are the markers that one may develop some neurocognitive dysfunction. Next slide. Next slide. We can go to next slide. Now, what are the characteristics of the biomarker? It's very interesting. Next slide. Please go put the next slide. Now, the characteristic of biomarkers are there for the prediabetes, diabetes, as well as complications. Say HbA1c. It is sensitive and specific. Advantages that it can give you the complication profile if it is related to diabetes control. Disadvantage, you cannot use it for day-to-day diabetes management. You can use it only for long term. And is a reflection of chronic glycemia, at least of few months, few years duration. So like that, for every biomarker has to be worked out for the characteristics, for the prediabetes, diabetes, and each complication, which is a terrible work to be done. The work is going on. We do not have the full data today. Next slide. Next slide. So the second one is fatty acid. Is a ketonoamine created by the glycosyl total serum proteins, primarily albumin. So this shows the various types of the FA. How does it function as a biomarker in the conditions? Third, I'll show a few of the things we worked out. Third one, next one. Next. Now, the glycosylated albumin also has been worked out, and its position as a biomarker has been more or less clear. So I'm just giving you that HbA1c, FA, glycated albumin, they're all worked out, and the position as a biomarker has been established. Next. Then we have the biomarker in the OGTT. I told about to 1,5 aldolase glucosidol. So these are the thing biomarkers which have been worked out. Next. Adiponectin. Adiponectin is also taken today as an independent predictor of diabetes because it is associated with dysglycemia, complications, and also fragments of obesity. Phetuin A is a protein, is a hepatic secretory glycoprotein that has been proposed to promote lipid-induced insulin resistance and diabetes. Alpha HB is an organic acid byproduct produced during the synthesis of the alpha kappa beta, a product of amino acid catabolism, and it produces cysteine in the hepatic tissue and can produce what is quote unquote hypertension diabetes. Next. Like LGPC, LP little a. LP little a is done. LP little a is a lipoprotein subclass that contributes to atherogenesis. So it has been taken as a predictor of the pre-diabetes, type 2 diabetes, and also its complications. Triglyceride, I saw some time back, it is the esters derived from the glycerol and free fatty acids. They are associated with beta cell dysfunction, reduced insulin secretion. So they are a marker of pre-diabetes and diabetes. I spoke about the triglyceride and LDL being low, being high. Next. Similarly, for the HDL, ceramide, ferritin, transferrin, MBL associated serine proteases, they are undergoing investigation to find out what relation they have with diabetes and their complication. And the total workup is not yet complete. Next. THBS1 directs formation of multi-protein complexes. GPLDI is a postulated role in the insulin mimetic signaling pathway. So they are undergoing investigation. The final word is not yet known. Next. Next. Can you change? So I will not go details of it. The ACL carnitine, this has been taken as a marker for ketoacidosis. mRNA there are specific mRNAs like 192, 193B, 15A, protein 2. They are all associated with diabetic complications, but the final word is not known. As I told you that many of the things of the biomarkers are not yet clear. Next. Yeah, I don't go details of it, but I can tell you that the ordinary CRP, IL-6, even the WBC count, even the lymphocyte count has been shown to be a marker of diabetes. I think you must have heard about it. Lymphocyte count, and they are the markers of they are the markers of worsening insulin action and worsening secretory function. Next. Fibrinogen, PI1, IL-18, IL-IRA, they're all undergoing investigation as markers of the coagulation and markers of the diabetes complications. I mean, it's associated with dysglycemia and the complications being investigated. Next slide. Next. Galectin is also one of the markers which is being studied. Now, galectin has three functions. That is cell adhesion regulation, advanced glycation end product receptor, and immune and inflammatory regulation. And today, galectin-3 is being used as a marker for the diabetes mellitus because it can detect the pre-mRNA splicing activity, cell cycle regulation. It is also anti-apoptotic. I mean, the cell death it prevents. So it is also undergoing evaluation as a big marker. Next. So the pre-diabetes biomarker, a study performed in the first relatives of subtype 2 diabetes mellitus. Galectin-3 is correlated with the increased waist circumference. It related to visceral obesity, H1C, high glucose high, and high sensitivity C-reactive protein, and can be used as a predictor of diabetes. Next. There's one called ophthalmate, methionine, homocysteine. I will not detailedly describe each one of them at this time of the evening, but they are all used. Just remember the name, the ophthalmate also is one of the issues which is being looked into. Next. We can go to the last part of the presentation. Phetuin, next. Next. Phytoin A is the one which is derived from the adipose tissue and the liver. They have activity in the insulin receptor, and there are few Indian investigators are investigating phytoin A in type 2 diabetes, and they are showing it as a marker of insulin resistance, and it holds promise as a marker. Next. 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 Coming to the last two slides, clinical studies. Next slide. Clinical renal markers characteristics in the ACCORD study, the ACCORD nested case control, a nephron D full sample cohort has been worked out. And there are some, as I told you, some markers of the various types of kidney injury has been correlated with the biomarkers. That's the final thing today. Next slide. And the nested case control study of about 200 cases of incident DKD, and again, same number of matched controls, a prospective cohort study, and they're looking into the association and discrimination values of these biomarkers and of the TNF, TNFR1, TNFR2, kidney injury molecule, and the outcome of the incident diabetic kidney disease and the progression to full-blown DKD. Next. You can go to the last slide now. Last slide. I will not go details of this because these things are not yet worked out. Next. No, put the last slide on, please. So high incidence diabetes is also accompanied by an estimated underdiagnosis in about 50%. We know diabetes we can diagnose only in 50%. 50% they remain undiagnosed. You know, for every diagnosed diabetic, there's an undiagnosed one. If you have successful biomarkers and cost-effective strategies for systematic screening of type of diabetes, mellitus, and these biomarkers are proven value, we can ensure early detection. And you know, the complication of diabetes ultimately the duration and the hyperglycemia. So we can lower the patient risk of developing life-threatening disease complications. Therefore, identifying new biomarkers and assay methods for diabetes mellitus to develop robust, non-invasive, painless, highly sensitive, and precise screening techniques is essential. So it is undergoing trial. The beauty of these markers that if they can diagnose diabetes before we get hyperglycemia, they can predict diabetes. Combining several biomarkers, not individual ones, may more precisely identify those at high risk for developing prediabetes and subsequent progression to diabetes. Thank you very much. As I told in the beginning, it's a very interesting subject. It's in its infancy. I've tried to give you what is the latest literature and just to show the way that the biomarkers cast this shadow of the things to come, and they can be utilized for diabetes and for diabetes complication diagnosis, screening, and predicting. Thank you very much for a patient hearing.
Thank you. Thanks a lot, sir, for giving the insight on the biomarkers of diabetes. And it is a keynote lecture, really. And thank you for giving us the blessings. And Kanan, are there any questions for Suhas, sir?
No question in the chat box. It was an excellent talk, sir. We enjoyed wonderful.
Ashish, I believe sir has talked on such a topic which is actually an option topic, honestly speaking, for the clinicians. Number two, lot of slides are absolutely tangential. Okay, so I am very skeptical whether anybody will have really a question in mind.
No questions at all.
Probably they will need longer teaching from sir so that they can be in a position to ask questions.
We learned a lot, sir. We learned a lot.
Absolutely, sir. Absolutely.
The thing that I wanted to impress why this topic is being discussed is the fact that we must try to find out whether we can diagnose before prediabetes. Yes, because you know that is the only way to diagnose the undiagnosed one and to minimize the complications. Number two, diabetes is a sweet disease with sour company. The sour company are the complications. And for every complication, there's a point of return, point of no return. Point of return is microalbuminuria. Point of return is the fluorescein angiography leak. Point of return is the systolic dysfunction. So if you have biomarkers to identify them and give adequate control, we cannot concentrate on every diabetic. If we know by biomarkers that this person is likely to go into complications, we can concentrate there. These are the benefits of biomarker, apart from the research tools. And the biomarkers of diabetes are also related to biomarkers of the obesity. Because diabetes is the in thing today. So that's why it is interesting.
Yes, sir. Thank you so much, sir. Thank you.
Thank you.
We are really enlightened, sir.
Yeah. Thank you for your blessings and support, sir. And sir is always with us for NDID conference since many years.
Thank you.
Thanks a lot for giving the closing. You are closing batsman today, and you have made one NDID through 9 wickets and 100 runs.
Thank you.
So over to you, Kanan.
Nothing to add more, sir. It is a real, celebration of science. The real celebration of science by our old teacher.
Nebulization करायचं असेल तर या.
Excellent teaching, sir. We enjoy the talk, sir. Thank you, sir.
Yeah. So we have finished, Kanan, all the talks.
There is only one talk remaining by Professor Makka.
He was not able to join tonight. He was in flight.
Almost other topics have been covered.
Thanks a lot, Suhas sir, again blessing us, and Noshi, and above all our master of ceremony Kanan, who has made the show very wonderful, ran the show wonderful since morning.
Thank you. Thank you, Vashi, for the opportunity given to me. Thank you.
And he's now Mita Bachchan of digital world. So thanks a lot from bottom of my heart to the RX team and all the dignitaries and the delegates who are with us since afternoon. And thanks a lot to our respected A.K. Das sir, Bansi sir, and Shashank Joshi sir, who are with us always as a program committee coordinators. And Das sir always bless us and they teach us many new things, and because of you, elegant teachers, we are doing these programs regularly because we are clinicians and academicians because of your guidance, sir. And thanks a lot to our international speakers, Noshi, Navi, Kampeli, and Iriana, Martha, and Tanya from Bangladesh. All of you have enlightened us with your talks, and above all the national speakers who are wonderful from our city and our India. They have enlightened us with the many new topics because our conference is New Dimensions in Diabetes. Supratik is taking on hemoglobin, Rajiv is taking on the tech-savvy diabetes clinic. So many new different topics have been discussed throughout the day. And Bansi sir has again given the paradigm shift. And Shashank sir has joined with the new topic of twin hypothesis and technology he has added, because nowadays technology is very important, is taking part in the management of diabetes, because even the village people are using technology. So we are thankful to Rakesh Sai sir, Sanjay Agarwal sir, and all our colleagues like Purvi. So I thanks a lot from bottom of my heart, and above all to Kanan. I am thankful to you from bottom of my heart, dear. And
thank you, dear.
The RX team who has done the wonderful job. So
thank you, sir.
Our Bhardwaj sir is with us. He is always patron, and he has always helped us to run away the academic shows in the Jabalpur. Bhardwaj sir, any few words?
No, it has been an excellent conference, a nice choice of speakers and topics. Keep it up. You are the shining star of diabetology in Jabalpur. And keep it up.
Thanks a lot, sir, for your blessings. Thank you. Over to you, Kanan.
Nothing to add more. I think you have completed everything in one single word. It's a real celebration of science today. We enjoyed a lot. We have excellent topics, excellent galaxy of speakers, stalwarts, our teachers, our mentors. All the topics are so exclusive, and it's one of the pathway for the knowledge sharing here also, and enjoyed excellent cuts of all the messages right from all the stalwarts. Thank you for the wonderful opportunity given to me, my dear Ashish. Thank you.
Thank you, Karan. We'll meet soon.
Yeah.
Everybody, we will meet soon physically. Thank you. Thanks a lot. Jai Hind.
Jai Hind.
Jai Hind.